and needs to be discussed with the patient and the caregivers before we embark on such treatment. Notably, slightly more than 2% of the patients in either arm was treated with definitive chemoradiotherapy without any kind of surgery. So let us have a look at the surgical outcomes. R0 resection, the rates were higher in the experimental arm, 89% in contrast to 84.7% in the standard arm. And R1 and R2 resections, as obvious, were more common in the standard arm. So if we focus on the postoperative histopathological risk stratification, we can see that 32.5% in the pembro arm and 44% in the standard arm had presence of high-risk features, which we have already alluded to before. So this is the postoperative therapy exposure. The median number of cycles of pembro administered was 15 as per plan. And interestingly, the dose of postoperative radiation therapy was 60 Gray in the experimental arm, in contrast to 66 Gray in the standard arm, which is basically because of presence of high-risk pathological features in a greater proportion of patients in the standard arm. Also, it's important to note that more number of patients received cisplatin in the standard arm, 139 versus 107. So this is the table depicting radiotherapy exposure, but by pathological risk stratification. So the median dose of postoperative radiation was 60 Grays in the low-risk stratum and 66 Grays in high-risk stratum as expected. So these are exploratory analyses of the event-free survival in the low-risk population and the high-risk population. And we can see the outcomes, they favor the experimental arm. However, the hazard ratio was 0.74 and 0.73 respectively, suggesting a 26% and a 27% reduction in the hazard event in the low-risk and the high-risk arm subsequently. However, these were exploratory analyses and the 95% confidence limit of this hazard ratio were crossing unity, which we need to keep in mind. Again, a tabular representation of the toxicities. There was no new safety signal emerging out of this trial. However, all-cause adverse events and treatment-related adverse events in excess of grade 3, they were more common in the experimental arm, particularly in the low-risk stratum. So in conclusion, event-free survival results favor the use of perioperative pembrolizumab across postoperative histopathological risk stratum. And this was consistent with the primary analysis of the trial, which already has been published last year. So neoadjuvant pembrolizumab led to pathological downsizing and downstaging of the tumor, leading to fewer participants having high-risk features, which engendered lower use of high-dose postoperative radiation therapy and cisplatin. There was no new safety signal, as already discussed, and the authors concluded that neoadjuvant pembrolizumab surgery and pathology-directed postoperative radiation therapy with or without cisplatin and adjuvant pembrolizumab is a new standard of care for eligible patients with resectable, locally advanced head and neck squamous cell carcinoma. With this, I'd like to thank you very much for your kind attention.
Thank you, Doctor. I think Dr. Bharat will resume his talk. Dr. Bharat Dua.
So good morning, everyone, again. Yeah, that's the correct one. So good morning, everyone. I'll be presenting the phase 4 analysis of the DART HPV trial. So since this was a phase 4 analysis and we weren't allowed to modify our presentation, this particular presentation does not explicitly explain the methodology of the trial, and I'll be discussing that briefly. So this was a phase 4 analysis of the de-escalated adjuvant radiation therapy trial for HPV positive oropharyngeal cancer. This was a pooled analysis of the phase 2 component, that was MC1273, the phase 3 component, that was MC1675, and certain patients that were treated off study protocol. So originally presented by Cecilia Hidalgo from the Mayo Clinic, and just like her, I have no financial disclosures. So let's start with the background. I'll need to discuss the methodology of the trial. So this was a post-op trial. That's the first thing that we need to understand. This was done in AJCC 7th edition stage 3 to 4 oropharyngeal cancer patients. So post-TORS or TLM, the patients were randomized to a standard of care arm, which was chemo and radiation plus minus chemo, or to a de-escalated adjuvant radiation arm, which was 30 to 36 gray of radiation, delivered 1.5 to 1.8 BID along with concomitant IV docetaxel. So the phase 2 component, the MC1273 trial, focused on the outcomes, showed relatively promising outcomes. The phase 3 component, that was MC1675, focused on toxicity and demonstrated an improvement in toxicity with a query survival signal detriment for ENE positive PN2 disease. But please note this was as per the AJCC 8th edition, and we'll be discussing this in the future slides. Now, at the Mayo Clinic, DART has been adopted as a standard of care prior to their ongoing follow-up study, which is DART2. But why shouldn't this be adopted in the community is something that we'll hopefully discuss in the presentation and in the subsequent panel discussion. So the objectives of the phase 4 analysis were to characterize the patients treated off study protocol and to understand if the cancer control rates were similar between the on and off study patients, and to determine the overall effectiveness of DART in this large cohort. As you can see, this included both the phase 2, phase 3 and the phase 4 components. The DART regimen, which I've already discussed, is mentioned at the bottom of the slide. This was 30 to 36 gray of radiation at 1.5 to 1.8 gray per fractions BID into 2 weeks, along with concomitant IV docetaxel at 15 milligram per meter square on day 1, day 8. Please note that the doses were decided according to intermediate or high risk factors post-operatively. The intermediate risk factors were T3 disease, N2 disease, PNI or LVI, and high risk factors were ENE. Patients with intermediate risk factors received 30 grays of radiation, and patients with high risk factors, that is ENE, received 36 gray. And concomitantly, in the standard of care arm, patients with intermediate risk factors received 60 grays of radiation only, whereas patients with high risk receive concomitant chemotherapy as well. So let's discuss the methodology. This was a phase 4 analysis. The study interval was from 2013 to 2023. This is when the patients were accrued. The exclusion criteria are the same as in the phase 2 and phase 3 trials. That is a history of prior head and neck cancer, pathological T0 or T4 disease, patients receiving induction chemo, and unknown HPV status. And we know that this was basically a comparison of on and off study patient characteristics. And the endpoints that were analyzed were LRPFS, DMFS, PFS, DSS, and OS. So this is the consort statement, and what is important in this slide is just a comparison of the characteristics of the patients that were treated on and off study. What is important to note is there was a slightly less amount of PN2 patients in the off study protocol, and this was based on the results of the phase 3 trials, which showed a tendency of survival detriment in the PN2 patients. The survival outcomes for the overall cohort were generally good. The 2 and 5 year overall survival and survival endpoints for all parameters were generally around the 90 to 95% mark. And if you look at the bottom table, this compared the outcomes in the on-study and off-study patients. As you can see, there was no survival difference, as is evidenced by the p-values on the bottom right corner. So if you look at the overall cohort, generally good results. At 5 years, the progression-free survival was around 80%. And if you look at the on and off study patients, the p-value is 0.26, which means there were no major differences in survival parameters between the on and off study patients. And coming to the important part of this analysis, if you look at the PFS by ENE, naturally the ENE positive patients would have an inferior PFS, as would the PN2 patients, which is on the right side of the curve. But what really came out of this analysis was if you combine the N2 patients along with ENE positive patients, these patients have a particularly poor survival with de-escalated adjuvant radiation therapy, and the p-value was highly significant at 0.0001. So the key points that came out of this analysis were that the patient characteristics of study were largely similar except for fewer N2 patients. Given the phase 3 results, 2-year oncological outcomes were generally very good. And then the patients were reassessed as per the AJCC 8th edition, and it was found that patients with intermediate risk disease as per AJCC 8, which was defined as PT13PN1, had a generally excellent 2 and 5 year PFS. These were keeping in line with large phase 2 and phase 3 trials. Certain limitations of the phase 3 trials and the phase 4 analysis. This was done at a tertiary care center, that is the Mayo Clinic. The extent of ENE was not quantified, which we know is now emerging as an important criterion in HPV positive head and neck cancer. And a very sort of non-standard fractionation was used, the biological impact of which is not very well known. So if you look at the conclusions of the phase 4 analysis, patients generally treated with de-escalated adjuvant radiation therapy, both on and off study, had generally excellent outcomes and has shown decreased toxicity compared to the standard of care. And at least at the Mayo Clinic, for patients ages CC8, PET13N1 without ENE, DART represents a standard of care. For patients with ENE, they say that we need further selection criteria for selecting these patients for de-escalation. Thank you.
May I now invite our moderator, Dr. Sarbani Ghosh ma'am, Professor Radiation Oncology, Tata Memorial Hospital, Mumbai, along with all the esteemed panelists to the stage.
Good morning, everybody, and I must begin by thanking Kanika for this kind invitation. I have very esteemed panelists on the panel. Though the panel is short, I just request everybody to pitch in and take questions. I'm not going to be calling out by name except for perhaps the first two, because it calls upon experience with protons as well as particle therapy. So let's get started. I don't have any medical oncologists. There was supposed to be the last four, I think, are three are medical oncologists, but I don't think anybody's here. But I'm sure the radiation oncologists can take those questions. Yeah. Thank you. Pardon? Oh, what I did. No, so I have the panelists here. I've got Sapna, I've got Ahitagni, I've got Mansi, I've got Roshni, I've got Bharat, I've got Preeti. I don't have Ranjit, Shuab, Nikhil, Anshul. That's okay. We'll manage. Okay, so we know that in head and neck cancers, mostly we look at different parameters before we choose the modality for treatment. And as in other cancers, in head and neck cancers also, it's important that we keep the endpoint of interest in mind. And this is especially important when we look at the photon and photon versus proton, or the proton versus particle therapy trials, because the endpoints of interest are important. And even for the de-escalation studies, this is important. So we have to keep in mind not only the good disease control, but also preservation of organ and function. So my first question, of course, set of questions alludes to the two trials that we had on discussion. One was the torpedo, and the other one was the trial of particle therapy versus IMPT and IMRT in nasopharyngeal cancers. So we'll just quickly go. So this was a phase 3 study, and it actually took all cases, and as Sapna correctly pointed out, most of them were early stage cancers, and a large majority of them were P16 associated, were HPV associated cancers, and they looked at whether IMPT compared favorably with IMRT in reducing late toxicities. And this was, of course, 205 patients strong. And in conclusion, they said there was no benefit of IMPT compared with IMRT, and fully optimized IMRT outperforms prior late toxicity and quality of life data. Physicians and patients were assured of no requirement to access IMPT. This was the torpedo trial. And this is, I will come back to these two slides afterwards. And then we also had a presentation on the choice of whether we choose protons or photon radiotherapy for nasopharyngeal cancers, and combined with, of course, carbon ion radiotherapy. And they concluded by saying that proton radiotherapy reduced grade 2 or more xerostomia at 6 months compared to photon-based radiotherapy. And proton radiotherapy reduced weight loss, caused less weight loss during radiotherapy compared to photon. And IMRT with carbon ion radiotherapy, or IMRT with that is IMPT with CIRT or IMRT with CIRT, had comparable excellent survivals. And the phase 3 randomized data, of course, is necessary. So my question to Sapna, of course, she has the longest experience with the use of protons in India. So let's ask about, what do you think and how do you poise the data that torpedo has given us versus Just before that, we had data from Steve Frank from MD Anderson. So how do the two trials compare? And how do you look at these trials when you have to convince your patients to undergo IMPT versus IMRT? Of course, we don't have access to any form of other particle therapy like, any of the carbon ions or oxygen and neon and all that. But then how do you compare and how do you convince your patients about MD Anderson and the torpedo study?
Uh, so, I think a lot of emphasis has been on the fact that torpedo is being read as a negative trial. However, if we compare the MD Anderson study with the torpedo study, we see that in both these studies, actually the acute toxicity is similarly reduced. So it's a question of what you're really looking at. I do believe that both torpedo and the MD Anderson study reinforce the point that there's a 30% reduction in the grade 3 toxicity. Even in torpedo, that comes out in the paper, the grade 3 toxicity was 50% versus 72%. At the end of treatment, dysphagia was 12% versus 24%, and the tube insertion rate was 30% lower. So it's really a question of what you consider the relevant endpoint to be. I do believe that acute toxicity and survival, to my mind, would be the most important endpoints. Now, to come to the second part of your question, how is it relevant to us in India? Now, firstly, we must understand that both these studies looked at HPV positive patients, which is really not relevant for us. Torpedo particularly had almost 97% patients were HPV positive, and about 70% of them were stage 1 and 2 patients. In our experience, where we are dealing primarily with tobacco-induced malignancies, our own results, this is a propensity matched analysis, has shown a distinct survival advantage in addition to the toxicity reduction. And in fact, this has been accepted as an abstract in ASTRO, and we are going to be presenting it this year. So the survival advantage story is a little difficult in the background of radiosensitive tumors such as HPV positive. There are a number of other issues with this study, but then perhaps.
So Mansi, I'd ask you also, because we'll move gears from oropharyngeal cancers and other head and neck malignancies, but essentially oropharyngeal cancers to nasopharyngeal cancers. Why is the difference so obvious and so, actually, if you ask me, nasopharyngeal cancers, there's no contention. But why do you think that is the case?
So, ma'am, when we talk about the nasopharyngeal cancers, it is basically the location. So, the clivus, the brain, these are the two structures that became our dose-limiting structures. So, when we are using particle therapies, the maximum advantage where we can gain is due to the location of the tumors.
But Sapna, would you agree to that? Because if you had nasopharyngeal cancers that were really advanced if you ask me, I don't know whether we really gain that much of an advantage with doing IMPT, whereas whether we would gain that much of an advantage if we compared IMPT and a well-optimized IMRT plan. So what do you say, Sapna?
So I feel the advantages of IMPT really come in the background of the fact that a lot of these patients have received neoadjuvant chemotherapy, and therefore their mucosal sensitivity is, that much. They're being able to tolerate the remaining part of the treatment and effectively also undergo chemotherapy. And that is where the advantage of proton therapy comes in. The reduction in the oral cavity doses, where we know that that dose is related to the risk of requiring tube feeding, and the dose reduction in the midline mucosa. These are two important, I feel, considerations. And the other thing that we don't normally speak about, and we actually don't have evidence for cognitive advantage, in the sense that there are no studies where we say that, okay, there is a cognitive advantage to proton therapy, but whether it is a young patient or an elderly patient, the hippocampus and the temporal lobe are also important structures.
Would you lay any emphasis on, now supposing we were to accept the MD Anderson data, which shows that there is a marked difference between IMPT versus IMRT, and it is statistically significant. Supposing you were to choose this, and now every other patient who walked into your clinic said that I want IMPT, how would you then convince a patient? Would you then lay anything by the modeling studies of Netherlands, to kind of sell IMPT, or tell them, no, IMRT is good enough for you?
I have a difference of opinion with the Netherlands group because they don't consider oral mucosal doses at all. And I think in our experience, what has been the huge advantage of proton therapy has been the sparing of the mucosa. Even in nasopharyngeal cancer, just something that we learnt in practice was that if we were not paying attention to the dose that was exiting onto the palate, the patients were not getting the advantage that we wanted them to get. So we had to be very, very meticulous about sparing the palatal mucosa if we really wanted to get the benefit. So the real advantage of proton therapy, and I don't think it has been stressed enough, is in the reduction of mucosal toxicity.
Any comments from the audience or from the other panelists?
So just if we compare the US trial, sorry, with the UK trial pertaining to IMPT versus IMRT in oropharyngeal squamous cell carcinoma, it's important to bear in mind that there was a very high incidence of crossover in the US trial from MD Anderson Cancer Center, almost to the tune of 25%, 23% to be specific. So this kind of slightly impedes the meaningful interpretation of results. The Torpedo trial, on the other hand, it's a very clean trial. It has been conducted with a lot of rigor. And the US trial, which was basically a non-inferiority trial and focusing on 3-year PFS, there was no significant difference in the primary endpoint. But surprisingly, there was quite a huge difference, 9%.
So then I'd like to stop you here. What was the difference between the ASCO presentation and the final publication? Something that was not statistically significant turned to be significant in the publication, you see. So there was something that happened in between in the US trial, which is something that all of us, when we read the paper, so that's why my request is that all of you should definitely read the papers also, not just go by the presentations, so that you can actually, the MD Anderson's trial, how it actually evolved over all this time is an important consideration to keep in mind. So as Ahitagni was saying, I think the Torpedo, though I may not agree completely to the trial results of MD Anderson and Torpedo, because there is a definite difference when we give protons to our patients. There's a definite difference. We see it very obviously in patients. The patients who receive protons tend to do differently, but of course we choose our patients very carefully. That's a different thing altogether. So all those put things together, so what happened in between?
I think they stated that there was a higher incidence of post-progression deaths and toxic deaths in the IMRT arm compared to the IMPT arm, which was pulling the survival curves apart. So I think that is something which we should keep in mind.
Yeah, Bharat, you wanted to say something?
Yeah, I think the incidence of tube dependence in the trials is something that's not been talked about here. I mean, 40% tubing in IMRT arm for oropharyngeal cancer versus a 26% in the IMPT arm. I think the rates of tube dependent and versus something like 1.7% in the UK trial. I mean, there were clearly differences in how they were. There were some institutional differences in how they were using their PEG tubes, and that is something that needs to be talked about, I think.
Actually, if we see this is at 12 months, but if we see at the early time, it's actually 58 and 40.
Yes.
So 58 is the IMRT tube, any tube dependence in the IMRT arm in the photon arm in Torpedo. In fact, Torpedo is being criticized precisely for this reason. So you have two institutions which are delivering proton therapy, and you have 18 delivering photon therapy, and they may have completely different tube insertion policies. So you have inserted fewer tubes in the proton arm. Is this why you have more how do you explain the weight loss at 12 months
Absolutely.
in the absence of dysphagia and aspiration?
So brings us to a very important point that, when we extrapolate blindly from the West to us, we should be a little bit more circumspect in how we tend to interpret the results, because our approach to tube dependency or even inserting a tube is a little different from what the West follows. I don't know, but at least in our practice, we do not practice tube insertions as often. And for us, it's more of a reactive tube insertion rather than a prophylactic tube insertion. So all these things put together, the economics and how you can implement all this data. I'm not saying that none of this data makes sense or this data does not hold. But the point is we need to interpret this data in our context also. Yeah, Vinita, did you have something?
Even if we keep aside the point of feeding tube placement, why there was no difference in quality of life at 12 months in torpedo trial? Usually we expect that proton will have lesser side effects.
So if you don't leverage the advantage of proton therapy and the reduction into the OARs is of the order of 10% or less, as I said, for only 3 OARs was the dose reduction in double figures. In none, it hit more than 15%. I think the max is 14 for the cricopharyngeal inlet or something. For everything else, it's 6 to 7%. Just to explain that in about last year, Jan 2025, we made a completely different set of OAR constraints for protons. And when I say different, I mean if we say spared constrictor according to Nutting should be 50, less than 50. For protons, we ask our physicists to get less than 29. Right.
So I think it all boils down also to the fact how you're interpreting data and what your endpoints of interest are. So now I'll come to a very complex study, which all of us thought was complex. But Preeti, I'll ask you to tell us a little bit more about this study, because I know we are doing the nanoray study in the curative setting, but not in this setting. So can you tell us something about this study? And then I would ask the audience whether you believe in this study, whether you think there is a place for it, and can we do it, and are we doing it? Yeah, Preeti, quickly, if you could just tell us something about this.
So in this study, they introduced new like radio enhancer injections in the tumor sites before starting of radiations. So but this study was only phase 1 study. Until now, only preclinical trial has been done. So at present, I would like to say no to introduce in our daily life treatment, because I need more number of patients and more number of progression-free survival and overall survival durations to see the results.
Okay. Thank you, Preeti. Anybody would like to say anything more about this particular compound or, this methodology? Because I know there are a large majority of you who practice SBRT. And at the same time, this is something that is perhaps one of those options that is available for recurrent metastatic disease and with limited metastasis, where you can perhaps deal with the primary as well as deal with metastatic disease by perhaps increasing the biological effectiveness, either by using this nanobiotics together with your stereotactic radiotherapy. Any comments or any questions or anything on this particular compound? Then we'll shift gear and we'll move to the next one. And this brings me to a very important and contentious issue, and that is actually de-escalated adjuvant radiation therapy. So Bharat, of course, we've been discussing this for a long time about how we can perhaps de-escalate in our group of patients and whether we actually do it in practice. Roshni, I'd also like you to chip in. So how many of you actually practice any form of de-escalation in our patients, especially if they are HPV positive, that means HPV associated? They fall in the low or intermediate risk. I'm not talking about the high risk RTOG0129. And I would think about what is the safety of doing something. Would you be comfortable doing this in your patients? And are you likely to practice it? And if you were to de-escalate, how would you de-escalate? Would you do this kind of dose reduction? Because this is a real drastic dose reduction. You're not talking about 50 gray also. You're talking about 30 to 33 gray. You're talking about 36 gray, and all that is very radical. So would you think of doing it ever, Bharat?
No.
What about you, Roshni?
Ma'am, not
Anybody in the audience would like to do this? Because, the Mayo Clinic has now accepted it and they do it as their standard of care practice. So that's why I know we don't have HPV positive patients as much, but then we do sometimes see patients who don't have habits, who belong to that really low risk, intermediate risk. Are you tempted to do something like this? Any of the panelists? Okay, then if supposing you were to de-escalate, how would you like to de-escalate? I'm not saying the dose you're not going to de-escalate for sure. Would you like to do any kind of volume or dose reduction de-escalation in our patients? Can you do that?
So as of now, no. So the two trials that have studied this, the Dutch and the Belgian, both. So while the Dutch trial was a little promising, the Belgian trial actually had a regional control signal. So 2-year regional control outcomes of 15 versus 7. Even though they did analyze where the recurrences were occurring, and most of them were in the high dose arm, but still that regional control.
You mean the trial by Biao?
Yes.
Okay.
So and the Dutch upgrade RT trial.
Yeah.
So these are the two trials that have looked at volume and sort of dose de-escalation. So as of now, it is not the standard.
Can I just ask the audience and the panelists, like, if we were to dose de-escalate, would you think of doing it in the HPV positive population, or would you like to do it more in our oral cavity cancers, which is actually our bread and butter? So would you like to think about doing a volume de-escalation or a dose de-escalation in our group of patients with oral cavity? Because that's our problem. Oropharynx really is not our problem.
I'm not really thought of, but we can still look into cases which requires maybe a little smaller volumes and smaller fields who are like very intermediate risk post-op patients of oral cavity.
Okay. So Ahitagni, would you like to say something? Because, you have done the HIPOT trial from AIMS, where they have actually reduced the dose, or rather they've practiced hypofractionation. But then, of course, there is some study that is going on about from the PRESERVE study, which actually looks at trying to reduce the volumes. Not extending your volumes to kind of, today what we do is go at least an echelon beyond what is involved. In the tongue, we do bilateral. Things like that can be reduced further.
Yeah, exactly.
Or can we reduce the
I
dose?
was going to say this thing only. So the incidence of HPV positive oropharyngeal squamous cell carcinoma in our center, in a paper from head and neck, it was slightly less than 23%. And in subsequent analysis, we are finding the incidence is even decreasing, surprisingly. So it's very difficult to conduct clinical trials in such patients because the numbers are not really very big unless we collaborate together. However, as a routine day-to-day practice, we do not perform any kind of de-escalation in such patients. However, if I were to perform de-escalation, I can think of moderate dose de-escalation, maybe to the tune of 60 grays instead of 66 or 70 grays, or volume reduction, that is decreasing the elective nodal radiation, as you were rightly pointing it out.
And do you think escalation makes more sense to us than de-escalation? Yeah, Sapna, please.
I think in HPV negative oropharyngeal squamous cell carcinoma, I think dose escalation.
That's the bane of our existence, right?
That may be explored, yes.
Yeah, Sapna wanted to say something.
So I just, so I have, nothing, no basis to go by, except sort of my own experience or gut feeling, is that I feel that our targets for gingival malignancies, they should not be de-escalated. They should, in fact, be generous. And perhaps at some point of time, we will be able to come together with a consensus. Maybe because we see a lot of recurrent patients, or when I look at our failure patterns versus those of the others, I feel that the patterns of spread involving the perineural spread, ITF, the remaining buccal mucosa, etc. So our targets really do need to be generous.
I have a slightly difference in opinion, but then when our study is mature and when we have data, we'll kind of show you, because there is something to do, do less volumes and less doses with PRESERVE, with our apron study and things like that. But then we'll come to them when we actually have more mature results. So now this is the last abstract, I think. And Ahitagni, would you like to talk? Because, you know, suddenly immunotherapy has become the buzzword. We either have the 689 when we have perioperative, or we have Nivo post-op when we have high-risk patients. And if you've missed the bus by not doing 689, people want to do the Nivo post-op. So would you like to say something about these studies?
I think it's important to be aware of the presentations and the publications, the Keynote 689 and the Nouveau Postdoc. However, we need to very carefully consider the applicability of these studies, these study results in our population. Just a word of caution pertaining to the neoadjuvant part of the perioperative immunotherapy, pembrolizumab. There is a risk of tumor progression to the tune of 5% with neoadjuvant pembro, and these patients may not undergo subsequent surgery. So this needs to be discussed. There is no neoadjuvant arm in the Nivo post-op strategy, so that is not a problem there. And then we should also talk of the toxicities, which also include immune-related adverse events like hypothyroidism, thyroiditis, though these are becoming more and more manageable. However, I think we should not sweep under the carpet that there is a definite increase in the risk of grade 3, grade 4 adverse events, treatment-related adverse events. Like in the Nivo post-op trial, the grade 4 toxicities were doubled from 5% to 10% in the experimental arm. In the Keynote 689 trial as well, the incidence of serious adverse events were doubled from 10 to 19%. So these are some of the things which we should discuss. Particularly in the Nivo post-op trial, there was an increase in renal toxicity as well. So these should not be swept under the carpet. And then we should look at the quality of life issues, which have not been reported in all of these studies. And the cost effectiveness, of course, less than 5% of our patients can afford this kind of immune checkpoint inhibitor for such a long duration of 6 to 12 months.
So can I ask my panelists as the last question, what would you prefer? The 689, the Nivo post-op? In this group of patients, you know, and the 689 is a mixed bag. The Nivo post-op is more high-risk patients, 4 parameters essentially. So what would you prefer for our patients? I'm not talking about the evidence that is available, about what literature tells you, and which is a better trial, which gives you more what you call solid scientific evidence. I just want to ask you, what would you want to do for your patients who could afford, who come and ask you the question? Someone has missed the Nivo post-op, someone has, you know, they're treatment naive, they've come to you. What would you advise them to do?
The Nivo post-op could be a more pragmatic way out in our country. It's only 6 months and less expensive as well.
So if you look at the Keynote 689 analysis about, and there was some pathological downstaging in that trial as well. I mean, they mentioned that 12% or was it 11% patients had an actual change, and I believe this was presented in today's presentation. So around 12% patients had actually a change in their adjuvant treatment. And so if you have a patient who you think might need chemoradiation, why not go for Keynote 689 and leverage that, maybe benefit that patient in terms of reducing his radiation dose or chemo dose. Of course, it's only in CPS1. It's in CPS1.
12 months of thing, what you call...
The patient's affordable, he's willing, isn't he?
So, ma'am, Nivo post-op is definitely a shorter treatment, and we have a post-op scenario with us, so we have a better selection of patients.
You say Nivo post-op. What about you, Preeti?
Same, ma'am, Nivo post-op.
I thought Nivo post-op.
Nivo post-op, but biologically there is
the thing 689.
Individualized to the patient.
Sapna?
I would also veer more towards Nivo post-op. Having said that, in a very few number of patients that we have treated, there is a significant toxicity.
Anything in the audience, from the audience?
Post-op, because I think the generic is also available, and sometimes we tend to extrapolate and use a low dose Nivo also if the patients are not affording.
Yeah, Rajesh? That's nice, you know, to know that there is some variance. And I think for want of time, I'm just going to finish now. And thank you all my panelists, and thank you all the audience, and thank you the organizers for this. Yes.
to mention one thing, that the borderline resectables were not included in Keynote 689. These were clearly resectable patients. For borderline resectable in our country, what normally happens without, I think Dr. Cruz has a point to make.
Yeah, Dr. De Cruz, we'll have the last word from you on 689. Sir, please. No, you have to make a point now.
No, what I was saying was that for borderline resectables, very often in our country, they would have had neoadjuvant chemo. And now, increasingly, we are seeing, without there being any study, neoadjuvant chemo immuno. And some of them have had actually excellent results, including PAT CRs. So that is perhaps something that we need to look at in our country.
I'd endorse the discussion that everybody said. For me also, it's more Nevo post-op because, as you all said, it's pragmatic in design. And exactly like Sapna said, I just use the Keynote 689, though it's not pure 689, but from other paper, the Chinese, and they're doing response adaptive surgery. When we give borderline resectable chemotherapy, add IO with that, and then leverage that advantage. There's no level 3 evidence or level 1 randomized data, but that's the way we practice as well.
Thank you, everybody. Yeah.
Can you also briefly talk about the AST study which was presented in ASCO? They are all very keen to know about it. I'm in case.
I think the arrest study, though I'm not a principal investigator, has put me in a spot several times. And that's because of the outcomes of this arrest study. It has actually opened more questions, if you ask me really, than answered them. Because the thing is, if every oral cavity cancer, especially tongue, more than 5 millimeter, you have to give adjuvant radiotherapy. I don't know whether it's doable or not, because that's what the arrest in short tells you. You know, it does not answer questions about any of the other intermediate risk factors. I don't know if Dr.
No, we wouldn't use it. It's not standard of care. And that was the conclusion when Sudhir presented at ASCO as well. There's also a lot of other data. The Ibrahimi that brought this change in the AJCC8, showing that as DOI increases, other adverse factors increase. Then our group published that if you have thicker tumors, if you do an adequate neck dissection, it won't be there. And there's a large NCDB database also showing 5:1 if you treat neck. You don't need to give radiotherapy. I can tell you when I presented ASCO plenary, the N0, Brian Sullivan jumped up and he asked me, why didn't you give radiotherapy when it's more than 4 millimeters? But that's only a concept that radiation oncologists believe. You all used to radiate everything more than 4 millimeters earlier, but today the science has moved. I am very, very careful on using radiotherapy. And even when I designed the trial, 1 centimeter was my cutoff for radiotherapy. So I kind of believed that the staging would change 5 years before the others brought that change in.
But when there are cluster of other intermediate risk factors.
That's a different thing altogether. You know, see, Vinita, the point is actually arrest. And the HNCOG tried to address this issue that if you had 1 or 2 parameters only, then what do you do? Now, nobody is debating the thing of role of adjuvant radiotherapy when you have a cluster of 2 or more adverse features. It's when you have 2 or less, then what do you do? That's the thing.
Thank you, everybody. I request our panelists and moderator to please gather at the center of the stage for a group photograph. Thank you, everybody, for such an insightful panel discussion.
Thank you, ma'am. We now move on to hematological malignancies, where evolving evidence continues to redefine the role of radiotherapy in lymphoma and advanced cellular therapies. May I invite our respected chairpersons to kindly join us on stage. Dr. Rajiv Sharma, Professor Radiation Oncology, VMMC in Safdarjung Hospital. Dr. Jyotika Jain, ma'am, Senior Consultant Director, Radiation Oncology, NH Gurugram. Dr. Megha Saroha, ma'am, Senior Consultant Pediatric Hemat-Onco, Dharamshila Narayana Hospital. Yes, sir. Yes, sir.
Thank you. Hi, good morning, everyone. The next session starts for hematological malignancies. I think we can start straight away and call the first speaker. That is Dr. Chanja Mahapatra, and she would be speaking on decreasing the dose of consolidation radiation therapy in DLBCL and HGBL, a phase 2 trial by International Lymphoma Radiation Oncology Group. I just wanted to add, like the old-time radiation oncologists have seen a lot of things being done in hematological malignancies, which has been started or been there in mental, mini-mentals, involved field and consolidation and ALLs and all. But the things have changed. I believe that would reflect in today's talks. Thank you.
Good morning, everyone. I'm myself Dr. Chanja Mahapatra, a senior resident Dharamshila Narayana Hospital. I'll be presenting on this abstract, which is presented in ASTRO Meeting 2025 by Kesley. And the abstract is about decreasing the dose of consolidative RT in DLBCL and high-grade B-cell lymphoma. It is a phase 2 trial conducted by ILROG. Consolidative radiation therapy is a key component of treatment in diffuse large B-cell lymphoma and high-grade B-cell lymphoma, as we know, especially after abbreviated chemoimmunotherapy and in bulky disease, or those who have double hit genetics and dominant skeletal site metastasis, and also where the presentation is very critical for local control, like if it involves epidural space. And as the standard dose is established in pre-rituximab and pre-PET-CT era, that is 30 gray, which is well established and showed us 93 to 100% local control. But Duke University conducted a phase 2 study with small sample size of 62 only, but they showed 20 gray is also good enough for local control, that is 98%. And this is the basis of my abstract presentation. And the largest confirmatory study was undertaken by ILROG. It is a phase 2 study which has eligibility criteria of 18 years of age and included stage 1 to 4 DLBCL and high-grade B-cell lymphoma, including double hit and triple hit genetics. And all the patients received more than 3 cycles of systemic therapy, incorporating both anthracycline and rituximab. And on PET, they showed the response was D-Valley score 1, 2, 3. They were only included. And ineligibility criteria was primary CNS lymphoma, primary mediastinal B-cell lymphoma, and cutaneous lymphoma, and lake type, and relapse disease. And the intervention was given by involved site radiotherapy of 19.5 to 20 gray in 1.5 to 2 gray per fraction. And primary endpoint was 5-year local recurrence free. Patient characteristics was heterogeneous patient cohort. It was 243 eligible patients from across the globe. 16 institutions were participated in the study. They were from Asia, Europe, and US. Median age was 65 years and included 53% female and 47% male patients. And the histology was mostly DLBCL, that is 85%, and also 15% of high-grade B-cell lymphoma patients. And they also included double and triple hit genetics of 9% patients. And most of the patients were in stage 1, 2, 2 disease, that was 66%. Also 34% they included of stage 3 to 4. And 32% patients were having bulky disease, that is more than 7.5 centimeter of disease. And also they considered international prognostic index, that was 0. Most of the patients, 50%, around 50% patients had 0 to 1. Also 40% patients had 2 to 3, and 11% was 4 to 5. and the chemoimmunotherapy was given R-CHOP or R-EPOC, and a number of cycles, most of the patients received more than 5 cycles of patient, that is 70%. A few patients received 3 cycles only. Radiation therapy was given as involved site RT, and comprehensive RT was given to 81% patients. Selected site RT was given to only 19% patients. And mostly the RT modality was IMRT and VMAT, but they also included 3D CRT, and 6% patients also received proton therapy. And response assessment was done by PET CT, which was post chemotherapy, and maybe interim PET CT not earlier than the last cycle of chemotherapy. Median follow-up period was 3.1 years, and which showed only 16 relapse cases, out of which 12 were distant recurrence. Only 4 patients showed local recurrence, and among these 4 patients also, they were having high IPI index. Around 2 patients were having IPI index of 4, and two patients only, they were having IPI score of 2. And there was 2 patients having bulky disease, that is 15.1 and 13.7 centimeter disease. Coming to the results, a 3-year freedom from local recurrence was 98.7%. Also, 5-year local recurrence free was 97.4%. Coming to the PFS, progression-free survival was maintained at 91.7% in 3 years, and it slightly reduced to 87.2% in 5 years. Overall survival was 96% in 3 years, which is very good, and slightly reduced to 92.3% in 5 years. Now, coming to the conclusion, reducing the dose of consolidated RT from 30 gray to 20 gray did not impact local control. And the strength of this study was it was a large multi-institutional study having heterogeneous cohort which included risk factor also like bulky disease and IPI score high, and also double hit genetics. And it made the primary endpoint 5-year freedom from local recurrence 97.4%, which was non-inferior to the previous data. Only great caveat of this study was it was phase 2 study, but phase 3 study may be impractical due to required number of patients, and the median follow-up period was 3.1 years. What can be clinically implicated? That it supports adopting 20 gray as new standard RT after PET CT score. If we get complete response, that is usually 1 to 3, so we can replace 30 gray as 20 gray. It is also adopted by NCCN 2026 new guideline, and also reducing radiation dose might reduce late toxicity like cardiac toxicity and risk of secondary malignancy without compromising the disease control. Author acknowledged the co-investigator and the patients. Thank you.
Thank you, Doctor. So basically, a lot of heterogeneity is there. I think Dr. Gagan will be discussing in panel discussion. We can discuss that later on. Now I'll request Dr. Shobna for presenting next session. It is basically a prospective multicentric phase 2 study involving pembrolizumab and involved site radiotherapy as an alternative to transplant in patients with localized failure following chemotherapy for Hodgkin's lymphoma.
Thank you, ma'am. Good morning, everyone. First, I would like to thank Kanika ma'am for giving me this opportunity to present today. My abstract today is pembrolizumab and involved site radiation therapy as an alternative to transplant in patients with localized failure following first-line therapy for Hodgkin's lymphoma, which is a prospective multi-center phase 2 study presented by Alexandra Drufus at ASTRO 2025. There are no disclosures to make by the authors. So we know that the standard of care for relapsed to refractory Hodgkin's lymphoma has been evolving significantly. Current standard of care, previously the standard of care was high-dose chemotherapy along with autologous stem cell transplantation, which has been the standard for a long period of time, achieving cure rates up to 75%. However, this approach was associated with significant morbidity and mortality, and also was thought to be over-treatment for this subset of patients. Later in 2011, brentuximab vedotin has received approval for maintenance after autologous stem cell transplantation. And subsequently in 2016, checkpoint inhibitors like nivolumab and pembrolizumab also received approval following autologous stem cell transplantation. In 2020, both brentuximab vedotin, which is an antibody drug conjugate, and the checkpoint inhibitor combination has been used in the relapsed or refractory Hodgkin's lymphoma. because these drugs were known to cause less toxicities with impressive efficacy. Subsequently, the authors tried to see in different trials if transplant sparing approaches is a possible option with the combination of these immune checkpoint inhibitors and ADCs. So if we look at pembrolizumab, it is or any other checkpoint inhibitor, which are PD-1 inhibitors, when given along with radiation, they have its synergistic potential to prime the T cells and increase the immune response. And this is what the authors have tried to see if this synergistic response can create a transplant sparing approach in this relapsed refractory subset of patients. So the question that they asked is if PD-1 inhibitors supported by localized radiation, if they can provide an alternative to high-dose chemotherapy followed by stem cell transplant in patients with localized failure after the first-line therapy. So this is a multi-center phase 2 study done in 3 centers in the US. The inclusion criteria was mainly initial stage 1 to 2A Hodgkin's lymphoma with non-bulky disease, which is less than 10 centimeter, who had a local relapse after chemo only or combined modality therapy. The primary outcome of the study is complete response after combination of pembrolizumab and ISRT. And the secondary outcomes were response to single agent pembro, 2-year progression-free survival, and toxicity. Some other tumor markers, molecular markers, and blood parameters like cytokines and PD-1, PD-L1 status, beta-2 microglobulin, and ctDNA were also noted to see if they can help us to understand if they will be useful in evaluating the response and for the future studies. So they did a baseline PET-CT at the time of diagnosis, at the time of relapse, and then pembrolizumab 4 cycles were given with a standard dose of 200 milligrams every 3 weeks. And then a simulation PET-CT scan was done. Based on the response, the dose of ISRT was varied. So dual score 1 to 3 was considered to be a complete metabolic response, and 20 gray ISRT was delivered to these subset of patients. And patients with dual score 4 to 5 underwent a biopsy. If the biopsy was negative, they received a dose of 30 gray, and if the biopsy was positive, they received an escalated dose of 36 to 40 gray. If dual score was 5, it was considered as progressive disease. They also underwent biopsy. If the biopsy is negative, they were still given an escalated dose of 36 to 40 gray. If the biopsy was positive, then they were removed from the study. Looking at the patient characteristics, the demographics mainly included patients between 22 to 66 years of age, average age being 36, and 45% of these patients were males, majority were females in this study, and over 80% of these patients were belonging to the white population. And looking at the disease status, more than 80% of the patients were stage 2 Hodgkin's lymphoma, and 14% of the patients were stage 1. And majority of the patients, that is over 85%, received a single modality of therapy. Either they are relapsed after chemotherapy, which is 50%, or 36% of the patients had primary refractory disease after chemotherapy alone. So 14% of these patients had a relapsed disease after combined modality, that is ABBD in combination with ISRT. Majority of the patients, over 80% of these patients, received ABBD-based chemotherapy either alone or in combination with RT, and only 5% of these patients received BioCop. So looking at the study progression, so pembrolizumab was received by 22 patients, which is the subset of the total population of the study. And when the PET restaging happened, 1 to 3 dual score was seen in 32% of the patients, which is 7 out of these 22 patients. And dual score 4 to 5, which is partial response or stable disease, was seen in 10 patients, which is 45%. And disease progression was seen in 4 patients. Out of these 7 patients who had dual score 1 to 3, who had complete metabolic response, all the 7 received 20 gray of radiation. And in dual score 4 to 5, which is partial response or stable disease, which is 10 patients, after biopsy, 7 patients had biopsy positive disease and received an escalated dose of 36 to 40 gray. And 3 patients had biopsy negative, so they received a reduced dose of 30 gray. All the 4 patients who had progressive disease, which is a dual score of 5, after undergoing biopsy were positive and are removed from the study. So out of the 22 patients who were the study population, 5 patients could not undergo the complete ISRT and pembrolizumab combination, and 17 patients completed the required study. So with pembrolizumab alone, the complete metabolic response was seen in 32% of the patients, which was one of their secondary outcomes. And with a combination of pembrolizumab and ISRT, 94% of the patients had complete metabolic response, which is the primary outcome of the study. Looking at the progression-free survival, which is another secondary outcome, at 35-month median follow-up, at 2 years, their progression-free survival was 61% if the overall population was considered. And in that population, which received a combination of ISRT along with pembrolizumab, the PFS at 2 years was 80%. When it was further stratified based on those patients who had primary refractory versus relapsed disease, the green curve represents the relapse, which had better response, and it was statistically significant as compared to the blue curve, which is primary refractory disease. These are different combinations that were used at the time of salvage with checkpoint inhibitors or pembro along with chemotherapy, or brentuximab vedotin with immune checkpoint inhibitor and stem cell transplantation. And all of these showed good responses. And therefore, optimal study for identifying the optimal treatment at the time of salvage is to be further done. Looking at the toxicities, most of the toxicities were less than grade 2. Common toxicities were diarrhea and fatigue. Very few grade 3 toxicities in the form of headache or encephalopathy were reported. So they concluded that pembrolizumab and ISRT combination yielded excellent complete response rates with minimal toxicities and could be an alternative to high-dose chemotherapy and stem cell transplantation in localized favorable relapsed or refractory disease. They also wanted to identify the correct timing or the sequence of radiation and the correct dosing of radiation, and they're not aware if 20 gray would be sufficient in this setting. And this is what they wanted to identify in further studies. Thank you.
Thank you, Dr. Shobna. Next, I'll call Dr. Sonia Tiwari, who will be presenting on updated results of restart protocol, that is radiotherapy, bridging and consolidation for CAR-T in large B-cell lymphoma.
So good evening to everyone, and thanks to Dr. Kanika for the invitation. So I'm presenting the update result of the restart protocol, that is radiotherapy, bridging and consolidation for the CAR T cell in large cell lymphoma, presented by the George McHill and the group in the Guy's Cancer Center, UK. These are the disclosures, and as we all know, the 40 to 50% cases will progress after CAR T cell treatment, and differential response is also responsible for the progress to the CAR T cell in the LBCL. Large metabolically active lesion have higher risk of the CAR T cell resistance. Radiotherapy is also can be used for targeted eradication of the high risk site and potential synergistic and priming effect to the to complement the CAR T cell, that is pre-CAR T radiotherapy and post-CAR T. Can also the high risk patient post-CAR T as a consolidative radiotherapy. And radiation also after CAR T cell may have the negative effect on the CAR T cell responding, can we reduce it with the to see the results of the radiotherapy. So restart protocol, the aim of the protocol is to maximize and standardize the use of peri-CAR T RT, that is predefined selection criteria for the bridging RT and the early consolidation RT, and also developing the blood sparing RT technique for the consolidation RT. So for the pattern of failure, mainly in the non-irradiated patients, are the local relapse is very common, that is 80%, more than 80%, and relapse is early within 3 months, and size and the SUV max are the high risk factor for the pattern of failure, mainly local failure. And also the depth of response at 1 month PET scan after CAR T cell in consolidation RT, that is mainly the failure in the Diwali score 4 and 5. mainly the progression of the disease and treatment failure. And if the DVALI score is 1 or 2 or high risk DVALI score 3, mainly in the 1 and 2, the progression of the disease in the 10 to 15% of the cases. So restart protocol is, what is that? So they taken the relapsed and refractory LBCL cases approved for the CAR T cell infusion and taken the baseline PET scan to identify the risk sites and chosen the for the divide into the pattern A and pattern B. In the pattern A single modality pathway, that is RT bridging, for the sites of risk, they given the 30 gray 10 fraction and low dose 4 gray for the priming and the debulking disease. And after that there is apheresis and the CAR T cell infusion, which is take about 40 days for the infusion. And in other pathway B, indication for the systemic bridging, that is systemic treatment for the rapidly progressive disease, widespread extranodal disease, and LDH more than twice than the upper normal limit. And then CAR T cell infusion. After that, after 4 to 6 weeks, then again PET scan and see the response, and then decide RT as a consolidation and by the blood sparing RT techniques. Mainly the sites of the DVALI score 4-5 and dose is 30 grade, high risk site with the DVALI score 3. So CAR T cell sparing technique for the consolidation RT, that is aimed to reduce the fraction, beam on time, and blood rich areas, that is hypofractions, use 3 gray per fraction, and contouring the large blood vessels, bones, and blood rich organ, that is heart, liver, spleen, and kidney, for the optimization, and reducing number of the VMAT arc and reducing the arc angle and triple F beam. Restart flowchart, that is they taken the 190, enrolled the 190 patient from October to May 21 to 24 by the 2 centers and use the Exi-cells and the TISA cell. And in the pathway A, the patients are 30 patient taken, and pathway B 160 patient. In this consolidation RT, 25 patient received the RT and no RT received by this 134 patient. The reason behind is there is complete metabolic response, progressive disease, and death because of the toxicity of the CAR T cell or and the previous history of the previous RT taken. So consolidative RT in the DVALI score 4-5 and high risk DVALI score 33% of the cases. And these are the patient characteristic, mainly the age 56 year, mainly, and male patient, and most common histology DLBCL, and the cells of origin GCB, IPL score mainly 0 to 2, and the stage 3-4 49% of the patient, extranodal site 14%, and LDH more than double, bulky disease more than 7 centimeter, and ECOG 0 to 1, and vein to vein days, this is important, 40 days. So RT detail is the bridging RT 30 gray 10 fraction and number of site 1 to 3, and consolidation RT is also taken same dose 30 grade 10 fraction, and the in high risk disease DVALI score 3 and 4-5. And all the RT patient completed at time as planned, and local control is important, that is 89% and 87% in the pathway A and 92% in pathway B. And there is no grade 3 toxicity, and CAR T cell infusion toxicity grade 3, only the neurotoxicity, no CRS, cytokine release syndrome. So long-term survival, only the 1 year survival, 12.4 months, that is in the total cohort 57%, and the overall survival is the 71%. Progression-free survival in the pattern A with the bridging RT, that is 65% in all patients. Pathway B, that is progression-free survival 55%, and consolidation RT progression-free survival, that is 12 months, and OS is 95%. That is important, that is good overall survival in path B. So conclude the author by this prospective protocol. This is a prospective protocol, but not randomized, for standardization, maximization of the RT use before and after CAR T is feasible with high compliance. And protocol treatment was well tolerated, no grade 3 toxicity with RT, and CAR T sparing technique is used, so no negative effect, no increased distant or local relapse because of the early consolidative RT, and survival outcome is also encouraging. Overall cohort progression-free survival 57 and overall survival 70%. Even in the worst group, Duvalion score 4, 5 and high risk Duvalion 3. PFS 54, overall survival 95. So consolidative RT seems to have compensated for the worst prognosis, and further move to for the next step, detailed RT planning study, adoption by the other centers, and the more randomized and national data collection. These are the acknowledgement by the author, and thank you so much.
Thank you, Dr. Sonia. Coming in last but not the least, Dr. Gargi Sharma, I invite to speak about the prospective study of split course bridging radiotherapy SC BRT prior to CAR T cell for relapsed refractory B cell lymphomas.
Good morning, everyone. First, I would like to thank Dr. Kanika ma'am
Please
for
use the
giving this
mic a
opportunity.
bit louder.
Is it okay, sir? Okay, so topic of my study today is prospective study of split course bridging radiotherapy prior to CAR T cells for relapsed or refractory B cell lymphomas. So the principal investigator is Brandon S. Imber, and it is from MSKCC. These are disclosures. So coming to background, anti-CD19 chimeric antigen receptor T cells, that is CAR T cell therapy, has revolutionized the treatment of B cell lymphomas that we know, and it's now the current standard for primary refractory or relapsed B cell lymphomas after the failure of first line treatment. And bridging radiotherapy is now well accepted because CAR T cell manufacturing takes several weeks. So patients who have bulky disease or have rapid progression, they require bridging radiotherapy during bridging therapy during this time. And bridging radiotherapy is now a well accepted approach in this case. So but in this present study, they are giving bridging radiotherapy as split course, part 1 and part 2. So the rationale comes from these two observations. First is effective cytoreduction. So this graph is from Hubling et al. Study, where they divided the patients into 4 groups based on their pre-treatment PET disease burden. So patients who had low metabolic tumor burden at the initial stage were classified as P low, and they persistently had low metabolic tumor burden during bridging therapy and responded well to CAR T cell therapy. Similarly, P high was the group who had high metabolic tumor burden during initial before bridging therapy, persistently had high tumor burden during bridging treatment, and had lowest outcomes. So there is a group in the improved. These were the patients who had initially high tumor burden, but after bridging therapy, their tumor burden was reduced and they responded well. So their progression-free survival was close to P low, which had the best outcome. So this means the effective cytoreduction, if we could achieve even in patients who had bulky disease initially, the outcome of CAR T therapy can be improved. The other observation comes from preclinical mouse studies. So here we have these Kaplan-Meier survival curves. So the first graph shows that when RT is combined with CAR T cell therapy, so those arms are performing better in terms of survival outcomes. And here also the timing of radiation with CAR T cell therapy is important. So when RT is delivered with a gap of just 1 day before CAR T infusion, these arms performed better than the remaining, the no treatment arm or the CAR T cells with 10-time dose. In the another graph, we see when the low dose TBI, 1 gray is combined with CAR T therapy, and or 2 gray TBI is combined with CAR T therapy. So those survival curves survival curves are approaching to 100%. So here we know that this low dose, the dramatic improvement in their survival could not be because of the low dose, and alone CAR T therapy is not giving the good response. So this is the combination, and the low dose RT just before CAR T infusion has something to do with altering the tumor microenvironment. So based on these two observations, investigators hypothesized that the delivery of low dose comprehensive bridging radiotherapy after lymphodepleting chemotherapy will be feasible, safe, and can improve anti-CD19 CAR T cell therapy outcomes. So they developed a strategy which was stage adapted. Patients underwent pre-treatment PET imaging, and if it was localized disease, patients received first course of RT as ISRT 3 gray per fraction for a total of 9 fractions. Then received conditioning chemo, and after completion of conditioning chemo, they received second part of the split course RT, which was 3 gray single fraction to the same area. And so the total dose to the involved site, to the total dose for the disease was 30 grain 10 fractions. Then they underwent CAR T cell infusion. And on the basis of pre-treatment PET, if it was advanced stage, patients received ISRT 3 gray per fraction for a total of 9 fraction. That was first part of the split course RT, but just to the bulky disease area. Then they received conditioning chemo, and then received last second part, that was 3 gray single fraction, and this time they included all the disease area, the bulky disease which had already received 27 gray, and also to the active PET disease. So the total dose to the bulky disease was 30 grain 10 fractions, and to the rest of the disease it was 3 gray single fraction, and they underwent CAR T infusion. So the eligible patients had histologically confirmed relapsed or refractory non-Hodgkin's lymphoma with PET positive disease, and they were planned for any commercial CD19 CAR T product. Patients who were planned for systemic therapy were unable to receive comprehensive BRT. They were excluded from the study. So this is the timeline. It started with PET scan, then biopsy to confirm the diagnosis. Then patients underwent leukapheresis. Then they received split course bridging RT, first course, which was 9 fractions of 3 gray per fraction. Then received conditioning chemo, and the second part of the bridging course RT was given at -2 or -1 day, where CAR T cell infusion was at day 0. Then biopsy, it was just a research biopsy to see the tumor kinetics after CAR T cell infusion. It was done at day 7 plus minus 3, and then response assessment at day 30, 100, and day 180. It was a phase 1 study, so primary aim was to evaluate the safety, and primary endpoint was to see the number of unanticipated severe toxicity results. So the patient characteristics, there were the median age was 60, ranging from 30 to 80 years. Main histology was DLBCL. There were 2 patients with high-grade B-cell lymphoma. The primary refractory disease was seen in around 40% of the patients, and 55% of the patients had localized, 45 had advanced disease, and in 75% of the patients, the CAR T therapy was the second line of treatment. And regarding CAR T product, majority had received lisocabtagene. So this is a PET image showing ISRT to 30 gray in the green volume, and the 3 gray volume is represented in the blue color. So the primary endpoint was feasibility. So all patients successfully received split course bridging RT followed by standard chemo depletion. And regarding safety, there was one patient who had grade 5 cytokine release syndrome at day 6. And important to notice that this patient had significant medical comorbidity, had high burden of active disease, and also received axi-cell. So all these factors, they are associated with higher risk of toxicity. Otherwise, this novel strategy was well tolerated in other patients with cytokine release syndrome grade 1 and 2 was mostly seen in the patients, and the overall ICANS, it was seen in 10% of the patients, that is 2, one had grade 1, one had grade 3. So the overall response rate was 89% at day 3 and 79% at day 90, 74% at 180. Complete response was seen in 79% of the patients. And regarding the pattern of failure, if we see both the high-grade lymphomas, they relapse, which means the high-grade lymphoma is an aggressive biology. Then the not only advanced, the localized disease relapse. That means anatomical extent cannot imply the favorable biology. Regarding the relapse site, the most common sites were skin, soft tissue, bone, or chest wall. That means extranodal sites are probably difficult to control. And lastly, the pattern of recurrence. The most patients had out of field recurrence. That means 30 gray would have controlled the primary site, but the sites which had received 3 gray, or there were new lesions, so the most of the relapses were out of field. They also did exploratory analysis of lymphocyte dynamics, and they found that maximum CAR-T expansion occurred between day 5 and day 10 post infusion. And when they saw the responders versus non-responders, the CAR-T cell proportion was significantly higher in responders. And among the CAR-T cell subsets, the CD8 cytotoxic cells were significantly expanded more in responders compared to CD4 cells. So there was enrichment of CD8 positive CAR-T cells. And in also the CD8 subsets, they found that central memory and effector memory cells, they were seen in higher proportion in responders compared to non-responders, which was desirous of good response, because these are the cells, the central memory and effector memory, which will actively fight with the tumor cells, have proliferative capacity, and can persist for longer duration, can give durable response. And lastly, just this is the negative slide. So they wanted to check if there was activation of patient's endogenous immunity after the low dose RT just before CAR-T infusion. So majority of the graphs show there was no significant difference between endogenous T cells and their subsets between the responders versus non-responders. So to conclude, this data indicate that this strategy, which is split course bridging RT with CAR-T, is a feasible and well tolerated in patients with B-cell lymphomas with evidence of accelerated CAR-T expansion. The objective response rates were good, and the preliminary analysis shows that anti-tumor activity is primarily mediated by CAR-T cells rather than patients' endogenous immune effects. Lastly, this is the first report of radiotherapy where the radiation was delivered after lymphodepleting chemotherapy, and it supports the feasibility of this novel strategy. Thank you.
Thank you, Dr. Gagi.
I think we conclude this the panel discussion. I believe panel discussion is very aptly the topic is where does the RT fit today, and I believe RT is relevant and is fitting very nicely in hematological malignancies. So Dr. Kanika for the panel discussion.
I would also like to invite all the panelists, Dr. Jhanda Mohapatra, Dr. Sonia Tiwari, Dr. Shobna, Dr. Sarita Jaiswal, Dr. Gargi Sharma, Dr. Aditya Sareen sir, and Dr. Sahil sir.
So firstly, I would want you to just clap for these young faculty. They really stepped up, because hematology, the topics were offered to a lot of senior faculty who looked at the slides and backed out because they were too complex. I think our juniors did a very good job in very descriptively making you understand these studies. And I am here on behalf of Dr. Gautam Sharan, who had to fly back because of some unforeseen emergency. So it is going to be more of a discussion, because I also heard these slides just with you right here. So firstly, I think Rajiv sir very rightly pointed out that it is there, but now how it fits into the newer scenario with newer drugs, with newer entities like CAR-T stepping in. So now we have to redefine our place in terms of our sequencing, in terms of our dosaging. And I think all these 4 abstracts were an example of that. We are de-escalating, we are trying to reducing the number of modalities of treatment, replacing a transplant with a lesser morbid option, or maybe, introducing radiation in a very different fashion where the synergy has a different role to play. So I will start with the first abstract, which was presented by Dr. Jhanja. I want the medical oncology and the transplanters take on it. We are de-escalating. What is your take on it? Are you happy with the results? Because as Dr. Jhanja very clearly mentioned, it has already come into our guidelines. This was practice changing. Despite being phase 2, this was practice changing, as it has stepped into our guidelines. Your take on to it?
Well, I think in the current given scenario and the data, obviously it has made sure, it quite encouraging, and the wherever possible, we try to make sure that our systemic treatment goes down, and we can spare them of the any extra thing. And de-escalating protocol, obviously everybody is the need of the hour, and wherever possible, I think we are doing it. But for the time being, I think as of the current practice standard of care from a med-onco perspective, generally we reserve this for patients, if you had an initially bulky disease and we feel that, this patient is going to have a high risk of recurrence down the lane. So that is where we are contemplating it right now. But yeah, if given a choice, I mean, these are there in the NCCN guidelines, so you can individualize as per your own practice. Yeah.
So with immunotherapy being integrated, like previously we just had chemotherapy as a part of conditioning regimens before RT. Has there been a change in practice? Because we see the number of cases coming to us for involved field are slightly declining over the last 3 years because of this immunotherapy being integrated. Any change you see in your practice?
DLBCL immunotherapy is not that upcoming into the field, but for Hodgkin's, it has definitely changed the entire treatment paradigm where, drugs like brentuximab and nivolumab and pembrolizumab, they have completely revolutionized the treatment. And I mean, then you have these inclusion of ISRT along with these IO. So we have tried in few of our cases, but in DLBCL, IOs are still behind.
Dr. Jhanja, since you presented this study, would you want to, give your take on to it? What was your understanding? Is it a one-step shop for all the patients, or would you define a patient category where you feel this risk adapted reduction dose works well?
Yes, ma'am. This is selected only for PET-CT dually score 1 to 3%. If it is high, then we are not de-escalating. And also for bulky disease, we might be some cases because they included bulky patients at 32% patients. But still, if it but the 4 local recurrence which we got, among them there was bulky disease. So we can be cautious in that case. But yes, we can include all the stage patients. Doesn't matter if it is stage 4 or stage 1. But yes, for bulky disease and for
yes, Mike. They have.
Yes, ma'am. Yes, sir.
The question only is that what is your take at the panel's take on understanding the fact that this is being used as more like a protocol and not as a selection for bulky disease. So, if you want to use that as a practice, maybe it would be graceful.
And another thing, maybe the entire audience can take a take. We wait for phase 3 for maximum things. Are we happy enough on the basis of a phase 2, although the number of patients has been 200 plus, to adopt this practice? Are hematologists comfortable?
No, not yet. We have to wait, I think, for another couple of cases to come to the conclusion, I think. Yes.
So how many of us have actually started practicing de-escalation?
So once, if the disease burden is low, tumor burden is low, so obviously it should be individualized, what I believe, but not right now.
So I think that is what Dr. Gagan was pointing out, that there is still scope of personalization. It is not a take home for all DLBCLs in CR, you are de-escalating. Anyone from the floor has anything to, Dr. Jyotika wanted to say something. Mike. So which will be, yeah.
Patients with so many variables, including say bulk, IPX4, so many factors. I don't know how come we can go ahead with 30 from 30 to 20.
So if we were to choose de-escalation of these 4 parameters, where would you still want to deliver 30 gray? Bulky disease, double hit, triple hit biology, abbreviated chemo, advanced stage. Where would you still all 4, or there is a subsegment where you would still insist that we want 30 gray, don't step down to 20 gray?
I think Right now, we should, for my personal opinion, that we should not come down to 30. Let it be unless there is a PET responder, and the class 1.
But it is the PET responder group they are talking of, dual 1, 2, 3. Okay. So I think we still want a phase 3 to substantiate it. Yes, yes, more data to substantiate this. And I think that is the limitation which the authors also had admitted to, that it is a phase 2 study. And they say that the number of patients they required to conduct a phase 3 was not available. And of course, the short follow-up also is something which still restricts our choice to continue 30 gray as a practice. So a lot of data is suggesting towards de-escalation. The trajectory is indicating that with more prospective studies coming into our disposal, we might be able to shift to 20 gray in certain scenarios. And of course, this has already been mentioned. So now we'll come to the second study. Dr. Shobna, you had presented. Would you want to say a couple of lines? You wanted to discuss a bit. What do you feel have been the strengths and what are your concerns for this abstract?
Ma'am, the main concern is that it's a very small study. It had only 22 patients, out of which 5 patients were later lost because of disease progression. So it was an evaluation of only 17 patients, out of which majority of them, 16 patients had complete response with pembrolizumab and ISRT. That is the main concern. It's a very small study, just including 22 patients.
From our medical oncology colleagues, any experience of this integration? Have you used Pembro with RT?
To be honest, yes, we have done this. But talking about this particular study in particular, I think this does open up a lot of options for us when it comes to relapsed Hodgkin lymphoma in certain subsets of population. For example, frail patients, someone who has a late relapse, and quite a small area of relapse, which can be targeted with radiation. And if a person is not very fit for a salvage chemotherapy or a transplant. So these would be the type of patients we can consider this. So we've seen safety of pembrolizumab along with RT, and I think this should be something good if we have more data to back this.
So I think it is just giving a signal. I think the authors themselves are indicating that we're just signaling that this may be an option. But are the transplanters happy with this integration?
Yeah, no, not, but yes, transplant ineligible patient. The patient we would love. So I am a transplanter, so I would love to take this patient.
But if it is a very limited relapse and transplant also is requiring a lot of logistics. There are patients who may not.
Autologous would be fine. I don't think autologous, the mortality rate is less than 5%, so we can take the patient for auto.
Right. So,
ma'am, can we have
I believe that it's a cellular thing. It's a cell which will kill the cell. It's not whatever ample amount of radiation or the chemo radiation you give. Ultimately it's a cell which will kill the cell.
Ma'am, in stage 1 or 2 limited recurrence in Hodgkin's after transplant, what is the expected outcome in terms of absolute overall survival, or the way they have disease-free survival or progression-free survival? Is there any absolute number you can say?
It's more than 95%.
So more than 95% can be salvaged. Yeah, so certainly that is a better idea. Yeah.
May I just add that for pediatric patients, I believe there is a decent data to suggest that if it's a late relapse and the patient has not received RT upfront, just like the same study, he or she may be a candidate for not getting transplanted. Autologous transplant may not be indicated for such patients. There is a decent data for that. And in this study, I think the duration of relapse has not been mentioned clearly, that how many were early relapse, how many were late relapse. It has not been mentioned. So first thing will be the duration of relapse will be very important. A late relapse may still be candidate for this therapy if it was not a upfront radiotherapy who had received, or it was a local relapse. I think still a candidate. Fair enough. I think we should go ahead because all the data till date has been only with chemotherapy. With immunotherapy stepping in, I think it has to be further explored.
But the CMR rates are so attractive. CMR popping up directly to 73% from 32% by integration of RT. So
Definitely, I think if the patient has not received upfront RT, majority of them had not.
6% received only chemotherapy.
I think some had, but I'm not sure if it was a local relapse, how The duration of relapse will determine if the patient can be again radiation can be given to the same site or not. So that will be an important determinant if the patient is a candidate for irradiation.
So take home is it is not a standard. We still are not saying that it will be replacing the autologous stem cell transplant as of now, but it is a promising option, and maybe with more numbers and a bigger study will validate the findings of this current study.
What
Dr.
is
Sarin?
happening right now is that you need to identify if you have a patient within 1 year, or well, let's say patient is a refractory, then you have to see whether patient is in within 5 years or more than 10 years of relapse. So you have to stratify your relapses accordingly. And I think most of us are we also do transplants a lot of autos, and I think for the time being we are using IO with the targeted therapy or IO with the chemo as a bridge for the autos. And currently if we feel that patient is let's say patient is having a major CLD and we feel patient cannot tolerate high dose chemotherapy, so obviously then the role of this kind of protocol definitely can jump in. But for the time being, I think most of our patients are going for the autologous. If auto is not an option, then I think we can go and use this approach.
So since if it is used as a bridging therapy, if there is somebody who goes through this regimen, will it make him or her ineligible for
So
a
for the time being,
transplant later on?
this protocol of IO with ISRT has not been used as a bridging therapy as such, but currently what we all are doing is IO with a conventional chemo or IO with the brentuximab. We are using those kind of protocols as well. And we are seeing, fabulous responses over there in
Will
Hodgkin's.
this regimen make the patient ineligible for a subsequent transplant if required later, ma'am?
You have to give certain amount of gap, that's all.
So I think that is one, again, a point, because that needs to be understood that we would not leave the patient from getting an opportunity for transplant if it does affect his outcome or her outcome. So of course the authors themselves have said that there are a lot of nuances and there are a lot of concerns which they will address before actually recommending this regimen, because the sequencing of treatment, the dosage, and the integration with systemic treatment needs to be addressed as of now. So, Dr. Sonia, you presented the restart protocol, the radiotherapy, along with CAR-T for the large B-cell lymphomas. What do you feel were the strengths for your abstract, and what were your concerns regarding it?
I think this is the good strategy to control for the treatment of relapsed and refractory lymphoma, DLBCL, large cell lymphoma. So bridging therapy is to see this is more important, that during that period from apheresis to the infusion, the time period is 40 days, even more. So that time the disease may be progressed. So bridging therapy is important to control the disease. Even after the consolidative RT, after infusion, so if there is no response or the progression of the disease, that also shows in this result good local control with this is not phase 1. This is a prospective trial, phase 3 hai. I think. Yes. So, but the time period of this follow-up is very short, only the 1 year. So that needs to define the mainly the selection of that patient and define the role of radiotherapy properly. What is the dose? Dose is not well defined in this study, 30 gray 10 fraction, but in other study they also given the 20 gray or in 25 gray, different doses. Even the priming dose is also given 4 gray for this low risk disease, or the size is less than 5 centimeter disease. So that is also important. That is also act as a immunomodulator and to reduce the inflammation. So
I think integration is elemental. The question is
and
bridge with
toxicity is
RT
less.
or consolidate. So again, coming back to our medical oncologists and hematologists, how
I
do you
mean,
look at it?
let's say if the patient is having, we are contemplating. So till today, I think we have done like 7, 8 CAR Ts, and I have not been able to use radiation as a bridging. Most of the times, it's the chemo that we are, using. So this kind of a concept can become rational if you have a disease which has localized site.
Yes.
Let's say if there are like multinodal station involvement, I don't think there will be any point to consolidate it with the RT, because you can't target so many sites and then plan for CAR T as well. So,
This study, there is a selection of the criteria. If the dually score is 4, 5, or size is more than 5 centimeter, then
So
the
I think even in
let's say if patient is having a supradiaphragmatic nodes and infradiaphragmatic nodes, let's say you have axilla, supraclav, and abdominal nodes as well. Will those patients with the same amount of criterias, I don't think we will be able to cover in such a huge field.
So as you may have seen in Dr. Gargi's presentation as well, the intent is not to radiate the entire disease burden. The bulkier disease has been identified.
The selected,
Yeah,
so that's
yeah,
so that means you have to target a very specific point, and those hot areas where dual is high, those may be one of those areas you can irradiate.
in the bridging strategy, some patient in the pattern B, pathway B, they given the systemic chemotherapy. So systemic chemotherapy is also added in some of the patient is very toxic. So even the suitability of the CAR T cell infusion is not suitable for the CAR T cell infusion after systemic therapy. So the bridging therapy has role in these.
Yeah, so bridging therapy is constituted in form of chemotherapy and targeted therapy. So we have like drugs like glofitamab, we are using those as bridging therapy. So at the end of the day, bridging therapy means that the volume has to be reduced down before you go ahead with the CAR T replenishment. I think, ma'am, anything else you want to?
See, there was one thing which was again determined in the study, that irrespective of whether you added radiation as bridging or as consolidation, it did improve outcome. So I think integration of RT is in either form been determined as one of the factors which is likely to add on to the outcomes to the CAR T.
Basically we got a sense of, and what even Dr. Sareen is trying to actually put across, is the fact that we need to select our patients very carefully for any such thing, because what we primarily got a sense of from the study was to reduce the bulk in some way or form when we incorporate RT. What we also need to understand is incorporation of radiation therapy. As we have seen in the previous studies as well, we had the boom study earlier as well, which had a 2x2, like ma'am was pointing out, the low dose radiation, which was being given as a bridging earlier also before CAR T. Does it have a role in the targeting the antigen escape or any such other phenomena that do lead to CAR T cell failures later on? Not in DLBCL, but in multiple myeloma, we've seen a lot of extramedullary recurrences following CAR T cells. So there is certainly some amount of deficiency or some shortcomings that even the CAR T cell therapy has, and if radiation can be incorporated in selected patients where we can incorporate such plans, I think that will be helpful.
So they have talked about using the blood sparing RT. In this, if you see the technique of delivery of this has been very, very specific. They have been concerned, as you had concerns about the volume of treatment. This is the type of, the treatment technique they adopted. They contoured the entire blood vessels bearing organs as well as the vasculature, and selectively reduce the dosage to them. So I think the concern regarding the volume has also been addressed partially, and I think of course there are a lot of other things which are to be addressed from the radiation physics point of view in terms of number of fractions, the treatment delivery, which will be, I believe, addressed in fewer more studies. So the authors concluded that this was to attempt the feasibility, assess the feasibility whether we can deliver such form of treatment. They wanted to assess the compliance, but it was well tolerated with no grade 3 toxicities, and survival outcomes were definitely encouraging. And even in the worst group, who did not have a good response, dual 4-5 with high risk, they said that the consolidation was able to compensate for the poorer outcome in that subgroup. And that is why if you see the OS ultimately in both the groups was 95% at 1 year. So I think the last study for the day, which was presented by Dr. Gargi, which was split course bridge RT. I think very interesting study. I think very diligently they have defined treatment volumes pre CAR-T as and after CAR-T. What is your take on the strengths and the concerns for this study?
So, ma'am, as bridging treatment, there were already studies published. They have used RT as the bridging treatment before CAR-T infusion, especially in bulky or symptomatic patients with pain or organ compression. But the important thing about this study is they used the role of low dose RT as immune priming just before CAR-T infusion, and the evidence comes from preclinical studies, so it hasn't been proven. But yes, if it works, then it's a great strategy. We are giving local control as well as we are increasing the effectiveness of the CAR T therapy.
So this abstract already considers the previous abstract as a baseline. So bridging has been considered and then the regimen has been changed. So your take, Dr. Sarita, do you think this sort of a regimen of splitting is feasible? And any concerns you have regarding this sort of a regimen?
Yeah, concern in the sense that after you are taking withdrawing lymphodepletion, so what is the duration they want? First thing is that, and so 1 day prior they have used 3 gray, which is just like a TBI.
TBI, it is TBI.
So first thing we have to see the type of patient, very selective type of patient can undergo who to this regimen, what I believe. So of course,
Dr.
we have
Gargi, would
to
you
have
just
time.
want to, re-inform our colleagues what exactly was the subgroup of patients they?
Yes, ma'am. So in this study also they are saying that not everybody requires bridging radiotherapy or bridging treatment. Only patients where we are worried about the rapid disease progression during that CAR-T manufacturing, so those require bridging treatment. And the other options of bridging treatment could be steroid or chemotherapy, like Sir said, but RT seems to be superior than other bridging therapy options because it gives rapid control, especially in these subgroup of patients where we have bulky or symptomatic disease.
Dr. Sarin, since you have been doing CAR-Ts, what potential synergy do we expect with such regimens?
So, I mean, see, it's a new field. To be honest, I mean, for me to answer, I have to use this in my practice and only then I'll be the right person to tell. But conceptually and hypothetically, and obviously the phase 1 and 2 data do suggest that, there is an evolving role of radiation. But I think times are going to be very interesting. Let's see how we can incorporate. For the time being, I have not been able to use radiation as a bridging till today.
Any experience of CAR-T along with RT?
Yes, plenty. So
please
we have used RT for cytoreduction plenty of times. And as the panel was, pointing out that it's a ambiguous dose of 20 to 40 gray. That's how it is, because CAR-T is more like, the product is landing on this date, so let's do whatever we can in this much time. That's what it is. Then some patients have a very large disease. Some patients' disease is not that large. Some patients have more symptoms, so you are more worried. Lately, we did a patient who had a retroperitoneal huge lymph nodes chain, which was very close to the kidney, and that we could do MR-Linac on it because it was just close to the kidney. So the point that I'm making is that, as Aditya very rightly said, that see, any bridge therapy that we use, say HCC bridge therapy, it's more about maintaining the stage, so that the transplant eventually happens. But actually in this situation, you want cytoreduction. And the lesser the number of cells in the system, the better will be the benefit of CAR-T. The hematologist will probably confirm.
Anyway, and do we have more people who had an experience of it?
So it's a simple.
Peri-transplant is something, pre-transplant as well as post-transplant is more often considered. I don't have experience of CAR T cell.
Post-transplant, maybe. I mean, this is eye-opening as well. In the previous study, post-transplant also you're using radiation. It's actually a good idea because sometimes, even after CAR-T, ma'am, you may have seen that only that one site is still smoldering. So maybe even post-transplant is a good idea. I mean, actually, this previous one was eye-opening that way.
Gagan, it is not only about cytoreduction, it is also about immune priming now.
No, but not in CAR-T cell, ma'am. Not in CAR-T cell.
So, ma'am,
CAR-T cell, the concept is totally different.
Gagan sir, So one simple situation, patient is having a single isolated group of lymph node, let's say abdominal nodes. I am very comfortable, let's say now I can think about, if my CAR-T product is coming late, I can ask, till the time you focus radiation, till the time we get the product. That is one concept. Now let's say simultaneously, patient is also having axillary, supraclav, the classical Hodgkin or sorry,
Definitely not
DLBCL is there.
recommending to use priming this radiation for every case.
So-
I'm not using.
No, no, I'm
It's
asking,
one thing in your armamentarium. That's
is there a
all.
way, is there a way to incorporate RT if there is a multinodal or extra skeletal involvement, or is there, it has to be an isolated nodes? That's the question which I want to.
So for in that situation, I would actually ask you that, okay, in this case, if you have exhausted all lines of therapy and you are relying solely on CAR-T and there is say 15-20 days before you give CAR-T, then I can incorporate radiation therapy to all these sites. I can definitely do that technically. Most of our radiation oncologists will concur. But yes, if you have a good systemic therapy which has a sufficient evidence backing and you would like to use that as your bridge therapy, please go ahead. So RT's radiotherapy is like one more thing in your armamentarium actually.
Absolutely.
Yes.
So in the study which Gargi presented, patients who had extensive nodal involvement, they just radiated the bulky disease. They did not touch the rest of the disease. But when they did the split 3 gray, then they gave 3 gray to the entire nodal station. So bringing 30 gray to the bulkier disease and 3 gray to the entire thing. So time is up, and as an organizer, I will not oversee it. I thank you all for your presence and a great discussion. Please come here for a group picture, and over to you.
But one thing I would request all the radiation people that, yeah, you people start total marrow irradiating. Because nowadays we will start very tedious thing, but
Transplanters make us work very hard. Very, very hard. And the only concern is TBI and TMLI packages are meager and effort is enormous.
Thank you, ma'am. Thank you, everyone. Our next scientific session focuses on lung cancer and thoracic malignancies. And for that, may I invite our esteemed chairpersons to kindly take their places on the dais. Dr. Denny Gupta, sir, Senior Director Medical Oncology, Max Hospital. Dr. Manoj Sharma, sir, Director Radiation Oncology, Venkateshwar Hospital. Dr. Vikas Chaudhary, sir, HOD Radiation Oncology, Manipal Dwarka. And Dr. Garima Singh, ma'am, Principal Consultant at BLK Max Hospital.
So the next session is the lung cancer. So may I invite Dr. Namita Patange? Dr. Namita? And she will be speaking on 10 years outcomes of the revised STARS trial comparing radiation and surgery for early stage non-small cell lung cancer. Over to Dr. Namita.
Good morning, everyone. Thank you for having me here. I'll be presenting the 10-year outcomes of the revised STARS trial comparing SABR with surgery for early stage NSCLC. In the last decade, we have seen that operable stage 1 NSCLC, we have seen satisfactory efficacy and safety relative to surgical resection in the following trials mentioned here. But two questions still remain pertinent. One is regarding the recurrence and the other is regarding the quality of life of the patient post-SABR. So the revised STARS trial had two cohorts. The first was a single-arm, single-institution phase 2 clinical trial for SABR, in which we gave 54 grade 3 fractions to the peripheral lesion and 50 gray with a boost of 60 gray to the gross tumor in 4 fractions for central tumors, and a prospective single institutional observation cohort of the WATS lobectomy mediastinal lymph node dissection arm for clinically stage 1 non-small cell lung cancer. 80 patients were enrolled in both the arms, and they were matched according to the propensity scores, which included the age, the tumor size, the histology, performance status, and the interaction of age and sex. The primary endpoint was overall survival, which had a pre-specified non-inferiority comparison with a hazard ratio margin of 1.965. The SEVIA trial, this was the following eligibility criteria. The surgical cohort was matched for the same, and there was no nodal or metastatic disease seen, and the candidates were operable in both the arms. To investigate the long-term quality of life and financial toxicity, 2 questionnaires were uploaded, and they were the SF12 version 2 and the cost questionnaire. Patient characteristics, primarily both in age, the age in both the arms was 68 mean age, and female and male distribution was similar, performance status was similar, adenocarcinoma distribution was similar, about 80%, and the tumor size was less than 2 centimeter in both the arms. And as you can see, the p-value was not significant. That means the 2 arms were comparable, and the median follow-up was 8.3 years. In the SABRE arm, all the patients underwent EBUS, and in the lobectomy arm, only a quarter of the patients underwent EBUS. Pathological nodal staging was done in the lobectomy arm, and adjuvant therapy was delivered in the lymph node dissection lobectomy arm, whereas 8 patients received adjuvant chemotherapy and 3 patients received adjuvant chemoradiation. Now, coming to the acute toxicity, as we can see, there is a drastic comparison between the 2 things. SABRE, there was only 1% of pulmonary cardiovascular toxicity, whereas there was a 50% toxicity seen in the lobectomy arm. Overall survival, the 10-year overall survival in the SABRE arm was 69% and 66% in the lobectomy arm, with a hazard ratio of 0.77 and p-value of 0.4, which was non-significant. So they both fit below the inferiority margin. So SABRE was comparable to the lobectomy arm in case of the 10-year overall survival. Coming to the lung cancer specific survival, the 10-year lung cancer specific survival was 92% in the SABRE arm and 89% in the WATS arm. And the hazard ratio was 0.95 with a p-value of 0.928, which was also non-significant, and it was comparable for both the groups. So SABRE was non-inferior to lobectomy for even lung cancer specific survival. Recurrence-free survival, the 10-year recurrence-free survival was 57% for the SABRE arm and 65% for the lobectomy arm. Although the hazard ratio was 1.17 and the p-value was 0.5, it was not significant, but we would like to dwell further on this. The recurrences, local, regional, and distant. The local, there were 16 events that were seen in the SABRE arm and 8 events that were seen in the WATS arm. And in the SABRE arm, majority of the recurrences were local and loco-regional, and distant metastasis was similar in both the cohorts. Results, among the 9 patients, as you can see, total of local, loco-regional, and regional, there were total 9 patients in the SABRE arm who developed loco-regional recurrence in the SABRE arm, and 5 were treated with salvageable chemoradiation, 3 underwent surgery, and 1 was re-radiated with SABRE. And among the 2 patients who had local regional recurrences in the lobectomy arm, 1 was treated with chemoradiation and 1 with systemic therapy. Coming to the quality of life questionnaires, almost similar number of respondents had responded to the questionnaires. The questionnaires were mailed, as well as the questionnaires were telephoned to the patients, and equal responses were observed. The 3 scores were obtained: the physical component score, the mental component score, and the cost total score. The scores were relatively from the low to the mid region, and the p-value was not significant for any of them. So the take home points: Though the 10 years follow-up, there is no significant difference between the SABR and the lobectomy arm in case of the overall survival, the cancer-specific survival, and the recurrence-free survival. Although I agree that yes, recurrence rates are higher in our patients, in the SABR patients, but we still have effective salvageable therapies that will give the patient a second chance of potential cure. Although the acute toxicity rate in the surgical arm is very huge compared to the SABR arm, the impact is there is no difference in the impact in the terms of quality of life or financial stress in both the arms. So SABR still remains a legitimate option for stage 1 operable non-small cell lung cancer, and a multidisciplinary discussion including the patient is strongly recommended.
Thank you, Dr. Namita.
Thank you.
And now we move on to next talk by Dr. Soumya S., a radiation oncologist, talk about newer TKI molecule and lotinib, how they are trying to club with whole brain RT in brain metastasis and NSCLC. Yeah, Dr. Soumya.
Good morning, one and all. I thank the organizers for this opportunity. So, abstract for today will be the use of anlotinib combined with whole brain radiotherapy for brain metastasis in patients with small cell lung cancer. It's a single arm phase 2 trial by Shang Liu et al. So the background of this study is that we all know approximately 15% of small cell lung cancer patients experience brain metastasis at the time of diagnosis itself. And those patients with concomitant brain metastasis generally have a poor prognosis with a median survival of just 4 or 5 months. So whole brain radiotherapy is regarded to be the standard treatment and has been proven efficacious by prolonging survival by 7 to 9 months. And the background of anlotinib, it is a multi-targeting tyrosine kinase inhibitor. It's a small and a hydrophobic molecule. It may cross the blood-brain barrier. So some of the anti-angiogenic effects are it's thought to effectively shrink tumors, reduce cerebral edema, decrease the radiation-induced brain necrosis, and of course enhance radiotherapy efficacy. So anlotinib and whole brain RT may be a preferred treatment option. So the background of this study was like the ALTER 1202 trial, which evaluated the efficacy and safety of anlotinib in patients with small cell lung cancer as a third line or subsequent treatment. So this background study included patients with from 18 to 75 years with small cell lung carcinoma histology confirmed, and those patients who had progressed after or at least 2 lines of chemotherapy with a good performance status ECOG up to 2 and 1 measurable lesion. So in that study, they had actually given anlotinib 12 milligram OD day 1 to day 14 every 21 days per cycle until progressive disease, with another arm of patients having a placebo, was given a placebo of the same dose. It was continued until intolerable toxicity or progressive disease. So as you can see in that study, the Kaplan-Meier survival curve was quite wide. They could when anlotinib was used as a third line treatment, it demonstrated a good overall survival and PFS benefit of around like 3.8 months, and the PFS benefit was around 6.1 months. So with the background of this thought in mind, they have designed a trial, a prospective phase 2 clinical trial to explore the efficacy and safety of anlotinib with whole brain RT in small cell lung cancer patients presenting with brain metastasis. So the study design goes like this. More than 18 years of age, good performance status with brain metastasis, should have completed at least 4 cycles of first line chemotherapy, and less than or equal to 10 metastasis. It excluded those patients who had received anti-angiogenic therapy in the past 1 month. So it included some 40 good patients. The single arm study, it gave anlotinib to the same dose, but it started 2 weeks before the whole brain RT, and the whole brain RT dose was standard 30 to 37.5 gray in 10 to 15 fractions, and followed by continuing anlotinib after whole brain RT also until disease progression or intolerable toxicity. So the primary endpoint was intracranial progression-free survival, and the secondary endpoints were PFS, OS, and intracranial objective response rate, the disease completion rates, and the intracranial measurable disease response. So baseline characteristics were equally distributed, less than 65, more than 65 age patients, more of male predominance, good performance status, more of smokers, and 65% of extensive stage small cell lung cancer carcinoma patients. Other extracranial metastases were also present. And obviously, there was a previous line treatment was either chemotherapy or immune checkpoint inhibitors with a combination. And so the results of the study, so they saw for a median follow-up of 28.9 months. The intracranial progressive disease or death was seen observed in 34 out of 40 patients. And the median intracranial progression-free survival was 9.9 months. And if you see the progression-free survival, overall progression-free survival is 6.6 months in this group of patients. And the overall survival is also increased to around 14.6 months. And if you see this intracranial objective response rate was around 72.5%, intracranial disease response rates were 95%, and the intracranial duration of response was around 12.8 months with a confidence interval of 8.8 to 21.4 months. So common side effects, what they encountered, but they didn't encounter any grade 4 toxicities, not much. I mean, no recorded toxicity. The grade 1 or 2 toxicity or grade 3 toxicity, commonly the fatigue and hypertension. Others like proteinuria, leukopenia, and whole brain RT related is all the reasonable, the routine ones. So with a median intracranial PFS of 9.9 months, this is quite higher than the previous studies with whole brain RT alone. So it led to a discussion that with a median good PFS benefit showed superiority compared to the ALTA trial, which had only 3.8 months, which was without whole brain RT. So the median overall survival in our study was 14.6 months, and it also is quite higher compared to the whole brain RT alone. So they concluded that the combination of anlotinib and whole brain RT shows a promising therapeutic strategy, demonstrating encouraging efficacy and a manageable safety profile in those patients with small cell lung cancer accompanied by brain metastasis at presentation. So these findings support the need for further validation through phase 3 trials, randomized trials to confirm the efficacy of this combination. Thank you.
Thank you, Dr. Soumya. The next lecture is by Dr. Manoj Tayal, and he will be speaking on differential survival benefits of post-operative radiotherapy in AGCC 9th and ISLC defined N2 non-small cell lung cancer subtypes, a multi-center real-world study. Over to Dr. Manoj.
Thank you, Chairperson. Thank you, organizers, for giving us this opportunity to present this study here on this dais. So I'll be presenting on efficacy of PORT for patients with 9-stage N2 descriptors in completely resected NSCLC. It was a multi-center real-world study done in China in mainly three hospitals over a period of 15 years. And it was presented by Zeliang Ma. So there are no disclosures here. So the background of the study was the post-operative trial Port C and Lung Art, published in 2021. And these two trials did not show any statistically significant improved overall survival in post-operative radiotherapy for non-small cell lung cancer. So the authors, in the continuation of the background, the 9th AGCC staging system further subdivide stage N2 into single station metastasis N2A and multiple station metastasis N2B. The IASLC made more detailed N2 classification, the single station N2 mets without N1 involvement, that is skipping N2A1, and single station N2 mets with N1 involvement, that is N2A2, and N2B is already known. So the inclusion criteria was the patients diagnosed from 2004 to 19, PN2 stage NSCLC, no distant mets, underwent lobectomy or pneumonectomy, and the subgrouping was done. So based upon, these patients were received post-operative radiotherapy, around 790 patients out of total 3,000 patients, and rest of the patient did not receive any RT. And the endpoints were OS, DFS, LRFS, and they were to be analyzed by using Kaplan-Meier multivariate Cox regression analysis. So this is quite a busy slide. Just the details of the patient here. Around 3,122 patients. Port received in N2A1 patients in 117, N2A2 patients 258 patients, and in N2B around 417 patients. So if you look at the results, the efficacy of port in N2A1 subgroup, no port versus port, the median OS, it was 91.9 months in the no port arm, and it did not reach any median in the port arm. And the median DFS, the median DFS was 34.9 months in the no port arm and 34.1 month in the port arm, and 79.6 months median LRFS, and it did not reach the median in the port arm. The statistical significance did not reach for the median OS and the DFS, although it was significant in the LRFS. Even in stage N2 N with the nodal involvement of N1 station, the median OS, median DFS, and the LRFS, they were all statistically significant. Even in the N2B subgroup, the median OS, the median DFS, and the LRFS, they were all statistically significant. But when the multivariate analysis was done for N2A1, already the significance was not there. So, but in N2A2, the multivariate analysis did not show any statistically significant improvement, but there was a definitive improvement in the N2B arm in both univariate and multivariate analysis. So the take-home message of this study was N2A1 single N2 station without N1, namely skipping. Although port can significantly improve LRFS, it does not improve their DFS or OS. The N2A2, that is single N2 station with N1, the benefit of port requires further investigation because the multivariate analysis did not show statistically significant improvement. And in the N2B, that is multiple N2 station, port can significantly improve DFS, OS, and LRFS. Thank you.
And the next lecture is by Dr. Rajendra, and he will be speaking on consolidative radiotherapy with osimertinib in advanced EGFR mutant non-small cell lung cancer, long-term local and intracranial control results from the phase 2 trial. Over to Dr. Rajendra.
Thank you, sir. Thank you, organizers, giving me this opportunity. So, as introduced by Dr. Manoj, sir, it is about consultative radiotherapy with osimertinib in advanced EGFR mutant non-small cell lung cancer. Long-term local as well as intracranial control results in a phase 2 trial with metastatic disease and no conflicts. So they try to check local control. They checked whether low dose SBRT is also as effective as high dose and assess CNS progression free survival in patients with and without baseline brain metastasis. So to begin, defining the oligometastatic patient in a disease with a highly potent first line systemic agent, Do we limit local control to patients who present with limited, which means less than 6 number of disease sites at diagnosis, or include more than 6? Do all initial metastatic site require radiation at the time of consolidation? And what ablative doses it need to control local as well as metastatic site? Can controlling primary and extracranial metastatic site extend CNS progression-free survival? Are there subgroups of patients who may benefit from a simple upfront strategy of osimertinib and RT instead of multi-agent drug regimen with higher toxicity? So in this study, they begin with osimertinib 80 milligram once daily. They have given around 8 weeks. Then they did imaging, and based on the imaging, they have given radiation to the persistent lesions in various doses. We'll discuss in next slide. And asymptomatic CNS mets not treated. And after radiation, this osimertinib was continued till progression or till side effects. But additional radiation was allowed after oligoprogression sites, which is defined around 6 or less than 6 different sites. CT, PET-CT was done to check it, and 32 patients they received radiation, and osimertinib was on hold during radiation for all patients. So coming to the radiation regime, which was commonly used, so 35 gray in 5 sittings, 34 in 5, 30 in 3, 45 gray in 15 fractions, even 24 gray in single fraction, 30 gray in 5, so and so. And these were different sites, and these are the doses, 20 gray in 1 fraction, 24 in 6. So you can see radiation doses was highly variable. And RT was even given before enrollment in the study. These were few sites like bone, iliac bone, whole brain, brain SRS, femur, spine. And after this palliative RT or SBRT, patients were enrolled in the study. Brain metastasis at baseline, around 50% had baseline brain metastasis. None received brain radiation at the consolidation time point. But if you see around number, they have not disclosed, so they have just disclosed the radiation. Local control rate, median follow-up 43 months, 3-year lesion specific local control was 84%, which is highly impressive, with 5% rate of grade 2 or more pneumonitis. And local failure has happened, and in one patient where radiation was given in the dose of 30 gray in 10 fraction, right axilla, 45 in 15. This was the dose. These are the patient where after radiation patient progressed. CNS progression free survival, all patients median time not reached, no baseline mets in 21 patients, and median progression free survival not reached in these patients who had no baseline metastasis in the brain. With baseline metastasis in 21%, median progression-free survival 30.2 months, and oligoprogression happened in 13 patients. Median time to out of study after completing oligoprogressive was 7.2 months. And if we compare the doses of SBRT light for other studies like SINDAS, PENG, lung, SORT to the current study, so you can see that around median follow-up of 35.7 months, which is longest, progression-free survival 32.3 months, and overall survival 45 months in this study, which is higher than the previous reported studies. It may be because they used third generation versus first generation, and they did consolidation at later time, maybe with lower disease burden at the time of RT. So if we see CNS efficacy compared to multi-agent regime where they have given multiple drugs, so median follow-up of 43 months and median CNS progression-free survival has not met, with median CNS PFS brain mets at baseline 30.2 months, which is very good. So SBRT light regime, lower BD of around 60 gray, which is 30 to 35 gray in 5 fractions, provide excellent local control as plant consolidation approach. And such regime provide favorable therapeutic ratio, especially to central mediastinal structure, worse outcome associated with hypofracture regime, and acceptable CNS and local control in this study. Thank you so much.
Thank you, Dr. Rajendra.
Thank you, sir.
And the next lecture is by Dr. Amita. Dr. Amita, and she will be speaking on mid-treatment circulating DNA to predict outcomes in stage 2B3C non-small cell lung cancer treated with MRI-adapted chemoradiation. Over to Dr. Amita.
Good morning, one and all. Thank you, Kanika ma'am, for giving me this opportunity today. So I'm going to speak about the role of circulating tumor fraction estimate in stratifying risk in locally advanced non-small cell carcinoma. And it is based on the trial that was done by Hashmi et al., which was a multicentric prospective trial, and they evaluated pre and mid treatment CTFE to stratify risk in MR-guided hyperfractionated chemoradiation in locally advanced stage 2B and 3C non-small cell lung carcinoma. So there were 3 objectives of this trial. First, to evaluate the baseline CTFE so as to compare detectability versus CT burden, which can be used as a prognostic marker, and then to compare CTFE versus maximum variant allele frequency for prognostic utility. The second objective was to evaluate whether CTFE remains to be a prognostic marker in the mid-treatment, and if it could be used for classifying molecular responders. And third was to assess generalizability of pre-treatment CTFE stratification in 2 independent real-world cohorts. So first, coming to what is CTFE. It is a clinical deployable estimate of tumor fraction. It is a machine learning composite score that estimates tumor burden from a single blood draw. It is an amalgamation of various cell signals, including germline variants and copy cell variants. And the value of the CTFE, it ranges from 0 to 1. Higher value means higher higher tumor burden. So in the study, 26 patients who had stage 2B or 3C non-small cell lung carcinoma, they were treated with hypofractionated chemoradiation, and they had a consolidation treatment with durvalumab, and their blood samples were taken pre-treatment and mid-treatment, that is at the completion of 14 days. So here it is to be noted that though blood was taken in the beginning of the treatment and mid-treatment, but the results were only analyzed retrospectively. Hence, the CTFE value, they did not guide the treatment. What we observed was patient with a low baseline CTFE did do well in terms of both overall survival and progression-free survival than the patient who had higher baseline CTFE, and these patients who had higher CTFE, they invariably had an early relapse and death from the disease itself. In this graph, we can see there is a wide separation between the 2 curves, the blue representing the lower pre-treatment CTFE and red representing the higher baseline CTFE. So the patients with lower CTFE, they had a better overall survival of around 60 months versus 10.5 months, and better PFS of 23.1 months versus 2.4 months. Hence, the baseline CTFE can be used as a prognostic marker to stratify patients at the starting of the treatment. Not to see whether just the detectability of CT burden is enough to stratify patients, but it is not so, because just the detectability does not significantly stratify overall survival or PFS at baseline. However, high burden ctDNA strongly stratifies both OS and PFS. So this stratification is more robust when the stratification is based on tumor burden rather than just presence or absence of CTFE. Similar findings were seen in the study done by Moding et al. And Black et al. Now coming to mid-treatment CTFE, So in patients who had a lower mid-treatment CTFE, they also did better than the patient who had persistently high mid-treatment CTFE in terms of both overall survival and progression-free survival. So what inference can we draw from here is that we get in 3 weeks we can know which patients will do worse, and their treatment can be adapted and they can have a more aggressive systemic therapy. So the mid-treatment CTFE, they classified patients into those having consistently low CTFE, and then molecular responders who had a drop of more than 50% below threshold, and non-responder who had a drop of less than 50%, and the responders did worse. Now, pre-treatment CTFE was generalized across 2 real-world cohorts, that is a local advanced disease and oligometastatic disease. And in both these cohorts as well, we can see that higher CTFE was related to a worse overall survival in both locally advanced and oligometastatic cases. And CTFE outperforms maximum VAF because it has more it more robustly captures the tumor burden, and it is an amalgamation of various cell signals. So the take home point is that the CTFE is a scalable and assay that does not require bespoke tumor informed MRD build, and it can be evaluated both at baseline as well as mid treatment so as to stratify patients into low risk or high risk category, and then the radiation dose of hypofractionation can be delivered safely, but the distant failure is more dominated by the biology of disease and not the dose of the treatment. And these can be used for further trials for risk stratification in both locally advanced and oligometastatic diseases. Thank you.
Thank you, Dr. Amita. And now we can move on to last abstract of this session by Dr. Aitangni Bishwas. And it's on sequential chemoimmuno along with thoracic RT versus only RT in stage 3 NSCLC in elderly and frail patients.
Thank you. Good morning again. So the title of the abstract is sequential chemoimmunotherapy followed by standard versus reduced dose thoracic radiotherapy for elderly, frail, stage 3 non-small cell lung cancer patients. A randomized open label cohort trial. This was basically conducted at Shanghai in China. Author disclosures. About 1/3 of the patients with non-small cell lung cancer, they present with locally advanced disease, and treatment requires very intricate multidisciplinary discussion, especially for elderly frail patients. For unresectable stage 3 non-small cell lung cancer, the current standard of care is concomitant chemoradiotherapy, followed by durvalumab maintenance or osimertinib maintenance in the presence of EGFR activating mutations, as evidenced by the Pacific and the LAURA trials, respectively. However, the elderly frail patients are underrepresented in most of the phase 3 trials. The age at presentation typically hovers between 55 to 65 years, and the real world scenario is very, very different, as we all know in our day-to-day practice. So what could be the mitigation strategies for such vulnerable patients? So as supported by the Pacific 6 study, sequential chemotherapy, radiotherapy, and in the absence of progression, durvalumab for a period of 2 years could be one of the options. If the patients are unfit for chemotherapy, then radiotherapy with concomitant and maintenance, durvalumab can again be an option as based on the results of the Dolphin trial from Japan. If we focus our attention on the subgroup analysis of the Pacific trial, we can understand that the dose of radiation did not significantly impact the benefit offered by durvalumab. And this perhaps inspired the study designed at Shanghai in China. So this is the premise of their study, which we have already discussed. So these vulnerable patients with stage 3 non-small cell lung cancer, they were offered chemoimmunotherapy. So the regimen was quite heterogeneous, 4 to 6 cycles of chemotherapy. This basically consisted of a platinum with variable partners. It could be in the form of etoposide, paclitaxel, docetaxel, or pemetrexed. The immune checkpoint inhibitor could be an anti-PD-1 or an anti-PD-L1 agent, and these patients were subsequently randomized in the absence of progression to cohort A, which was the standard dose thoracic radiotherapy, 60 grays in 30 fractions, versus the reduced dose, that is 50 grays in 25 fractions, with concomitant immune checkpoint inhibitor, and this was followed by further maintenance IO for a period of 6 months or unacceptable toxicity or disease progression. The primary endpoint was basically 1-year progression-free survival. The co-secondary endpoints were 1-year overall survival and grade 3 or higher acute toxicities. The inclusion criteria: patients more than equal to 18 years of age with ECOG performance status of 2, or more than 70 years of age with an ECOG performance status of 0 to 1, or more than 65 years of age with a Charlson comorbidity index of more than equal to 1. These patients were supposed to have a life expectancy greater than equal to 3 months and a body weight more than 30 kilos. So this is the trial profile. 66 patients were enrolled and then 56 were subsequently randomized, 28 to standard dose radiotherapy and 28 to reduced dose radiotherapy. And some of the patients, they refused maintenance immune checkpoint inhibitor. So these were the patients 27 and 26 who were analyzed per protocol. The baseline characteristics were fairly well balanced between the two arms. However, we can see a predominance of squams in reduced dose RT and more patients with ECOG performance status 2 in standard dose thoracic radiotherapy. The chemotherapy regimen, which was extremely heterogeneous, surprisingly, there was higher clustering of platinum and pemetrexed in patients receiving reduced dose thoracic RT. Most patients received 4 cycles of chemoimmunotherapy, and approximately 90% of patients received anti-PD-1 immunotherapy. This is the list of comorbidities. The most common comorbidities, as expected, were hypertension, COPD, and cerebrovascular disease. So this is the per protocol analysis, Kaplan-Meier curves of progression-free survival and overall survival. I think the curves are splitting and they're favoring the standard dose thoracic radiotherapy arm. The 1-year progression-free survival was 82.9% versus 73.4%, favoring the standard dose radiotherapy arm. However, the p-value was statistically non-significant, and which is not surprising taking into account the small sample size. The 1-year overall survival stood at 92% versus 84.7%, again the p-value being non-significant. These are the same analysis, but in the ITT population, and we can see again the curve splitting, favoring the standard dose thoracic radiotherapy arm. The 1-year progression-free survival and overall survival values were numerically superior to the reduced dose radiotherapy arm, but the p-values were statistically non-significant. Now, switching gears and moving to patterns of recurrence, we can see there was a higher incidence of local regional radiotherapy, almost a doubling of the same from 18% to 40% in reduced dose thoracic RT arm. A total of 26 patients experienced disease progression, and most were local regional progression, and we have already highlighted the difference. This is the swimmers plot depicting the duration of immune checkpoint inhibitor in the maintenance phase, and roughly around 60% patients completed 6 months of therapy. Treatment-related toxicities, there was a higher incidence of grade 3 and grade 4 acute toxicities, 57.1% versus 82.1%, more so in standard dose thoracic RT arm. Important to note that grade 5 mortality was 1 versus 3, and 2 patients died because of hemoptysis and 1 patient died because of acute myocardial infarction in the standard dose thoracic RT arm. So the limitations, this is a single arm design. The research hypothesis was conspicuously missing in the available slides. And though the patients were randomized, there was no direct comparison between the standard dose and reduced dose thoracic RT groups. small sample size, and an extremely heterogeneous chemotherapy and immunotherapy regimen, as already alluded to. So, in conclusion, sequential chemoimmunotherapy followed by radiotherapy and concomitant IO followed by maintenance IO is effective in elderly frail patients with locally advanced non-small cell lung cancer. Reduced dose thoracic RT did not significantly compromise the survival, and it showed a trend towards a more favorable adverse effect profile. However, there is a concern about increased incidence of local regional recurrence in this cohort. So this approach indubitably needs further validation in larger phase 3 trials. So thank you very much for your kind attention.
Thank you, Dr. Yeah. So I think next is a panel discussion. Dr. Gagan.
I would like to invite Dr. Gagan Saini, sir, Vice Chairman and HOD Radiation Oncology, Yashoda Medicity Hospital, Indirapuram, to moderate this session, and all the panelists, Dr. Ahitagni Biswas, sir, Dr. Namita Patanj, ma'am, Dr. Rajendra, sir, Dr. Soumya, ma'am, Dr. Manoj Tayal, sir, Dr. Amita Ambasta, ma'am, and Dr. Raman Narang, sir.
Dr. Manoj is also there. Okay, so lovely. Thank you. Good morning, everyone, and thank you, organizers. Thank you, chairpersons, friends, everyone. Let's start with the panel discussion. I don't know what is the topic of the panel discussion insofar as ASTRO has given, but I do feel that all the previous issues with radiation therapy are being gradually mitigated, and I welcome the esteemed panelists. We start with the first paper, and this was presented by Dr. Soumya. Dr. Namita, this was the STARS trial revised, data. And you clearly showed that insofar as the survival is concerned, it is quite similar. Insofar as the cancer-specific survival is concerned, it is quite similar and also quite high. And recurrence-free survival is also as expected in the real world. So I ask you the question, after 10 years follow-up, would you now consider radiation therapy to be absolutely at par, SBRT that is, to be absolutely at par with surgery? You can use the mic, you have it, yeah.
Yeah, sir, I actually feel this SBRT is at par with surgery, and by considering SBRT, we can reduce the hospital stay and reduce the post-operative complications. That 30-day complications, the 90-day mortality will be reduced, and the patient goes walking home every day.
So you feel SBRT. Dr. Denny, would you refer your next small primary lung cancer, non-small cell lung cancer for SBRTs, considering this paper is showing very clearly that the benefit is similar?
So I think as of now, those who are not willing for surgery, because patients usually have a reluctancy for surgery.
Yes.
And those who are, I think, less than 3 centimeter tumor size and lot of comorbidity, diabetic,
So you will
hypertension, cardiac.
send straight for SBRT.
So in select subset, as I said, comorbidity.
No, but in this paper, it's very clear that because the STARS cohort had operable patients, they were actually operable. So
I think it's yet to come into routine practice.
So doesn't that make you think at least about changing the practice?
So we can try. In fact, it's after 10-year follow-up they are showing. Although I think it's a long back. It was initiated this trial.
Yeah.
And yeah.
Okay, so what is the other weakness? Other panelists can join in. What is the other weakness in this data which is making the medical oncologist still reluctant? If such a paper would have been in medical oncology, on Sunday only you would have given that chemotherapy.
So trial I can refer to both surgeon and radiation.
So since long time we are doing SBRT in stage 1 and having very good results without any major morbidity and I'll say almost negligible mortality. So it has edge over surgery, but in young fit patient, it gives a detailed pathological report, nodal status that goes in favor of surgery. So it depends upon the decision in multidisciplinary tumor board.
Perfect, perfect. So what you are saying is that the surgical benefits, they are there and they can be should still be exploited. So back to you. What do you think? Concurs with the study findings with what Dr. Rajendra just said. You presented it.
Yeah, I truly resonate with what he
Yes.
says that if there is a young patient, yes, we should undergo a
So basically,
detailed.
what you presented was that there was a higher rate of locoregional failure
Yeah.
in the cohort of SABR,
Yes.
and that was, though it was not making that much difference, but it was
Yes.
slightly there. So what
Yes.
both of them are saying could actually be considered correct.
Yes.
That there is still some benefit, but for the least reluctance, we can switch to SABR now. We don't have to look for medical
Gagan,
reluctance.
can I make a point here?
Yeah, please.
So at the time of SABR, so this is 10 years, they were not doing, mediastinal endoscopy or mediastinoscopy to
I
see
think
whether
they must have been doing.
No, they were not doing that time, number one. Number two, if you see the results in the operated patient, a couple of them got chemorad, a couple of them got chemotherapy, which of course none of the SABR patients got.
So
And
I
then there
fully agree
was
with you.
more side effects. The side effect profile was
post
worse. That
the
was
post-operative
50%.
morbidity
Yeah,
was quite high, up to 50%, I think, to a tune of.
50% versus 1. So 1%.
Very nice points. So, so what she is saying is that if you stage your patients correctly, maybe you can reduce the locoregional failure. I actually tried to look for it. I wonder where you got this data. I actually tried looking for it, whether they actually staged the mediastinum. Then I thought they must have. Brilliant. So
Exactly.
they haven't
Your
staged the
selection
mediastinum.
should be very ideal. Like you are, because we are not addressing the mediastinum, so your selective cohort of people for SABR
Look,
should be
in
very.
any case, the patient doesn't remain suitable if the mediastinum is positive or anything like that.
So you be double sure that you don't have a node positive disease with EBUS and everything, and if you selectively
So,
choose an
what-
ideal T1 patient, it should
Yes,
be fine.
yes, totally agreed. So what Dr. Charu just pointed out was that, very selectively, this thing. I would also want to add that there are group of patients who are early lung cancers who are likely to have more morbidity, even though their Charsal comorbidity index may be still adequate, and that is the more central lesions. They have a much, much higher mortality than the lesions which are peripheral. So even those cases, I think in this, the light of this paper, should be seriously considered for SABR. This is what my thinking is. So, anybody else wants to make a comment? Ahit?
We do agree.
I think it should be a patient-centric decision making. It should be decided under the roof of a multidisciplinary clinic, and all the pros and cons should be appropriately explained to the patient and the caregivers, and then his or her opinion also
So
matters.
difficult question now. If any one of us, one of us can take this thing, themselves develop a stage 1A lung cancer, would you go for SABR or surgery?
So as a radiation oncologist, I'll go for SABR. The reason, non-invasive technique, you just have to properly stage your patient with available imaging, as well as if required, you do EBUS and FNAC.
Properly.
And then do proper maybe 4D CT scan, check the movement, and target your volumes properly and give ablative dose. More than 100 or 110 BD, I think I'll prefer as. But I'll ask Dr. Danny again whether he will send to me or not.
Dr. Denny, we ask you
यार
to.
तुमने क्वेश्चन बड़ा अजीब सा फ्रेम किया है. You yourself.
Boss, I'll ask you a simpler question. I will ask you a simpler question. What everybody said was that after surgery, there is protocol for adjuvant chemo also sometimes, adjuvant RT also sometimes, chemo many times, and so on and so forth. So it's basically an adjuvant, tailored adjuvant treatment. Isn't it time to do these trials of some sort of adjuvant treatment for SABR patients? I mean, what is stopping us from doing adjuvants in SABR patients? There are papers, we say, but properly designed studies where, you add something adjuvant, look for biomarkers or something like that, or maybe adjuvant patients in those who were not worked up for mediastinum or something like that. I think that is also one of the very important concerns since the science has evolved to this point today. What do you think about that?
I think we have tried SABR also in some of the patients, but although in those patients we were reluctant or very small lesion as of now, right? But like your question, if we have properly staged and patient has any peripheral lesion, so definitely it is a quite like equivalent options, not an issue with that.
Yeah, it is an equivalent option. I mean, we must start
Agreed.
considering it as an
Agreed.
equivalent option.
Peripheral lesion with no nodal this thing
yeah.
and properly staged, we can go for that.
But
not an issue.
with that said, I must also point out that these are not randomized data. These are propensity matched surgical cohorts. And, you know, it's always best to have randomized data. But yes, it is coming again and again equivalent since so many years. And now 10 years also it's equivalent. So there is some merit to it. Type 2 error is in statistics, if it is, you know, if happening again and again, then, you know, it's possible that it's not there. So let's see. So let's quickly shift to the N2, which we have been debating for different forums for more than a decade now, that N2 is whether radiation should be given or not. Some people say N2 radiation should be given. So, and ART, you know, kind of solved it. So, but then in N2A1 group, there was a benefit in loco-regional failure rates, statistically significant benefit. In N2A2 group, you know, there was benefit in all parameters. And in N2B group, also there was benefit and it was numerically much larger. So what are this N2A1, A2 and N2B? So N2B is multi-station N2, simple. Multi-station N2 was always one of those, you know, for radiation. And N2A2 basically it's an N2 because of mediastinum, but then one of the nodes is actually in the N1 region. And N2A1 is only a single station mediastinal node, and there is no other lymph node as far as the staging is concerned. So N2A1 also is having loco-regional failure-free benefit. So with this said, I wish there were some surgeons also here, because we radiation oncologists have believed for a long time that it will ultimately help. But let's ask, you know, you had presented this paper, right? Boss, you had presented, of course. Yes. So what do you think? Would you push for changing the practice, or is there something more that you would like to be, you know,
See,
fulfilled?
the question about adjuvant treatment, when we add radiation, because we have to do a risk stratification, as in this study also, like the previous two post-operative radiotherapy trial did not show significant improvement in the overall survival. But when you do a further risk stratification, even in these N2B subsets, so the higher risk patients will still have benefit of adding radiotherapy, whether I mean, in addition to the immune checkpoint inhibitors or other adjuvant treatments. So you should always consider adding radiotherapy in these higher risk patients.
Perfect. So this patient is there, Dr. Manoj, 58-year-old and R0 resection is N2B now with 3 mediastinal stations, 3 stations. Adjuvant chemotherapy is completed. So would you want to do PORT and why? Maybe this question I should ask you and then Dr. Denny also.
So yeah, that's what I've answered. This is a multi-station lymph node involvement, so I will advise him post-operative radiotherapy.
You would like to advise post-op radiation. Dr. Denny, are you convinced enough, or do you think?
Two scenario, patient has gone like Asian trial type of patient, immunotherapy upfront, along with
immunotherapy
chemo.
upfront, yes.
Yeah, immunotherapy upfront,
yes,
along with chemo,
yes,
and then surgically resected,
yes,
and then adjuvant immuno,
yes.
So
all is
here I would not like to add radiation,
yeah,
despite being the multinodal station, because immunotherapy has shown benefit over and above chemo. If patient somehow is not able to receive immuno upfront, then of course we can go for this.
So in the current day, Haji.
So no, you have already done neoadjuvant, and still the patient has multi-station lymph nodes involvement. So the risk still remains. So you have to cover that risk. Yeah, even adjuvant also.
So, Dr. Denny, what he is saying also has a point. What you are saying also has a point. Let's hear what Dr. Charu
This
has
is
to
what
say.
even I was saying, your IO has not responded. You're still having N2B. So this is a subgroup clearly where the immuno has not worked. Even if you're giving adjuvant, when it has not worked in neoadjuvant, why do you think it should work in this? And the other thing is port may. I mean, if you see the subset of N0 and N1 nodes, it was quite a large one, or N2 with a single station. If I remember correctly, it was of 60 to 70% was that figure.
I remember now.
And even in N2 multi-station, they said that there was a loco-regional risk reduction, which I think most of the people, they don't see. It has been taken as a, just a statement that any patient who's got N2B post-op doesn't need radiation. But if you have your ENE, if you have your multiple station, if your neoadjuvant ke baad bhi the patient has not responded, I think these are the scenarios that we should
So
consider.
many a times, Dr. Denny said was something that is said by many medical oncologists, and it would be probably reverberated, around the world that now that immunotherapy is working so well, what is the point of radiation? It's not something that only he is saying, but herein lies one of the typical fallacies of oncology, that sometimes we feel one is enough, and we don't want to add two things together for better benefit. But this is something that not only you will say, many people will say this. But
any immuno-oncological trial, whatever they have been conducted world over, so they have taken all these points into consideration. Post-op, N2B, multinodal, and then they have proceeded with the adjuvant.
No, actually N2B, since is not a standard recommendation, it's not a standard adjuvant.
So like you are saying that all these trials, they have already taken these things into account. The port C and port R trial, they also had combined all. They did not subclassify N2A1, N2A2, and N2B. So, the difference here was about the improvement in N2B disease. So, like this, the subclassification has not been done in other trials also.
So I guess as being pointed out by everyone, that immunotherapy is reducing systemic failures, is doing quite well for locoregional disease also. Probably benefit of adding the two together.
Yeah.
Probably there is a benefit of adding two together. But yes, of course, it remains open to discussion. What about others? Anybody else wants to point out? So great. Let's move.
I
How
think
much time
in the
we have? 9
absence
minutes.
of a trial, in the absence of a phase 3 trial showing a benefit, clinical benefit, it is difficult to justify the use of radiation therapy just on the basis of this retrospective analysis.
Ma'am, I won't disagree, because what you're talking is science, but this targeted therapy in lung has been moving at very fast pace, and I don't know if any trial can actually sustain long-term controls. With
I think what Dr.
radiation.
Charu is saying makes sense, that if the patient is not responding well to immunotherapy and
Yes.
after surgery also
Yes.
the nodal burden is heavy, or if there is extra nodal extension, then you can have a case-to-case based discussion in MDT.
Yes.
But otherwise, universally, we cannot apply because the trial was negative.
So if there is an N2B which was subjected to immuno and has got pathological CR, then maybe we should just forget about giving radiation. And if it's an pathological N2B after surgery, after immuno and everything, then should consider. And any adjuvant immunotherapy should not be presumed to be a substitute for that, because empiricality is something. So great. So we go to the next paper, RT with osimertinib. This is Dr. Rajendra's paper. So Dr. Rajendra, what do you think about this practice? So would you do you always use SBRT light in general? Are you using slightly lower doses, or are you always trying to use the highest possible dose in your consolidative SBRTs after patients on osimertinib?
If I say without this paper, whenever there is this oligometastatic disease, so we try to push as maximum as possible, minimum 80, 90 BD. But if it is actually say single lesion in lung, single lesion in somewhere in bone, so we try to push proper SMBR with BD of say 100. But yes, with this paper we can reduce the doses. But I can say this is phase 2.
Lovely. So this is
But
a phase
one
2
point
paper.
is very good here.
Yeah. What is good? Tell me that.
In extensive metastatic disease, even 6 sites, they say 6 sites or maybe more, even with brain mets, they say you give osimertinib for 2 months and then take opinion with your radiation colleague.
Yes.
That is a very good point.
Yes.
And I will
What do you think
need
about
comments
that?
of Dr.
Every
Denny.
patient after 2 months getting consolidative radiation to all residual sites.
If we see the patients who are on osimertinib, take any 10 patients, 50 patients. So chances of local recurrence which we are seeing are not there most of the time. So which we are seeing failure of distant metastasis are there, not the local. So in light of that, I don't know how adding the local modality will help in metastatic setting. Maybe abscopal effect you can say, and it you can say, but we have 5 year, 7 year patients on osimertinib. So when they have relapse or progression, so mostly they are doing it distant site, not local regional.
So why do you think they did this in this protocol? After 2 months, they gave consolidation to all these areas.
So I'll try to answer. So we are not arguing that osimertinib is not a good drug. It's a very good drug. But whenever you add second modality, it gives its own benefit, whether it is in local control in lung, which improves quality of life, which improves disease-free survival, and especially if the metastatic site in brain, bone, it is about living with better quality of life, and then SBRT adds in that without compromising on osimertinib dose, without giving any major morbidity. So I think we should practice it, and we should always add radiation early, not at later on with progressive disease, multiple site, poor general condition. Then it gives poor results.
So, keeping only science in mind, do all radiation oncologists colleagues sitting here want to incorporate radiation early based on this osimertinib data? Even
it
a
should
nod
be
will
early.
help.
It should be early.
It should be early. Should be early. Okay.
My answer is no.
No. Okay. Doctor
When,
Vinita
why,
says
when
no.
we have to do a response adapted radiation. Suppose there is a patient who's got, say, 6 metastases and everything is responding to osimertinib, then why do we want to add consolidative radiation therapy? I would rather think that when there is an oligoprogression, then we get an early referral. Rather than, consolidating. I know radiation therapy can be given safely to multiple sites, and especially this paper Dr. Rajendra presented says that you can do a dose de-escalated consolidation radiation therapy. But I also have a difference of opinion from Dr. Denny. He said that, majority of these patients will continue to have a distant progression. They will have distant progression, but a good majority will continue to recur on the sites where the initial presentation of the disease was. So I think the idea should be to early pick up these patients and give an early referral for radiation so that the osimertinib, the same drug, can be continued for a longer time without going for chemotherapy or another IO or targeted therapy.
So what Dr. Vinita essentially is saying is that while maybe there is some benefit in to give radiation to all sites, that benefit may not always be clinically sound, clinically justified, and therefore what your point is, but we evolve maybe a better paper, maybe better data, maybe more randomized data, maybe some other endpoints, maybe distant control or something will answer this question. Not everybody should probably get it. I would also say that not everybody should get it. I would also say that. So with this, we move to the next one because we have limited time. So this is about Ahit's paper. So this is about sequential chemoimmuno followed by standard versus reduced dose. So yeah. So okay. So Dr. Ahit, what are your thoughts when you read this? What were your initial thoughts when you read these slides? You can take the mic.
I think it was an interesting study design, looking at some of the mitigation strategies in patients who are underrepresented. And if I have, but I think I have already touched upon these points. The limitations was that it was a small phase 2 trial. There was no direct comparison between the standard dose and reduced dose thoracic RT arm. The chemotherapy protocol was extremely heterogeneous. The same story for the immune checkpoint inhibitor protocol as well. And when they're decreasing the dose of thoracic radiotherapy, there was increase in local regional recurrence.
Yeah.
However, the toxicity profile becomes more favorable, particularly pneumonitis, which is fairly common.
So, Dr. Ahit, did they, deny radiation therapy to the non-responders in this paper?
I think majority of the patients, they responded and ended up receiving thoracic radiotherapy.
But
like patients who are responding to immunochemotherapy, they were randomized.
So as science, would you agree with that? That should you deny the non-responders radiation therapy?
No, not at all. So, I mean, that's definitely an alternative treatment modality. If a patient is not responding to immunochemotherapy, in the setting of elderly, frail, non-small cell lung cancer, thoracic radiotherapy should be strongly considered, either in the radical setting or if a patient is not suitable, at least in the palliative setting.
And would you choose a lower dose for any patient?
I think again there's a suggestion that in patients with EGFR activating mutations, there may be a case of lowering the dose of thoracic radiotherapy if there's an initial response to chemoimmunotherapy. But
actually, I feel that in so many lung cancer trials, sometimes these type of results come because it's an actual intent to treat real world scenario, and patients ultimately get more drugs, more medicines after that, and that's why these curves never really separate fully. This happens because it's a real world scenario. So fair enough. So the point being that you would try to give higher dose whenever possible. Great.
But
So
in a real world scenario, in an elderly frail patients, we sometimes can't give 60 gray. So, but I'm happy to give them 54, 56, or sometimes even up to 50 gray. My only problem with this paper was that they have given radiation therapy with concurrent IO. I would be very wary of that because I think that the risk of pneumonitis would increase once we are giving low dose radiation therapy with concurrent IO.
they were giving thoracic radiotherapy with concomitant immune checkpoint inhibitor. So there was a higher incidence of pneumonitis in the standard dose thoracic RT arm as expected.
okay. So what dose would you prefer for a frail patient?
So it will vary between 50 to 54, 56 gray, but
You
may
would
not
do
be
standard fractionation.
generally, yes. But then sometimes we also consider giving a hypofractionated RT also. 15, 20 is also done.
Yeah. Sometimes up to 16 fraction.
Absolutely.
Something like that.
You have to tailor it.
Anybody else wants to join in? All the other panelists are welcome to join in.
Hypofractionated thoracic radiotherapy is also being actively explored in this setting. 15-20 is a good way out.
Yes.
Lovely. So great. So we move quickly to anlotinib combined with whole brain radiation, Soumya's paper. So Dr. Soumya, would you use after reading this this anlotinib, in your practice? Suppose it's easily
I
available.
tried to find out with my medical oncologist. I don't think so. This drug is available. So, I mean,
suppose it is. Suppose it is. You presented the data.
Yeah.
It's kind of exciting, that data.
Yeah, the data.
So what does anlotinib actually do?
It's actually multi-targeted TK. It's just like lenvatinib sort of action, antigenic action. As far as they have mentioned in that slides, it actually boosts the effect of radiation also. Apart from other mechanism of action.
It's actually just a VEGF inhibitor.
Yeah, VEGF
Just a
inhibitor. Just a VEGF inhibitor,
So-
multi-targeted.
Yeah.
So I guess like if it is available with this, results are like looking.
So how does VEGF
attractive.
inhibitor help radiation therapy?
VEGF radio, it's actually you want to say like how does it boost, radio sensitizing
What is the
effect.
benefit of using a VEGF inhibitor?
VEGF inhibitor, I think directly.
It kind of induces vascular normalization.
Yeah,
The
vascular
tumor blood vessels
normalization,
are
yes.
leaky.
So would you use Dr.
Aggregation
would
in
you use it,
microenvironment, tumor
for your
microenvironment.
lung cancer patients?
I don't think we are using it, but I have some of my colleagues who are more active in thoracic oncology. I can ask them.
You
but
can
most
ask Dr.
probably it's
Denny.
not.
Dr. Denny, do you want to have an opinion on this?
Small cell there is no targetable drug driver mutation, and in the light of immunotherapy, we are using in most of the patients with the availability of Chinese, Indian so-called molecules. So I don't think, and anlotinib is not available in India. You said
It's not available in India.
it's not available,
No, but just
and
if it
it's
is,
mechanism of action also
based on this
VEGF, FGFR, and multi-targeted.
So time is up. I want to ask the organizers, should I stop here? Or is there time for one more question? Actually, this was the most exciting paper. Unfortunately, it's in the end, the CTFE paper. But anyway, regardless, all I will say is that we have been adapting radiation therapy. We have been going through various phases of evolution in radiation oncology. The first one probably was when CT scans were used, 3D based imaging was used, and now the adapted radiation therapy is there. And this is actually a biological adaptation of using CTFE, the paper that was presented. And maybe you can just give us one line at the end, and so that we can just conclude the panel.
Sir, I think in patients who have locally advanced diseases, we can do a mid-treatment CTFE. It is not going to harm anything because in the trial, as we saw, that the treatment was not guided by the CTFE values. But those patients who were having higher CTFE, they did. I think in future, if they get more aggressive systemic treatment, then they will do fairly better.
Lovely. So yes, CTFE is response adapted radiation, so biological adaptive radiation. With this, I think I should conclude panel. Although I don't want to, I thank the panelists, I thank chairpersons and the organizers. Thank you.
I request our chairperson and panelists and moderators, Gagan sir, please wait for the group photograph. Thank you for such an insightful discussion. Thank you so much.
Behind every successful radiation treatment lies the science of medical physics and technological innovation. Our next session celebrates advance in imaging, dosimetry, adaptive planning, artificial intelligence, and precision delivery. May I invite our distinguished chairpersons to the first row. Dr. Maninder B. Mishra, sir, medical physicist at RGCI, Delhi. Uh, Mr. Maninder Singh, sir, senior radiation therapist at Dharamshala Narayana Hospital. Dr. Manoj Semwal, sir, chief advisor, medical physicist and radiation safety at Army Hospital. Dr. Nidhi Marjara, ma'am, medical physicist. Dr. L. Nitya, ma'am, chief medical physicist and radiation safety officer. Mr. Thomas Ranjit Singh, sir, chief radiation technologist at Dharamshala Narayana Hospital. Mr. Ramesh Jayantilal, sir, medical physicist.
आपको presentation बहुत चाहिए।
Good afternoon, all. Today, my topic is clinical validation study of ionizing radiation acoustic imaging array for real-time visualization of radiation therapy dose in liver cancer patients. This whether or not even here. See me. A clinical validation study of ionizing radiation acoustic imaging array for real-time visualization of radiation therapy dose in liver cancer patient, which was already presented in RI 2024 by Wejang and team. This study is collaboration with Michigan University and Moffitt Cancer Center. Open loop image guided radiotherapy. With current open loop imaging guided radiotherapy workflow, does uncertainties due to the errors from positioning, accuracy, and outcome in a vivo real-time volumetric dose verification and feedback system will be beneficial to adaptive radiation therapy to improve the accuracy. Currently, there is no such kind of techniques. ionizing radiation acoustic imaging, how it works. We are developing a novel technology. The authors are developing a novel technology of ionizing radiation, include induced acoustic imaging, to address these challenges. It based on high energy radiation beam induced thermal acoustic effect using acoustic wave to detect the dose deposition deep into human body. The initial acoustic pressures generated by heat is proportional to the deposit dose, which provides the physical feasibility of quantify mapping the dose deposition. Volumetric array system. In this order, to turn that technique into clinical practice, a volumetric array system was developed. A 2D matrix array transducer with 1024 elements was customized, designed with element size and central frequency matched with radiation-induced acoustic signal, and have customized built pre-amplifier array integrated with transducer elements to reduce the noise. All the design of this system is well supporting the high sensitivity in detecting the extremely low radiation induced acoustic signal, which is around 5 to 6 orders to magnitude less than normal ultrasound imaging. RI for imaging the temporal dose deposition and dynamic accumulation. To evaluate the imaging system in monitoring the dose distribution of clinical treatment plan, a large-based cylindrical phantom was made to test the treatment plan. A C-shaped dose distribution consists of 23 beam angles was created. The temporal dose deposition and accumulation in the phantom during the delivery was continuously monitored by RI. A frame rate of 3.3 Hz was achieved for monitoring the temporal dose accumulation in this body. This RI system would be able to provide a sufficient temporal resolution for monitoring the dose delivery. Patient characteristics. To evaluate the clinical feasibility of RI in vivo, a clinical pilot study is running in University of Michigan with liver cancer patients treated with radiation therapy. Different beam delivery techniques induced, including 3D-CRT, IMRT, BMET, were involved. RI dose mapping were performed with 10 of the patients, close to 20% of the total prescription dose were mapped by RI. The measurement was performed from single angle beam to a beam delivery angle up to 60 degrees. For the RI for imaging dose deposition of IMRT treatment plan on liver cancer patient. For the first example, a cancer patient treated with IMRT was involved. To avoid changing the clinical workflow, the treatment plan for each fraction was divided into two parts. The first was to sagittal beam for IR imaging with maximum dose of 8.77 gray to cover the area with tumor. The second portion was to make sure that the total delivered dose meet clinical requirement. During the RI imaging, the 2D matrix array was placed in the right side of the patient's abdomen and coupled by a water balloon. The sagittal plane and axial plane of dose distribution shown in the right side. RI for imaging dose deposition of IMRT. The dose distribution from the treatment plan were extracted based on the liver mass as shown in the dose distribution from both axial plane and sagittal plane. The dose is decreased from the top to bottom. The bottom RI measured dose imaging mapping the overall shape the delivered dose, which is relative consistent with the dose distribution from treatment plan. Although the dose distribution target area is not actually the same with the treatment plan, it can be improved by involving the acoustic property of the tissue into reconstruction and utilize more advanced algorithm. With all over deposition the shape of RI measurement dose accumulation, this steady RI weighing system is able to the map dose deposition deep into liver with IMRT plan during the cancer treatment. RI for imaging dose deposition of BMET treatment plan in liver cancer patient. Another patient with liver cancer treatment with volumetric PMET therapy, different from previous patient. We had beam delivery from sagittal. This study was had all the beam delivery in axial plane to minimize the potential radiation damage to the correct electronics of the imaging system. A delivery angle around 60 degree was with maximum dose of 6.8 gray to cover the area. The tumor was used for RI imaging. During the RI imaging, the 2D matrix array was placed in the right side of the patient abdomen, which is far away from the target and rarely have any radiation beam delivery. The sagittal plane and axial plane of dose distribution shown in the right side. During procedure, the liver mass applied to the treatment plan due to a wide range of the delivery angle and dynamic modulated. The intensity high dose typically happen in middle of the treatment region. The bottom arise major dose imaging, mapping the overall dose shape and delivery dose, which is relative mapping to overall shape and delivery, which is relative to consistent with the dose distribution from treatment plan. Compared with IMRT, the distribution of image dose in the target area can more accurately reflect the dose distribution in treatment plan. The 3D RI mapping system is able to map the dose distribution into liver with PMET during the cancer treatment. RI versus treatment plan dose volume histogram. In this DBH for RI measurement and treatment plan were compared in both the liver and PTB. The similarity between RI and treatment plan dose demonstrated the capability of RI to map radiation dose in the clinical treatment settings. Summary of clinical pilot study. In this study, total 10 liver cancer patients were involved who are getting treatment. The radiation beam delivery with the different delivery method can be mapped by RI. More than 60% of the abdominal had been imaged by RI. Minimal dose detectable dose was 10 centigrade, which is very below than any tolerance dose. Thank you.
So next, Ms. Diksha Sharma.
Good afternoon, everyone. I'm going to present a paper, Impact of a Clinical Prototype LINAC Dual Layer KV Detector on Contrast and Metal Artifact Reduction in Patient Cone Beam CT, which was presented by Mr. Thomas Harris in ASTRO 2025. So these are the disclosures. The author had the disclosure, but I have none. The background of this study is dual energy imaging offers several advantages. Development mostly related to DCT, dual energy CT improves treatment planning by capturing images at two different X-ray energy levels. This study aims to bring prototype dual energy imager to a LINAC onboard imager with focus on virtual monoenergetic images. Prototype dual imager is an advanced diagnostic system designed by capturing images at distinct X-ray energy spectra by analyzing the difference in tissue and material absorption. So onboard dual layer imager design, designed with variant to fit a true beam KV detector, two vertically stacked detection layers keeping the first layer identical to the current model. Unlike a normal detector, this system has two detection layers. The first layer works like the standard detector, while the second layer captures additional X-ray information. Combining information from both layers allow better image reconstruction. Monte Carlo simulation used to design second detecting layer settled on a somewhat thicker cesium iodide layer to improve photon detection efficiency while preserving resolution. Cesium iodide scintillator is a highly efficient dense material that emits visible light when struck the ionization radiation. And the morphosilicon is a light-sensitive semiconductor device that converts lights or X-ray scintillation into electrical energy. It is widely used in flat panel X-ray imagers. So this is an imaging data flow chart. The prototype was installed on a clinical linear accelerator. More than the 50 patients were scanned, including head and neck patients, thorax, pelvis, brain and extremities cases. This shows that the detector was evaluated in real clinical situation. As per the data flow, the linear accelerator is taking the images and sending to the XI node as well as the therapist workstation and the research computer. 3D virtual monoenergetic imaging, dual layer CBCT projection decomposed into basic materials, interactive least square solution to polyenergetic Beer's law equation, decomposed projection FDK reconstructed into material basic volumes. VMI enhanced the accuracy of radiation treatment planning by suppressing images artifact and dramatically improving tumor visibility compared to the CT scan. So coming to the virtual monoenergetic validation, before using the system on the patient, its accuracy was tested using a standard imaging phantom. CAT Phantom 604 scanned at 125 kV and 80 kV virtual monoenergetic imaging constructed. Different materials are used. The average error was only 0.5%, showing that the system provides highly accurate measurements. They used different materials, insert and compared, which is 50% bone, 20% bone, and acrylic, polystyrene, LDPE, and PMP. All standard deviation are less than 0.001. 3D virtual monoenergetic imaging and metal artifact reduction. It is used to improve the quality of the image. These slides present one of the main results. High energy virtual monoenergetic images at 120 kV significantly reduce metal artifacts caused by the dental filling. The image uniformity improved by approximately 48.7%, making the affected region much clearer. 3D virtual monoenergetic imaging contrast. Low energy virtual monoenergetic imaging effective at increasing the contrast. Low energy virtual monoenergetic imaging at 40 kV improved soft tissue visibility. And in head and neck patient, tissue contrast increased by 1.7 times, and in pelvis patient, the contrast increases by the 2.4 times. So to be conclude, a novel prototype dual layer imager was installed on a clinical LINAC. Dual energy imaging capabilities successfully added to a LINAC imaging. Metal artifact reduction and the contrast can be enhanced with the imager. Future work will investigate other dual energy capabilities. These improvements can support more accurate image-guided radiation therapy. Thank you for attention.
Thank you, Diksha. Next presenter is Mr. Dheeraj Kumar.
Good afternoon, everyone, and respected chairperson. Today, I will be presenting a study titled "A Novel Biomarker for a Treatment Response in Biological Radiotherapy: Real-Time Quantification of Radiation-Produced Free Radical Generation on Clinical mRNA." This work was done by the Clary Park and colleague. This is just disclosure slide from the author. So, stereotactic MR-guided radiotherapy. This is a treatment technique where the patient is treated on a machine that combines a MRI scanner with a linac called MR linac, and it is useful because MRI gives excellent soft tissues contrast, allows a online therapy planning. It helps us to modify the plan when the tumor or organ at risk, change the position between the fractions, and challenges come in the smarts. The current adaptation is mainly anatomical. It does not tell how the tissues biologically respond to the radiation. And also the dose prescriptions are mostly based on the population level data and they not fully represent the individual patient response. So the clinical challenges comes is to account for the specials and the patient specific biological response during the radiotherapy. The variation in the local chemical environment and composition lead to vastly different biological outcomes. A major radiation-induced DNA damage happens indirectly when the radiation interact with the water and produce a free radical species, and that free radical species have a different chemical environment. Tissues may contain a free radical scavengers, which can reduce a free radical activities. So the same physical dose may produce a different biological effect in the different patients. However, currently there is no real-time non-invasive method exists to measure the radiation produced free radicals during radiation. MR of the radiation chemistry, as we know, X-ray interaction with the water lead to a radiolysis products and free radical generations. Some of the free radical generations have a paramagnetic free radical species which act as unpaired electrons. It induces changes in the T1 relaxation due to the paramagnetic relaxation effect. An objective of their study is to develop and demonstrate a novel MRI-based framework for the non-invasive measurement quantification of real-time radiation produced a free radical generation during a radiotherapy. So they introduced their technique, which they call a FIRE MRI, standing for the free radical irradiation emergent MRI. They tested their framework on 0.35 Tesla MR linac and used a MP2 range. MP2 range is an advanced MRI sequence used to measure a T1 accurately, and it takes two images from different inversion of times and combined with the one high quality images to generate a T1 map. It was optimized to detect a small T1 changes. These methods provide a dynamic T1 mapping with a 6 seconds of temporal resolutions. And MRI measures the T1 changes and then T1 changes converted into the concentration using relaxivity based models. As you can see in that relaxivity models, changing the T1 is inversely proportional to the summation of relaxivity at 0.35 Tesla and concentration. After validation of their technique, they comes on the simulations, radiation chemistry simulations to determine the superoxide relaxivity and determinations they did in the computer-based prediction model. They use a water and combrane, and they found that result superoxides is the dominant permanent paramagnetic species contributing to the change in the relaxation times. For the matching the simulations, or the experiment they did on the 0.35 Tesla MR for superoxide relaxivity, and they determine, as you can see in the figure graph, the changing in the relaxation time versus the time and concentration versus the times. They come in the conclusion superoxide relaxivity on the 0.35 Tesla is given 10,346 per mole per second. After that, they did a demonstration fire MRI in the different phantom with different physiological environments. They started with the pure waters and combrines, metotempo and glutathione, radiosensitizing and gold nanoparticle. As you can see, the changes in the graphs for the superoxide concentration versus time in the second graph. They did in the 35 different phantoms, 5 per conditions. They come on the summary and significance is that they develop a fire MRI for the real-time MRI based measurement and quantification of free radical generation produced by the during radiations. They demonstrate the measurable T1 changes due to the radiation produced superoxide free radical generation, the phantom. The future work is expected to do be evaluate the feasibility of fire MRI in vivo with the biological systems and the potential significance of impact of the study free radical generations as a molecular biomarker for treatment response and area under the curve as a metric for the normal tissues damage. Thank you for your time and attention.
Thank you, Mr. Dheeraj. Next, I'd like to call Dr. Neeta Singhal to present the paper. The topic is quantifying changes in lung function using 4D CT-based ventilation imaging for patients undergoing functional avoidance radiation.
Good afternoon, everybody. Good afternoon, chairpersons. So coming to thoracic radiation therapy, we always see pneumonitis is a major limiting factor while we treat thoracic radiation therapy. So this paper is about quantifying changes in lung function using 4D based ventilation imaging for patients undergoing functional avoidance radiation therapy by Chen. So radiation pneumonitis, as we all know, is a limitation while treating thoracic radiation therapy, and we usually manage by measuring with mean lung dose or V20. And while we see in our clinical practice that 70% of lung may have spatially variant lung function, like we are trying to save the part of lung may not be functional at all. So this paper is about functional lung imaging and quantifying the changes. So we have already derived data for functional lung imaging, like previously in 2017 this paper was published where a functional avoidance radiation therapy was practiced. It was a multi-institutional trial, and after deriving the functional radiation images, they had pulled their radiation doses and planning according to the plan so that they can avoid the functional part of lung. I will just show you the functional part. What is functional part? So this bright color is the functional part. In future slides, it will come how it has been derived. So this is the functional part. So radiation isodose is pulled to the area where it is a non-functional, maybe because of the tumor or pneumonitis, etc. The non-functional lung may be there. So you can pull the doses to non-functional lung and try to avoid the functional part of lung. So 54 patients were prospectively distributed for functional avoidance clinical trial. Lung toxicity in this study was assessed clinically by 3, 6 and 12 months, and 4D CT scan was done once before radiation therapy and once after 3 months of treatment so that we can identify the area that has developed pneumonitis. So this is about functional lung imaging. Some of us may be doing this. So deformable image registration is done. That is inhalation and exhalation images are registered, and some calculation is done to identify the functional. So brightly colored area is the functional lung. So all ventilation images were percentile normalized and they were distributed in 9 region of interest according to the doses. So different doses were allocated to different bins were allocated to different radiation doses, and some statistical analysis was done. So this is a non-radiation pneumonitis patients where we see fitting slope of 0.16, that is slightly stable or maybe increasing. And in a radiation pneumonitis patient, we are seeing decreasing slope. So that means as the radiation dose increases, the function of lung gets deteriorated. And this was most appreciated in 20 to 25 gray bin, where radiation pneumonitis patient had minus 6.5% of deterioration as compared to non-radiation pneumonitis patient. So this shows a slope which is showing deterioration in radiation pneumonitis as compared to non-radiation pneumonitis, which is a relatively stable curve or maybe slightly increasing curve with all these statistics. So to conclude, the pattern of ventilation changes as a function of radiation dose varies for patient undergoing functional avoidance radiation therapy. A significant reduction was seen in 20 to 25 gray bin, and so this is a biomarker. This is an early predictive image biomarker, so we can just identify the patients who are developing who are in future going to develop deterioration in pulmonary functions by seeing these images. So I hope I was able to stuck to the time. Thank you so much.
Good afternoon. I would actually invite Dr. Vikas sir. And his topic is dynamic imaging in avian follow-up, evaluating 4D MRI for post-radio surgical mobility.
Good afternoon, everyone. I first at the outset would like to thank the organizers for giving me this opportunity to present this wonderfully prepared paper of dynamic imaging in AVM follow-up evaluating 4D MRI for post-surgical obliteration by Dr. Shankar from Chennai. For evaluation of AVM, gold standard has always been DSA, that is digital subtraction angiography, because of its superior spatial and temporal resolution. It can show us the feeding arteries, the nidus architecture, the microangio architecture rather, and the venous drainage. What is the hallmark of cure on DSA is that there is no nidus filling and there is no early venous drainage. So this is an example of a pre-treatment DSA after 1 year and after 2 years. This is a grade 1 response to treatment, that is minimal residual flow, not complete obliteration, but over a period of time, this can go into complete obliteration where it will be called grade 0. For MRI for nidal obliteration depends on conservatively what depends on T1 and T2 weighted images. On T2 weighted images, we see lack of flow voids on the right side image that shows obliteration, or lack of enhancement on T1 weighted images. However, the downside of this is that this only gives us structural information without telling us what is the hemodynamic status of the lesion. For this to evaluate, there is a role of 4D Cine MRI which has been studied. In this we used, this is almost like cutting edge of MRI, where we use 3D imaging with time and velocity encoding, which gives us the fourth dimension, in which we can see the direction of blood flow, the volume of blood flow, as well as the tissue perfusion. So this was an example of a thalamic AVM. Unfortunately, the image is not there, which shows the obliteration. And it can also track dynamics of flow. And that is what we see actually on DSA. So it can actually reciprocate or reproduce what we see on DSA. So we can avoid a invasive procedure which DSA intends. So the premise of this study was, can 4D MRI replace at least some of the DSAs in radiosurgical follow-up? The hypothesis was this, and the objective was to evaluate the accuracy of 4D MRI vis-a-vis DSA. So this included a prospective study including 45 patients with eloquent area AVMs having a Spitzler-Martin grading of 3 to 5, and they were evaluated on baseline imaging by rotational DSA, CT angio, and baseline MRIs, which included 4D MRI. The treatment involved 22 gray on a single setting for volumes of nidus less than 10 cc, and 35 to 40 gray in 5 fractions for volumes more than 10 cc. The follow-up imaging was done by 4D MRI at 6 months, 12 months, 24 months, 36 months, up to 48 months. And where there was a obliteration, DSA was done to document complete cure. So the study design was well thought out. So this was an example of a thalamic AVM when the left, which was a follow-up after 12 months, shows complete obliteration. The same on the extreme right by DSA, which is showing a nidus right in the center of the imaging, a black dot, which disappears post-treatment. Second example, this we can see on the left image as a high parietal AVM, where you can see a blush of vessels, almost like a spider web, which disappears post-treatment on 24 months. And similarly, you can see the mesh of vessels, which are seen on the pre-treatment MRI, are not there on the post-treatment MRI at 24 months follow-up. So all the data was statistically analyzed to for diagnostic accuracy. We wanted to, they studied sensitivity, specificity. Cohen's kappa was done to calculate intermodality concordance. Wilcoxon test was performed to see for volume reduction over time, and Kaplan-Meier analysis was done for time out to obliteration. So this was a result. 44% patients had grade 0 response, that is complete obliteration of the nidus, whereas 26% had grade 1, out of which another 42% went on to subsequently have grade 0 response. So comparing the diagnostic accuracy, it gave us a high specificity and high sensitivity, almost touching 90%, and even a high positive predictive value of 92% and a relatively low negative predictive value of 85%. So that It approaches DSA level accuracy. Even the concordance was 0.8, which was strong, although not perfect, but very strong. 4D dynamic assessment was possible, where you could evaluate the structural parameters as well as the hemodynamic parameters like the arterial filling, the venous drainage, and the nidus opacification. So this was dynamic course by grade, where the sensitivity was 45 to 58%. Persistent residuals were of grade 2 and grade 3 were shown to plateau after 12 months. So this 4D MRI could show us failure of response even at early stage, so that disease modification could, the treatment modification could be implemented at as early as 12 months. Our Kaplan-Meier analysis showed showed that at 32 months, which was average follow-up, 55% achieved grade 0 response by 36 months. And many grade 1 also underwent transition to complete obliteration over time. This was the qualitative hemodynamic evaluation, where they studied arterial shunting as well as venous shunt persistence, which also reduced over a period of time. This graph, that is what this graph shows. And similarly, these were also the quantitative biomarkers of obliteration, which reduced significantly. That arterial shunt intensity, which was calculated using AI models, reduced from 0.9 to 0.2, whereas venous filling time increased from 0.1 to 2.8 seconds, which indicated response to treatment. So this was a unique study where they used 4D MRI, comparing it to DSA. The advantage of 4D MRI is that it is non-invasive. It reduces the risk of DSA such as stroke or access site hematomas and reaction to contrast, which 4D MRI will gain. So what are the future landmarks for this? Using AI models, radiomics, hybrid imaging, and dose response mapping, and identifying tumor markers, imaging biomarkers which show response. 4D MRI can suitably replace DSA for surveillance of AVMs post-treatment. Although for confirmation of the complete obliteration, DSA would still be required, but 4D MRI is a promising tool in our hands, a non-invasive one. Thank you.
Next speaker is Dr. Chavi, for radiotherapy induced acute lymphoma or low and intermediate risk prostate cancer.
Good afternoon to all. First of all, I would like to thank to the organizers for inviting me for presenting this study. This is a study, the topic is radiotherapy-induced acute lymphopenia for low and intermediate risk prostate cancer. The principal investigator and the presenter for ASTRO was Mariam Motebed from Massachusetts General Hospital. Starting with the presentation, this study is a subsidiary study to another study, which is the PARTQOL, that is a multicentric clinical trial, prostate advanced radiation technologies investigating quality of life in patients of prostate cancer, published article published in 2024 in Red Journal. And this is a subsidiary study to that, to learn the outcome. Starting with the study, this project was funded, just a disclaimer, funded by the Federal State of Program Income earned by Massachusetts General Hospital. And the first author is at Brown Hospital, my bad. Radiation-induced lymphopenia, it is defined as the depletion of lymphocytes count caused by radiation. What is the level of the lymphocytes? Basically, lymphocytes count, which is less than 1000 per microliter and graded as grade 1, grade 2, and grade 3. It is ascertained that radiation damages the circulating lymphocytes in the vessels and the lymphoid-rich organs like spleen, lymph nodes, and bone marrow. Based on this knowledge, this trial was designed. The radiation-induced lymphopenia can negatively impact treatment outcomes and patient survival. Comparing the risk of radiation-induced lymphopenia provides a unique insight into the therapeutic efficacy of proton versus photon therapy. And the hypothesis is that the proton therapy decreases the risk of RIL compared to photon therapy while the patient undergoing radiation. So the treatment of CA prostate patients who are undergoing radiation in intermediate and low risk were compared, and this is prostate only radiation. And the modality is used on both the arms is IMRT versus proton therapy. To compare this is the baseline the incidence and temporal variations of RIL was following the proton and photon modalities for patients with low or intermediate risk prostate cancers, and to assess the ALC and dose to circulating blood cells and their comparison with the pelvic bone marrow and the outcomes related to that. So they aim to investigate and compare the incidence and temporal changes of the acute lymphopenia for prostate cancer without the nodal radiation in the pelvis for these patients. Now this is the study design. Again, as I mentioned, it is part of the Party QOL trial. It is a sub trial to that, and the cohort was they tapered into comparison study of collection of biospecimens during their participation period was done, and 63% of the patients, that 63 patients, 30% treated by proton therapy and 70% by photon therapy, they were included in this study. The CBCs were collected on at the time of recruitment, that is before radiation, and at other time periods, that is after completion of radiation at 3 months post radiation on the follow-up of the patient. And that's how the study design was done. The N number in proton arm came out to be 19, that is 30% of the patients, and N was 44 in the photon therapy arm, which was 70%, and it was almost a 1:2 ratio. Here we can see that the median age is 68 in proton and 71.5, almost matched in between. The Gleason scores were matched. The stages were matched in the two arms. The doses used were 70 gray equivalent and 28 fractions in protons, and 70 gray and 28 fractions for photons. And the assessment done at initial baseline, 16% of the patients in proton arm had lymphopenia and 7% in photon arm. HEDOS was assessed, that is a hematological dose framework. It is a type of assessment where the two type of models were used for assessment of what is the dose to the peripheral blood and to lymph-rich organs. And this was studied further in this trial, accounts for the probability of blood flow through the vessels, OARs, and the dose to non-contoured regions such as adipose tissue, muscle, skin, and bone. And the DVHs were generated after that. The number of patients analyzed were this, and mainly grade 2 RIL was assessed, grade 1 and grade 2 RIL was assessed, which was in 26% patients in protons and 26% to 59% in photon therapy, and grade 2 in 21 versus 30%. Higher grades were not seen in both the patients. After 3 months, the first follow-up, 88% patients there was an increase in the ALC follow-up in 88% of the patients on proton arm, and whereas in 76% in photon arm. We can see this pre and post 3 months. Coming to the analysis, blood dose contribution to the other structure that we had shown: bone, muscle, fat, skin, small bowel, colon. And there is the simulated dose to the circulating blood using HEDOS on the left of the blood dose histogram, and on the right blood dose histogram, the histograms of the protons on the top and the photons on the bottom, there is a mean dose of about 2.5 times larger with the photons as compared to the protons. So, and this is the second part of the result, which is seen that there is the reduction of ALC at post RT. The mean accumulated dose was 2.5 times larger, and there's reduction of ALC at post RT at 3 months follow-up relative to the baseline were corroborative between the fall and the RIL seen in the patients. Summarizing, the acute lymphocyte lymphopenia significantly decreases post-RT and partially recover at 3 months following irradiation of both modalities. Immediately post-RT, ALC reduction is significantly larger for photon radiation compared to the proton, and the difference in follow-up though was not significant at 3 months. The recovery of ALC are steeper for photons as compared to protons, and larger dose per volume of circulating blood during the photon RT could be responsible for this steep difference in the ALC fall-off. This is for future work and future studies and to study further outcomes in the patients. Thank you.
Speaker, Vedash. He is going to speak about unveiling LED radiation effects on the hippocampus, ADC dynamics reveal microstructural changes during
Can I take it off? I need it. Good afternoon, everyone. I would like to thank the organizers and especially Dr. Kanika for giving me this opportunity. So I'll be presenting a paper by Ori et al. Unveiling early radiation effects on hippocampus. ADC dynamics reveal microstructural changes during therapy. So the objectives are to define ADC as an imaging biomarker of hippocampal microstructural response during radiotherapy, to demonstrate the dose response relationship between hippocampal radiation exposure and ADC dynamics, and to validate biomarker specificity by linking hippocampal ADC changes to domain specific cognitive outcomes, and to discuss clinical integration, including adaptive response monitoring and predictive modeling for neuroprotection. So just to get an idea of the basics, as you all know, radiation therapy improves survival in all the GBM high-grade glioma patients, but the normal neuroparenchyma also has to bear the brunt of the EBRT. And the hippocampus is a highly vulnerable structure due to its role in neurogenesis and then cellular structure. So it is quite sensitive to radiation. And cognitive decline is obviously in terms of memory, that are long-term effects of radiation. Apparent diffusion coefficient, that is ADC, is an MRI-based biomarker that increases with microstructural injury and correlates with the long-term cognitive outcomes. So the knowledge graph that the previous studies had were relationship between early changes, delivered dose, and specific cognitive domains, which this study would bridge. So coming to the cohort description, so all the high-grade glioma patients were taken, baseline assessments were done prior to the starting of the radiotherapy by MRI and cognitive testing, then followed up by weekly MRIs and cognitive assessments. The collected data was analyzed, and then the ADC changes during radiotherapy and cognitive outcomes were seen at 3 to 6 months. Median age was about 64 with a male predilection, and most of the tumors were right-sided and in frontal lobe, with a predominant histology being GBM in 87% of cases. The CTV was around 184 cc, and steroids were used in about 20% cases, and the respective hippocampal dose on the right was 10.4 and the left had a median dose of 8.9 gray. So these are the spaghetti plots that represent relative ADC changes during the course of radiotherapy from week 1 to 6.
week 1 to week 6. And as you can see, week 5 and week 6 versus week 1 show a significant increase in the ADC relative change, and so as suggested by the p-value. So so now in this slide, we can see the volume changes were also compared with a relative according to weeks, and suggested no significant correlation in no change in volumes. So this is a linear regression scatter plot that shows the mean combined hippocampal dose and a relative ADC change that is represented by R value 0.61. So it suggests a strong correlation. So similarly for the left hippocampi, the R value was 0.41, suggesting a moderate one. So now we come to cognitive testing. So various tests were employed, namely one-card learning, behavioral pattern separation, face shape binding test, face name letter test, and face name matching test. So these are specific tests with combined ADC change, showing the R values and respective P values. So it was found to be significant only for FSBT and the composite change. So this is a dot and whisker plot that shows that was plotted with a relative ADC change and with specific cognitive tests, and it was found to be significant only for composite change after dividing the patients in positive and negative groups. This is a bar graph that shows proportion of cognitive decline for specific tests and in relation with relative ADC changes. So the above data sets were exposed to uni and multivariable analysis for composite score decline, and that was found to be significant for ADC change greater than 10% and frontal lobe tumors for uni as well as multi. However, mean hippocampi dose greater than 9 gray was found to be significant only in univariable analysis. So we also had a control region, left cerebellum. So there was no association found between the left cerebellar dose and the ADC change. Supporting hippocampal findings are region specific rather than global brain effect. So to conclude, talking about clinical implications, ADC is an early imaging biomarker of normal tissue response that happens prior to the volumetric loss. And there is a clear dose response relationship. The higher dose correlates with the greater ADC risk. And ADC changes are also region specific, underscoring hippocampal vulnerability. As per future directions, we need to integrate ADC into adaptive monitoring and develop predictive models. Along with, and this study needs to be validated across larger adult and pediatric cohorts. Thank you.
Next speaker is Dr. Manjari Shah. She's going to speak on CD-based quantitative study of average toxicity correlation of ACVF with central.
Good afternoon, everyone. I'm Dr. Manjari Shah. First of all, I would like to thank Dr. Kanika ma'am for giving me this opportunity. So today I'll be talking about a CT-based quantitative study of AV's dose toxicity correlation after stereotactic radiation for central lung tumor. It was presented by Mr. John Coste, Amsterdam UMC Group. So the novelty of this study is that author used AI-assisted airway segmentation to delineate the radiation tolerance dose for each bronchial branches. So coming on to the introduction, we all know that stereotactic radiation is the standard treatment for early stage lung cancer, but treatment becomes challenging when we are treating central lung tumor rather than peripheral tumor because of its proximity to proximal bronchial tree. We all know that onset of toxicity is usually month to years, so underreporting usually happen in these cases, and so tolerance dose determination become difficult. Now, what they have done that bronchial tree is considered as a single entity, and that is what author is saying is a big limitation because we all know that all bronchial branches vary in size and diameter. So what they did a quantitative analysis of CT-based bronchial branches pre-RT and post-RT, and then they compared the damages on those bronchial branches, and they use artificial intelligence for AI airway segmentation for these branches. The disease was the study was done from it was a retrospective study. It was done from 2006 to 2024, on which 105 central lung tumor cases was taken. The dose fractionation that was used was 18 grain 3 fraction, 7.5 grain 8 fraction, 11 grain 5 fraction. 70 tumors were located within 2 centimeter distance from proximal bronchial tree, and it was included in the inclusion criteria that it has to be within 2 centimeter from proximal bronchial tree. The availability of pre-RT and post-RT CT scan should be there, and no prior history of RT of the same region. And then exclusion criteria were included local relapse or surgery. So after doing all inclusion and exclusion criteria, only 29 patients were recruited in the study. So this is how they use AI. They segmented the bronchial branches, and if we can see on this image, they have given different color to different bronchial branches, which is in proximity to tumor. So what they did a CT scan before the radiation, they did a CT scan after the radiation, and then they analyzed each bronchial branches in pre-RT and post-RT CT scan. After these, they find there were 3 findings. Some bronchial branches were open, some were stenosed, where there was more than 50% narrowing of the lumen, and some were completely occluded. On the planning day, they did a MRI images also on the baseline MRI images in which the contouring of the bronchial branches become easy, and then they propagated these images into the planning CT scan by using rigid and deformable image registration. And this is how they have contoured all the tumors and the bronchial branches. And this we can see the dose color wash. Bronchial segments were analyzed using 2 methods. First method is DVS that we frequently use, dose volume histogram, in which we know that numerical analysis become very excellent. So where we can have the D mean, we have D to 0.1 cc and 0.03 cc. And the another was dose mapping, spatial dose mapping. So what is the difference between a spatial dose mapping? It tells us the exact location at which bronchial branch has received the highest dose. So then we can determine the toxicity, whether it will be stenosed or occluded. Although we have recruited only 29 patients, but the data that 29 patient has given is of 178 bronchial segments. So what we can see that after follow-up of 20 months, time to full stenosis was approximately 10 months. And we can see that all the segmental, subsegmental branches, more than 50% of branches either do have occlusion or stenosis. And when we are going to more central location of branches, bronchial branches, the diameter was getting reduced. So occlusion rate was higher and stenosis rate was lower. So this was the dose mapping correlating stenosis. They have distribution of radiation dose range in 9 randomly selected patients. We can see that there was stenosis when red dose volume histogram was visible, and when it was completely open, then it was blue. So these were the predictor of radiological stenosis, that local hotspot at ipsilateral wall more than 130 gray, more than 25% of contralateral wall receiving more than 90 gray. So because it was circumferential radial dose distribution, so it was leading to more of stenosis and occlusion, and 25% of bronchial segment length receiving more than 90 gray. So to conclude, this study demonstrates that AI-assisted airway segmentation combined with dose volume histogram and dose mapping analysis give a branch-specific dose tolerance, radiation dose tolerance. Higher the D mean, higher the D 0.03C, tells us the additional toxicity that it will have future occlusion or stenosis. And we know that dose mapping will show extra anatomical info regarding developing a radiological stenosis. So a confirmation study is ongoing for this result, and these were acknowledgement. Thank you so much.
Thank you, Dr. Banjari, for the nice presentation. For next presentation, I would like to call Ms. Akshaya.
Thank you, chairpersons. Good afternoon to everyone. Today, I am going to present the paper titled In vivo dosimetry for ultra-high dose rate irradiation of rat spinal cord with novel scintillation detector, studied by Liziango and team. The ultimate aim of this study is to investigate whether flash therapy spares late toxicity compared to conventional therapy, and to assess the accurate in vivo dosimetry with the help of novel scintillation detector. Flash therapy is a new technique that delivers radiation at an ultra-high dose. It has the potential to reduce damage to healthy tissues while effectively treating cancer. However, measuring the dose accurately during flash therapy is challenging. The study investigates the irradiation of rat spinal cord with ultra-high dose rate and the necessity of in vivo dosimetry. Rat spinal cord is widely used to study the late effect of flash radiotherapy because it is highly sensitive to radiation and has a steep dose response curve. Even a small increases in radiation dose can significantly increases the risk of injury. Therefore, accurate in vivo dosimetry is essential. A scintillation detector is a good choice because it is small and tissue equivalent and also high spatial resolution, high temporal resolution and real-time dosimetry with minimal perturbations. Now we shall see the detector validations. For this research, the HyperSyn RP flash scintillation system is used. It has very small sensitive volume of 1 mm of diameter and 3 mm of length. The scintillation detector showed excellent performance. This graph shows that during 18 MeV conventional radiation, the dose accuracy between scintillator versus ion chamber was within 0.5% and during ultra-high dose rate irradiation, the accuracy between scintillator versus film was within 3%. This study demonstrates that the detector performs reliably both conventional and flash therapy conditions. The study also evaluates whether the detector response change with a different field size, dose per pulse and pulse repetition frequency. The detector showed only minimum variation indicating stable performance under different irradiation conditions. This graph demonstrates that field size dependence is within 1.5% for both 6 and 18 MeV, but 18 MeV has small bump at small field size, then it becomes flat. Dose per pulse dependence is within 2% and pulse repetition frequency dependence is within 2%. In this experiment, the scintillator detector was inserted into the spinal canal of a living rat through the catheter. It was positioned from the C2 to T2 region using dental X-ray guidance. The rat's spinal cord was then irradiated with an 18 MeV flash electron beam and the detector measured the radiation dose in real time. The detector position was verified using dental X-ray images. The measured moment matched the expected position, confirming accurate localization before irradiation. The result shows that the measured dose agreed with the Monte Carlo calculation. The dose difference was less than 4% and gamma rating of 2 mm 2% was 100%. This result confirms the detector is accurate in vivo dosimetry during flash therapy. In conclusion, the HyperSyn RP flash scintillation detector provides accurate real-time dose measurement during ultra-high dose rate irradiation. It is minimally affected by changes in field size, dose per pulse or pulse repetition frequency. The study demonstrates the first successful in vivo dosimetry for rat spinal cord flash irradiation and supports future research in flash radiotherapy. Thank you all, and I sincerely thanks Dr. Kanika ma'am for giving me this opportunity. Thank you all.
For next presentation, I would like to call Dr. Robin.
Good afternoon, everyone. And at the outset, I would like to thank Dr. Kanika for giving me this opportunity. So my presentation is design and implementation of combined spatially fractionated radiotherapy and image-guided on-treatment biopsy for resectable soft tissue sarcoma patients enrolled in a prospective clinical trial LCC 2250 by Rankin. So we all know that soft tissue sarcomas are a pretty radio-resistant tumors, and the modalities are go for a surgery followed by post-op radiation or a pre-op radiation protocol in which we do a biopsy followed by a staging imaging. We do pre-op radiation, and after 5 to 12 weeks we go for a interval surgery. So this is a normal protocol. What they introduced in this was an additional 18 gray grid therapy. Prior to the pre-op radiation, it was a single-arm prospective study of 20 patients, and after 3 to 4 days interval, core needle biopsies were done from the paths of grid, peaks, and valleys. So what is a grid? Basically, the radiation is in the form of a grid, as you know, where high dose regions are created within the tumor at equidistant intervals, and in between them are areas where radiation is restricted. And the area where the radiation is directly going, we call that a peak, and in between those areas, we form the valleys. And the biopsies are done from both the peaks and valleys. So the primary outcome of this part of the study was to study the grade 2 post-op complications, because the surgeons were wary of the fact that so high dose 18 gray single shot radiation may lead to wound complications, and so that was the primary endpoint. And because of this, it was a 3+3 safety led in assessment, which means that 3 patients were taken in the beginning. They were subjected to this treatment of grid therapy followed by radiation and surgery. And if there was any grade 4 complications of toxicities, then the study would have stopped earlier. And if they are okay, then next set of 3 patients were taken. The secondary endpoint of this study was to assess the major pathological response, which was relative to the pathological cohorts. So this was part of this study. So how the secondary translation endpoints were assessed in terms of DNA damage, which was based on gamma H2AX phosphorylation. The more the phosphorylation means the DNA damage is more. The second is assessing the immune stimulatory effects in both the peak and the valley area by measuring the CD4 and the CD8 T cell count. And third, the most important thing was a immunofluorescence staining for our G-gas sting pathways. So what happens is when a very high dose of radiation is given, it results in the DNA damage, and these DNA fragments go into the cytoplasm, which activate the G-gas sting pathway, and the immune response is generated. So for both the peak and the valley, they wanted to study where this phenomena is more pronounced. So then the physics part came into the picture is the commissioning of the grid radiotherapy, where through a conventional LINAC, MLC based grids were created like this. They were 1 into 1 centimeter grid created by MLCs, and at an equidistant from each other. So you can see that these colored areas would form the peak, and the white in the center of them would form the valley area. So the step and shoot MLC segments were used, and this is how it looked like. So on the patient, when the beam is delivered from the gantry head on the patient tumor, it will reflect at these this presented as red boxes, where the grid is created of high dose regions. And this is how it looks like. So, but again, no radiotherapy process or technology is complete or until unless it is accurately checked, and commissioning of this entire thing, like the leakages, any errors are looked into, the dosimetries are studied properly, so that because any leakage, any inaccuracies would add on to these factors. So radiochromic films were used. And then there is a small concept of peak to valley ratio, which means the dose in the peak, that is where the grid is created, and the valley, that is the empty area, that has to be maximum. So the difference would, the ratio of the peak dose versus the minimum valley dose would be the PVR ratio, and the higher the ratio, the more is the spatial separation. So now once it is done, the patient is treated, then the patient is treated by all possible best imaging modalities of surface guided using Vision RT, then using CBCT and the 6D couch corrections. So all these are taken into account, and the patient was treated. Again, the commissioning and the thing was done. Then after 72 hours, we had to take the biopsies from exactly these grid areas and the valley areas. So again, the patient was taken to the radiation machine. It was again, the images were fused. They were, the grids were created. I can say the field light was created on the patient surface, and from where you would have entered and gone for that particular biopsy. So again, the interventional radiologist was also involved as a part of the study, and needn't to say that he tested all this on a homegrown solution phantoms, where the guided needle was passed through exactly the same track as the grid radiation has entered. You can see the green is the area where the grid was created and the biopsy entered, and the dot in the between the two green lines showed the valley area from where the biopsy was taken. So again, the biopsy training and validation would result in extremely high accuracy when it was done at the hands of interventional radiologists, and to the tune of 0.9 mm accuracy was achieved. So this was done under ultrasound guidance, and post grid biopsy was taken. So this was basically a technical, a few of the slides has got missed from this, but it was basically a technical presentation where to check whether this is feasible or not, to see what is the impact of so high high dose of radiation biologically in terms of immune response, and how the immune response is created with this high dose radiation, and is there any bystander effect within these valley areas which is also responsible for tumor control. Thank you so much.
Thank you, Dr. Robin. The next presenter is Dr. V. Subramanian.
Yeah, good afternoon. Thank you for the organizer for giving me this opportunity. It's really an exciting talk. I just would like to give you. The group of the presentation is by the Duke University, United States of America. So the topic of this talk is that automating the head and neck cancer IMRT treatment planning with a large language model agent. So I'm sure the author has declared no, the conflict of interest. However, okay, yeah. So, however, they declared that the research agreement between the Varian and the APM and this one. So before going into that, everybody today it's very much familiar with what is actually the ChatGPT. So I have also put two slides in order to illustrate or to explain what is the LLM and what is the difference between the LLM agent. So what is LLM? Large language model is basically a GPT, ChatGPT, where you just ask the question, I need the image of radiotherapy treatment planning of current practice and recent advances. It will give you what it is in the slide. But whereas what is LLM agent, that means along with this ChatGPT, you also have kind of the reasoning and acting the AI model. That is use of generative model, explanation model, explainable model. So all this other AI system also incorporated into the framework. So that will give you that automated whatever the clinical the requirement. So that is what actually LLM based model agent. So basically, this is what actually the artificial intelligence, the treatment planning based, going to be the future. And, you can see that the ultimate, the AI treatment planning is called autonomous treatment planning. That means every aspects of treatment planning will be dealt by the AI system, having a different module of AI like machine learning, deep learning, reinforcement, large language model, computer vision, generative AI, explainable AI. So out of this, there are every, the model that's called agent. You can see here fourth one that is called large language model. So wherein you will be able to incorporate one more AI algorithm to automatically generate your clinical objectives. That is what actually the basic difference between the LLM and LLM agent. So basically, they have explained with the phenomena was two concept like zero start learning and the few shot learning. That means without any prior training model, like if you ask what does the ASTRO stand for, it will give that answer. What is ASTRO? And if you give the two more examples, the RSNA is this, ASTRO is this. What is that? The ASTRO. Then that will give. So that means you give the prior to the one or two the examples, and then you will give. So these are the two important phenomena where that LL model being used for the automatic planning. So currently there are treatment planning system, various level of the automations, starting from the knowledge based in Eclipse, most of the people you are using, and protocol based and multi-criteria optimization reinforcement. Now again it will be coming LLM and agentic AI. That is what actually automations this one. So in the manual planning, what we do, we prescribe the radiation oncologists prescribe the dose. After seeing that the optimizations, we see to that what is the clinical objectives, whether we have to modify or not, we modify, and we see to that whether it is achieved or not. So what is the difference between that manual planning and LLM based? You can see that the upper the manual planning, you observe you give the clinical the objectives, you observe the plan status, what is that the result, then modify the dose volume histogram accordingly. But when it is coming to that LLM model based, you can see there is a three important the concept called observe, analyze, and update. This is what incorporating, it's an AI model. So that means react, the reasoning and acting. When you are happen to see that what is your clinical objective which is not meeting out, that will automatically reasoning why it is not, then how it can be done. So that will reason and act. That is what actually that LLM model basically. But this is the prerequisite. You have to generate, give that the prompt using. Generate the treatment plan for this patients following this constraint. What will take actually prior to that, using that AI model. So these are all the important tools, like, the interpreting the clinical goals. The major task will be chopped out or, down to that, it will be many few steps of that, algorithmic and, programmatic coding. And then this both the tools like arithmetic tools will be used. The optimizations prior it will be chopped out like many numerical ranges. I need from this value to this well, what are the parameters can be tunable, and what direction this can influence the dose distribution. These are the optimizations prior to that optimization or prior to that the AI. So this is how that once you give that, the user prompting, so this will, chopped out like what are the observation, analyze and update. So you can see that, the dosimetric endpoints, this bar diagram compares like clinical planning and ChatGPT with optimizations. That means prior to the AI use, without the optimization. You can see the difference, in this all that star. That means ChatGPT with optimizations. Most of the the clinical goal are superior compared to that other planning. So this is what. Same thing in the box elongated diagram. This shows how that the ChatGPT based plan is superior than other one. And again, this steps can be of every time when the clinical goal is not met out. Probably every time it will keep on doing automatically without any human intervention. That is that actually important of this automatic planning. You can see that isodose distributions, how that clinical ChatGPT based and clinical treatment planning is improvised one. So coming to the summary, the proposed clinically ready workflow, the leveraging LLM based agent for inverse IMRT planning within that commercial TPS like Eclipse they have used using that zero shot setting. And the results show that the agent can generate treatment plan efficiently with the consistent quality. It demonstrates the potential of LLM based agent as a clinically applicable tool for automated treatment planning. So the future is towards that automatic. This is one of the very important exciting work they have presented in ASTRO. Thank you very much.
Thank you, Dr. V. Subramanian. The next presenter is Mr. Abhay Kumar.
This is not the, this is not the then it is not here.
Good afternoon, all. I would like to thank Kanika ma'am for giving me this opportunity to present this paper on behalf of Mr. Roman, deformable scintillator array dosimetry for in vivo volumetric dose and dose rate validation for ultra high dose rate proton therapy. So we all know the success of radiation therapy basically depend on two things: after post-treatment validation and pre-treatment verification. So there are generally for photon, electron and proton dosimetries are already established for daily QA and patient-specific QAs. But the problem arises when we move to flash therapy. As in flash therapy, we have to give almost 40 gray in less than a second. And for that to achieve, we need a detector which should have been measured in less time as well as more spatial resolution. As in these two curves, we can see the electrons and protons, the pulse time between them. And as we move to proton beam scanning, we can see the spot dwell time is less than 3 milliseconds, whereas the spot scanning speed is greater than 25 meter per second. The field size is almost 1.1 centimeter and the whole delivery take less than 1 second. So this is generally one of the 5x5 PBS dose rate, where we can see the dose rate difference between the distance of 4 centimeter is almost more than 50%. That is from 1200 to 200 is get. Whereas the equation given by dose rate is D dot PBS, where dx is the row dose and D dagger is the threshold dose, while Tx is the total time. So these are some of the available dosimeter system in radiotherapy, where luminescence, charge and chemical, which are basically available. The author has taken a scintillator detector for his purpose. He has used this because of spatial resolution as well as temporal resolution, which satisfy his needs. As we can see, the spatial resolution or temporal resolution of scintillator detector is quite linear with dose, rate, and with time also. So they have considered and constructed an array formed with this scintillation array, where they have checked the intensity as well as the dose rate also. As we can see in the graph that it fits perfectly. So how they did, they taken a stereo vision camera where they have overlaid it into a treatment planning system, that is a treatment planning room, where they have installed CMOS camera to measure the light intensity. So these cameras are basically left and right side of the camera which project their complete 3D centroid point clouds, which used to project at the ISO center, where we can directly use it on the patient to correct the angular corrections. They have derived the formula accordingly to fit the curve. So this provide an in-phase view and planned dose map accordingly. So after projection on the planned dose and in-phase view, the mean error they have seen is 0.32 mm. So now they have done this for a 2D. So now they started mapping it for a 3D. They place it under the planned CT to the room ISO center, which directly overlay and time resolved surface dose, which solve their in vivo dosimetry issues. So for that, they have converted the CT slide in water equivalent tissues, and on that they have scaled the PDD. In this, we can see a general Bragg P curve, and from this, they have taken the beam divergences also accounting. So in this, we can see they have deposited where the beam divergence because of the scattering is seen here. So after matching the difference, they have almost approached that 99.1% is the average passing rate. And they have used also for different threshold dose, they have measured it, and the passing rate was almost 99 in each case. So the conclusion is this is one of the noble dosimetry for in vivo, and the future directions can be they have not yet applied it for proton arc as well as conventional patient also they are trying to do. So thank you.
Thank you, Mr. Abhay. The next speaker is Didi Karaswal. The topic is improving SPR calculation for pediatric patients using novel imaging algorithm for tissue parameterization with photon counting CT.
हाँ जी भैया Good afternoon, everyone. I would like to thank Kanika ma'am for giving me the opportunity to present the paper titled Improving XPR Calculation for Pediatric Patients Using a Novel Imaging Algorithm for Tissue Parameterization with Photon Counting CT. The presentation has three objectives. First, to calculate the stopping power ratio directly from the patient CT images. Second is to use the monoenergetic CT images from photon counting CT and to compare the accuracy of this new method with the conventional method. So, proton therapy delivers the radiation precisely to the tumor while protecting the healthy tissues. But the biggest challenge is the range uncertainty. Therefore, the accurate stopping power ratio calculation is very important. Normally, a single energy CT converts the CT numbers into SPR using a lookup table. However, this method cannot accurately determine the chemical composition of the tissues, causing around 3.5% uncertainty in the proton range. Previous studies showed that the dual energy CT can estimate electron density accurately, but estimating the mean excitation energy is difficult because it happens on the tissue chemical composition. This study tries to solve that problem. Now, photon counting CT can identify photon energies and create virtual monoenergetic images. These images contain more information than the normal CT scans, making it possible to estimate the tissue composition more accurately. Tissue parameterization. In this method, each pixel is analyzed using monoenergetic CT images. The researchers first checked whether the monoenergetic CT numbers were accurate. Although there were small differences, the accuracy was good enough for the SPR calculation. ICRU 46 provides the standard chemical composition of the pediatric tissues. The researchers used the effective atomic number to estimate the initial chemical composition. Then they made the corrections to match the real patient tissues more accurately. The drop algorithm solves multiple equations to estimate the weight of each chemical element in every pixel. Before testing on the patients, the researchers performed Monte Carlo simulations using 11 pediatric tissues. As we can see here in the image, if it is distinguishable, we can see the 11 different samples are there in the image. The calculated chemical compositions were compared with the reference values. Most tissues showed only small differences, indicating that the algorithm is reliable. Using the calculated chemical composition and electron density, SPR was estimated. Most tissues had very small errors and only cortical bone showed a slightly larger deviation. After successful simulations, the method was applied to a real pediatric abdominal cancer patient. Monoenergetic CT images were used to calculate the tissue composition and the SPR. This slide shows that the reconstructed maps of the different elements such as hydrogen, carbon, oxygen and calcium. These maps are important for the accurate SPR calculation, and the data was taken from the ICRU 46. In real patient data, the deviation was higher than in the simulations because human tissues are more complex and some tissues are not included in the standard database. This slide compares the SPR obtained using the conventional CT single energy method and the proposed monoenergetic method. The new method provides the more improved accuracy for many tissues. The main challenges are accurate effective atomic number estimation, limited pediatric reference tissues, and CT artifacts such as scatter and beam hardening. These need further improvement. In conclusion, the photon counting CT combined with tissue parameterization can improve the SPR calculation for pediatric proton therapy. Although the results are promising, further validation and improvements are required before clinical implementation. Thank you.
Thank you, Ms. Phil. Next, I privilege to call Mr. Rakesh Kaur. His topic is a novel fluorescence lifetime imaging integrated with optical transparent regions for quantitative in vivo imaging.
Good afternoon to everybody. First of all, I must thank the organizing committee for giving me opportunity to represent this forum. And today's topic is a novel fluorescence lifetime imaging integrated with optical transparent agents for quantitative in vivo imaging, which was originally presented by Lexan Go and his team. So as we know, the lifetime imaging is a technique of measurements, and it depicts the average time the molecule spends at the excited state, and after emitting the photon emission that it returns back to this ground state. So in conventional this intensity-based images, which is dependent on interesting factors such as the molecule concentration, light powers and the photo bleaching, while as FLI is independent of these factors, and FLI is sensitive to tumors, is a microenvironment such as the pH factor, viscosity and the oxygen, and providing a unique insight for preclinical cancer research. And in optical transfer agents, there were challenges in deep tissue imaging. Scattered effects diminishes fluorescent signals, limiting imaging performance. So recent study shows that absorbing dyes such as tartanzine, which is FDA approved, can achieve optical transparency in living animals. This way, it reduces the refractive index contrast within the tissue by increasing the refractive index of the aqueous components. That means in and out of the molecule in the deep tissues can be smooth, so that the image can be possible in a fine way. So hypothesis, the use of the optically transparent agents can improve photon penetration depth, thereby enhancing both the spatial resolution and the quantitative accuracy of fluorescence lifetime imaging in preclinical research systems. The main components of the FLI system is the pulsed laser. It delivers the pulses. This 400 to 850 this micro this meters in the frequency of the 78 hertz, and this and it is the components also contains the this camera, which is a complementary metal oxide semiconductors, and is a fast gated and is very high resolution camera, and it is incorporated with the intensifiers, and this and the other parts of this is the zoom lens, which enables the adjustment region of interest and magnification, allowing imaging at both microscopic and the macroscopic scales. So if we look at the features of this macroscopic and the mesoscopic, so the region of interest is in diameter is 3 centimeters, while for mesoscopic is 4 mm, and pixel size is 35 microamp versus 3 mm. So the flexible imaging capability provides the spatial resolution to monitor tumor growth patterns across large organ regions, and also the tumor spatial heterogeneity at finer scales can also be possible. So if the evaluation of the characterization for sensitivity and specialty, this well-plated system is used. So this well-plated solutions is diluted in the IR dyes 800 in this in different buffers of different concentrations and in different conditions. So if we look at the first picture, which is possible that this IR dyes lifetime at different concentrations, you can see there is a consistent reading in this. So it gives that it is a sensitivity. It represents sensitivity of the this IR dye solutions. And for specificity, they have used different consider 10%, 20%, 50%, and 70% this ethanols. So this readings are distinguishable. It's lifetime by 0.1 nanosecond of difference in various buffers. So this the experiment is done. You can see there two capillaries are placed 1 centimeter apart. This capillary 1, it is a 10% ethanol, and capillary 2, it is 20% ethanol is placed. The two glasses capillaries 1 centimeter separated with different buffers covered by chicken breast slices, and this capillaries at the rate of 2 mm depth. So if the image of the original is taken and with the tartrazine is taken, you can see the difference in these imaging. So you can see the difference. So image profile, you can see image contrast. In the original it is 8.1, while in the tartrazine it is 30.2. So this way we can enhance the image based image contrast greater than 3%, and also we can this in capillary 1 you can see it is 6.3 versus 0.2. So this way we can decrease the error of lifetime results by 6% in capillary 1 with short lifetime. So in vivo experiment, which is an ongoing work by this team. So this fluorescence lifetime imaging differentiates the specific binding to tumors and non-specific accumulating in surrounding tissues. Plus optical transparent agents reduce the skin scattering and improve photon penetration. So this way we can enhance the spatial resolution and the contrast and tumor to background of fluorescent imaging to investigate the tumor spatial heterogeneity. So in conclusion, FRI system can recover fluorescent lifetime in sub-micro mm concentration distinguishes lifetime in different molecular environments by 0.1 nanoseconds, showing that sensitivity and specificity of the solutions. The use of the optical transfer agents can be significantly improve intensity resolution by increasing the image contrast in 3 times, as explained earlier, as well as they improve the lifetime resolution by enlarging the lifetime contrast. And this is the future work they are doing. In vivo applications improve spatial resolution of fluorescence tumor imaging, facilitating the visualization and tumor heterogeneity. Thank you very much.
Yeah, very good afternoon. Myself, Dr. Brahman and Chatpati. It's my pleasure to get a chance in Best of Astro, and thanks Dr. Kanika Sood Sharma Madam to giving me the opportunity. Today, I highlight the procedure, the changing scenario that is a simply evolutionary from the radiation oncology, from the 2-dimensional to the 3-dimensional with 4D CT. Now it is coming to the era of the radiation therapy by proton, that is in the sitting position. And this is the principal investigator from Leo Cancer Care Center, Kerry Clyde Host, J. Slonowski, Y. Yan, J. Miller, C. Hoffman, A. N. Sander, B. Barger, C. Harari, M. Kang, S. Orelli, B. Turki, M. Harari. It is, you see, this is the team acknowledgement from the Leo Cancer Center, and this is the treatment plan of the proton therapy. You see, this is the huge area, and it needs the treatment of the patients in a very specific manner, and we're giving the high dose with this type of the protocol. And this is, you see, this is they're highlighting the infrastructure of the construction of the proton treatment, and from the Leo Cancer Center, the best cancer care, now it is coming to the treatment in upright position. When the patient comes, it will go to the proton beam suit. Yeah, in that everything will be treated in a sitting position, CT simulation in the sitting position, and the treatment contouring done after the fusion with the deformable registration, and then the treatment is with the upright position. This is the something examples like head and neck cancer, breast cancer, brain tumors, and different the modality. And for this thing, the characterization of the XYZ is more important. For this case, you see, because when you are treating no doubt your XYZ, and along with this, we are doing the rotational treatment along with the pitch and row. And like what you are treating, the treatment in SRS and in the 7F treatment. Yeah. This is, you see, this is the you are giving the XYZ in rotation 360, Z translation is 70 centimeters, and Y is around 55 centimeters, X is around 30 centimeter travel. And person positioning, when you're doing the treatment, we are giving the treatment in the sitting position. It is a very arbitrary, it is a very principle of our radiation physicist and the radiation oncologist team to give the very precise. Because if anything, no doubt why it is given the sitting position, we are thinking. Because you see the proton treatment, when a gantry is moving, it is very heavy. It is like the 2000 kg, like the gantry around approximate in our this part. So there's highlighted that treatment, so that maximum safety, maximum energy saving, and better treatment position, and that the treatment protocol is mostly equivalent, and is the supine position and the upright position. You see, they're taking the CT scan like this, and after that, the CT image is transferred to the system, treatment planning system, and after that, that is a treatment is given. You see, this is one slide how the CT is given, you see. In this position, CT is taken, and after that, that CT we are do you see in the different rotation also, because there is a rotational error, we are giving the high radiation dose to the, like if it is needed the stereotactic treatment or it is a conventional treatment, according to the XYZ along with the all the peaks and row we are taking the CT. And why that is important, but as a radiation oncologist, for a doctor, we know it is we have to think of the organ motion. No doubt you give the radiation in high precision, but along with this organ motion, we think about is precision delivery, patient comfort, and patient flexibility. We are thinking of all this. And our physicist team, they will do the quality assurance for the proton treatment is very efficiently, and this is the special treatment. I'm not going in details. Along with this, the end-to-end QA results is doing on, and this is the IGT testing before giving the treatment, because you see this is the phantom model. We are giving the XYZ correlation will give best. And if you need to change the light bulb, this is why that happens, why the thing like this. Suppose the gantry is so heavy, it is needed for treatment on patient in the lying down position, the gantry is moving. So you see, this is the demonstration, I am not giving details. Yeah. And by this contouring is important, because deformal image registration, we transfer this thing in the all this, and the science behind the proton treatment, you see this is the tumor, and where is the, so it is close to the spinal cord, you are giving it, the brake peak is there, you are giving the radiation. So motivation of the upright CT, why it is important, when is the patient treatment in the lung cancer and the abdominal tumor, you see the increased long volume at axle, favorable heart shift, reduced tumor lung execution, decreased mean lung dose, and in abdominal some cases blood elongation, more anatomical time. And this is the example of the, you see in the proton treatment in the sitting position, that is a difference, and there is a like a huge difference, and all comparable whether you giving the supine and the like the sitting position. And this is the one prostate treatment plan, and this is one on the tumor in the the orbital ocular region, that also that solve the purpose. And you see the final, the conclusion is this, the ray station, cystic crowd fracture staging, along with the CT simulation, along with this we can do the planning, and we give the treatment in a better way, and to reduce the cost, saving the patient's life, and you are giving the more precise, accurate treatment. So the further evolution and the next generation, I think in the next future, I think it is a future of nowadays in radiation oncology proton therapy, and the next future is this, we can need the more sophisticated treatment modality along with the data, more data you have to publish, and future is further optimize the CT protocols to enable more precise calibration to support upright proton additive therapy. And along with this, I'm just highlighting to this patient is the first, I mean, treated in the worldwide, you see. Okay, this is my pleasure to giving this thing with you. Thank you.
Thank you, Dr. Sitavali. The last speaker of this session is Dr. Vikas Kumar. The topic is role of Coursera in treating radiation-induced edema and necrosis in brain tumors.
Yeah, right. Yeah. Because for the prostate treatment, hello, sir. Yeah. Yes. Yeah. Thank you.
Good afternoon. Thank you organizers once again for this opportunity. So in next few minutes, I'll be speaking on role of Boswellia serrata in management of radiation-induced cerebral edema and necrosis. So this talk is officially sponsored by UNV CanCare Private Limited. So if we look at the incidence of edema and necrosis in clinical settings, it's mostly seen after radiosurgery, and it is in the tune of 5 to 20%. And mostly it is seen in the setting of re-irradiation. And out of these, almost 50% are symptomatic bothersome radionecrosis. Although everything depends upon cumulative dose, volume, technique, etc. Current standard of treatment is corticosteroids, anti-VEGF, lasers, and sometimes hyperbaric oxygen. But what we face with steroid is actually long-term steroid toxicity. It affects bone health, the glucose intolerance, the lipid metabolism. It causes steroid-induced myopathy. It causes skin atrophy and thinning, and many more. Another limitation is that steroids interfere with immunotherapy, which is being used very widely these days. Bevacizumab has own toxicities, including financial toxicities. So there is always a clinical need of some robust alternative. So if we look at the history of Boswellia serrata, so in ancient times in Ayurveda, it was used as a medication to relieve pain and inflammation. In 1960s, we could know the phytochemistry of Boswellia serrata. It was actually acetyl ketoboswellic acid, which was its active metabolite. In 1990s, we had some systemic anti-inflammatory evidence in the treatment of inflammatory bowel disease, rheumatoid arthritis, osteoarthritis, and bronchial asthma. Between 1996 to 2023, we had few papers supporting its role in management of radiation-induced edema and necrosis. 2025 was a landmark year for this molecule. So there was a largest retrospective cohort analysis by Rituraj et al. And there was a systemic narrative review from Germany. So we'll discuss in detail later on. So how it acts? It acts by inhibition of lipoxygenase and cyclooxygenase pathway, thereby reducing the mediators of inflammation, which is largely leukotrienes, prostaglandins, and pro-inflammatory cytokines. These anti-inflammatory mediators, they cause reduction in edema. Apart from this anti-inflammatory effects, it reduces oxidative stress and it improves microcirculation, which eventually leads to helps in limiting the necrosis pathology. So coming to evidences, the first evidence in favor of cerebral edema was published in 2001. So there were 12 patients in a prospective single-arm study. 11 were of glioma, 1 was of metastasis. It was used as a 1200 milligram thrice daily. 3 out of 5 patients had edema reduction, which was related to treatment related, and 2 out of 7 patients had edema reduction in tumor progression related edema. So in this study, steroids were reduced and withdrawn in approximately 25% of the patients. Second study, which is only randomized trial published till date, it had 44 patients. Patients received RT involving almost 60% of the brain parenchyma. 75% of them underwent whole brain radiation for whole brain, and 25% of the patient had glioblastoma. So what we found in this study that more than 75% of reduction in cerebral edema happened in 60% of the patient with Boswellia and 26% in placebo arm. And the difference was clinically significant, but the major drawback was the response was not durable. The effect could last for only 4 weeks. Another Evidence in favor of edema was from DiPero et al., which was published in 2019. There was 20 glioblastoma patients. All patients were on dexamethasone. In this study, lecithin-based boswellia was used, and it was started during first week of chemoradiation, and it was continued throughout the maintenance phase up to 34 weeks. Proportion of patients with stable edema increased over time, and dexamethasone could be reduced or maintained without escalation in a substantial population. Coming to evidence in context of radionecrosis, the first study was published in 2023 by Warnick et al. So this was a very small study containing only 3 patients, but all 3 patients were of corticosteroid refractory radiation necrosis. Boswellia was used in very low doses. I don't know why. It was 150 milligram twice daily with dietary fat. And all of the 3 patients experienced resolution of symptoms, improvement in imaging abnormality, and successful corticosteroid discontinuation. There was no adverse effects reported. Coming to the most robust study till date by Rituraj et al. It was a single institution retrospective cohort analysis from Ohio State University. So there were altogether 94 evaluable patients. The dose of boswellia was 4050 to 4500 milligram per day. Treatment was for more than 2 months duration. Primary endpoint was assessed with objective response rate and more than 30% reduction in T2 flare edema on MRI. Median SRS dose was 24 grain, 3 fractions. Median time interval was 14 months. Median boswellia duration was 7.8 months. The radiological response was defined as complete response when there was complete disappearance of edema, partial response where there was decrease in edema volume by more than 30%, stable edema as decrease in edema volume by less than 30%, and progression of edema if there was an increase in edema by more than 25%. So coming to patient stratification, so the entire group was dichotomized between 2 groups. One group was low or stable steroid requirement group, and other was increasing steroid requirement group. The lower stable steroid requirement group was where had those patients who either never received steroids or received prior steroids only, or stable or decreasing dexamethasone less than 4 milligram per day. So the objective response rate was almost 63.8% in low or stable steroid requirement group and 48% in increasing steroid requirement group. So this represents an association, because this was a retrospective study, so this represents an association rather than proof of steroid sparing effect. And the key takeaway was early initiation of boswellia in such patients with low or stable steroid requirement is associated with higher response rate and lower risk of edema progression. So this slide represents a beautiful waterfall plot showing almost 86% of the patients showing edema controls. It's an overall outcome. The outcome represents both group actually. And the edema control was meaningful, sustained, had sustained radiological improvement with increasing response over a period of time. So strength of this study was, it is the largest boswellia cohort study published till date. It showed an objective MRI-based response assessment, demonstrates a clinically meaningful steroid sparing effect, and it is particularly effective, attractive for patients who are on immunotherapy. The limitations are, it was a retrospective study from a single institution. There was no placebo, there was no control arm, and steroid doses were variable. So coming to the clinical evidence at a glance, so in most of the studies, the edema control or the response rate was in the tune of 50 to 60% with reduction of steroid doses or discontinuation of steroid in almost 1/3 of the patients with acceptable side effects. Coming to uses in pediatric patients. So as of now, there is no robust evidence of uses in pediatric patient. Rather, I come to this study in which they discouraged the use of boswellic acid in pediatric age group because these were found to promote cell growth and stemness properties in pediatric high-grade glioma cells. So why bevacizumab, whether we should use or not, or why, if not, why, or if yes, why? So if we look at the response rate in comparison to bevacizumab, it has similar median response rate of around 60%, and it carries severe side effects such as gastrointestinal perforation, delayed wound healing, thromboembolic events, and hemorrhages. So with regard to doses, safety, and monitoring, the total dose recommended is 4,000 to 4,500 milligram in 4 divided doses. It is encouraged to have this medication with dietary fat, and we need a 4 weekly LFT monitoring and toxicity scoring as per CTC criteria. So despite all these studies, there are evidence gap. There is no randomized controlled trial till date. There is product heterogeneity confounds cross-study interpretation. There is gap in flare non-specificity and attribution ambiguity, which is unaddressed in prior design. So Boswellia's RT trial can answer these questions or can fill these gaps. So in this, this is a phase 2 randomized trial from a single center. Accrual is still going on. So the eligible patients are going to be with delayed symptomatic steroid dependent radionecrosis. RMA is going to receive Boswellia at a dose of 4,500 milligram per day with tapering of dexamethasone, and arm B will receive dexamethasone in tapering doses alone, and median follow-up has to be like 6 months and then forward. So this results of this study will answer many things. So one is the take-home message from entire review of literature is that current evidence supports this molecule as a promising adjunctive therapy for radiation-induced cerebral edema and radionecrosis with anti-inflammatory effects and potential corticosteroid-sparing benefit. Approximately 50 to 60% patients demonstrate clinical improvement, with nearly 1/3 were able to reduce or discontinue corticosteroids with predominantly mild gastrointestinal toxicity. But despite these encouraging results, the evidence remains low to moderate in quality, limited by small sample sizes, heterogeneous formulations, dosing schedules, and outcome assessment methods. So it could be currently considered as an adjunct, not a replacement for steroid or bevacizumab, until adequately powered prospective randomized trial establish its efficacy, optimal duration, dose, and treatment of duration. Thank you. Thanks. Any questions, Gagan? Yes.
Any experience with mucositis in this compound?
So I have till date I have used in 5-6 patients. I didn't come across this mucositis related.
Any studies?
Any studies? It's a gastrointestinal side effect, so it can involve GI mucosa as well. But main, derangement was related to LFTs.
I'm saying my question was that since this is such a nice anti-inflammatory, how will it work with mucositis, radiation-induced mucositis?
Are there any studies? That was the question.
Okay, I didn't come across. I didn't. I could not
Another
try to
question,
find it.
yeah, another question is linked to this only. Like in brain tumors, we see post follow-up edema, and we face a lot of problem, whether it is a recurrence or edema, and then where we can use it. A similar problem we face in head and neck, especially in the laryngeal tumors. Lot of edema is there. So can we
Yeah,
try
we
it there
can.
also?
It's a good question. We can use the science behind it actually.
Yeah, if it is reducing the edema in
Yeah,
brain,
reduces
crossing the
inflammatory
blood-brain barrier.
cytokines. It inhibits lipoxygenase pathway, cyclooxygenase pathway. So we were using this and COX-2 inhibitors in many conditions. So that analogy can be applied here as well. So, but it needs to be tested on a
Because lot of times this edema you can't make out it is a recurrence and or it's a edema. So lot of time patient undergo laryngectomy and then the histopathology comes no tumor found. It's only the post radiation changes. So we try. I think we can try it there. And
yes. Thank you so much. So,
Thank you so much, sir, and special thanks to our chairpersons. For the next session, I would like to invite Dr. Robin Khosa, sir, radiation oncologist, Apollo Hospital, Indraprasth. Dr. B.N. Sadapathy, sir, HOD and senior consultant, radiation oncologist, KMC Cancer Institute, Merit. Sir, I request both of you to please grace the dais.
May I invite the next speaker, Dr. Ave Chakravarti, College Doc.
Good afternoon, respected chairpersons, faculties, and delegates. At the outset, I would like to thank Kanika Madam for giving me this opportunity to present this trial. So we'll start off with the SACRO trial. The SACRO trial's first author was Professor Piero Fossati, who is the director of MedAustron Ion Therapy Center, Austria. The author has no conflicts of interest to disclose. SACRO stands for Sacral Chordoma, a randomized and observational study on surgery versus definitive radiation therapy in primary localized disease. Now, this trial was initially based on another paper published by Imai et al. In Red Journal in 2016, which determined the local control, overall survival, and DFS in 5 years for unresectable sacral chordoma receiving carbon ion radiotherapy, which was at the rate of 77, 81, and 50% respectively. 32% patients had metastasis. So coming on to the study, patients were given 3 options, either to undergo surgery, definitive radiotherapy, or to undergo randomization. Adjuvant radiotherapy was considered only on those patients who had R1 or R2 resection. The primary endpoint being relapse-free survival, secondary endpoints being overall survival, survival post-progression, local and distant relapse failure, best response rate to definitive radiation, and post-treatment morbidity and quality of life evaluation. So a total of 23 active sites are present in 7 countries and more are getting recruited or joining. Out of the 18 centers in 6 countries, 175 patients were screened, out of which 3 were not eligible, 2 patients failed screening, and 17 patients did not complete their baseline case report forms. So finally, 153 patients were included in the final analysis, that is the 4th interim analysis. The first patient was taken in 2017 up till the last patient, that is the 175th patient in 2024. 153 patients being assessed. None of the patients chose randomization. 69 patients chose surgery and 84 patients chose definitive radiation. As you can see, maximum of the patients with high tumors, that is tumors in S1 to S3, chose radiation, whereas those with low tumors chose surgery. 6 patients received postoperative radiation. Coming on to the radiation, so for the carbon ion radiation, it was given in two forms, either the Japanese style or the German style. Japanese style being 73.6 gray or 76.8 gray in 16 fractions. The German style being 66 gray in 22 fractions RBE. And the proton beam therapy, which was received by 10% of the patients, was at a dose of 73.5 gray RB in 35 fractions. Now, if we come to the relapse-free survival, for if you include both the radiotherapy in the surgery arm, including all patients as well as in the high tumors or the low tumors, it was comparable with a median follow-up of 36 months. The overall survival was also comparable between the two groups. With respect to the toxicity, the grade 2 toxicity was much lesser or no difference between the two groups, whereas grade 4 and 5 toxicities were much lesser in the radiotherapy arm, and mind you, it was statistically significant. With respect to the quality of life, there was no difference, which was determined by FACT-G questionnaire and the brief pain inventory. At the outset, I would like to conclude by saying that particle therapy is a valid alternative to surgical resection, as there is lesser toxicities, that is grade 4 and grade 5, but randomization was not done. This is a prospective parallel cohort study. So this, as a result, creeps in the selection bias, wherein good surgical candidates were considered for surgery, and hence I would like to conclude that for determining the type of therapy, we need to have a multidisciplinary expert evaluation or an objective criteria, that is clinician's decision. So further trials are required to validate this study. Thank you.
Thank you, Dr. Abhay Chakraborty, giving the nicely evaluate the treatment for the cerebral coloma, and you're putting that is a comparable trial, that is the surgery versus the surgical resection followed by radiation. I think more trials is needed for this. Already, have you any go through any literature showing this is the radiation therapy with the proton therapy is very good alternative, and out of the responsibility.
So pardon me, the question, could you repeat?
Yeah, because you are telling the surgery is comparable for the radiation therapy.
Correct,
if
sir.
you're going to the trials, just what is the survival, the disease-free survival, you've gone through this.
Sir, I...
Yeah.
Okay. Okay, thank you. Thank you.
Next speaker is Dr. Babita. Babita.
A very good afternoon, everyone. And thank you, Dr. Kanika ma'am and team, for inviting me today to present this study here. So I will be talking about the role of adjuvant primary site radiotherapy for cutaneous melanoma patients with microsatellitosis. The study was done by Kelsey N. Noran, VS, and it was presented in the current ASTRO meeting. So the primary objective of this study was to evaluate the outcome for patients with cutaneous melanoma and primary site microsatellosis in the contemporary therapeutic area. Now, as we all know, the current treatment for melanoma has significantly changed over the past 15 years. We have good immunotherapy, and even the surgical techniques have improved. So now we are, this study was specifically focused on evaluating whether microsatellitosis is, what is the outcome for these patients when we add radiation therapy, plus the effect of adjuvant primary site radiotherapy in this very specific population. All right. So what are the risk factors for the local recurrence? Despite all the advancements, there are certain risk factors which are very well known to all of us, which is desmoplastic histopathology, breast low thickness, perineural invasion, a positive surgical margin, and a head and neck primary. All these factors put the patient at risk for developing a local recurrence despite all the advancements in systemic treatment. When we specifically focus on the head and neck primary sites, here we have to balance the cosmesis as well as the local and systemic control. Now, does adding radiation have any role, or it just adds to further morbidity? What exactly is microsatellitosis? Now, these are microscopic discontinuous melanoma deposits adjacent to the primary tumor site. This is seen only on histopathology, and it is different from macrosatellitosis. It is an indicator of poor prognosis because it is associated with a high regional recurrence risk, and specifically upstages the patient to a stage 3. Now, this is a brief data that has been sourced from Warren, published in 2025. Here, the local regional recurrence when microsatellitosis was present was to the tune of 54% versus when it was absent to a tune of 26%. And this also translated somewhat to the distant recurrences, that is 38% versus 31%. Coming to the methodology of the study, the retrospective review of all cutaneous melanoma patients which were treated at MD Anderson Cancer Center in the era 2016 to 2023. This is specifically when immunotherapy had already come and was being used. The patients were clinically N0 and M0 at the treatment. There should be no in-transit disease or macrosatellites. In-transit diseases, that is when the primary site and the sentinel lymph node, if you have any metastasis in between that, and macrosatellites are the gross clinically palpable or radiologically seen tumor deposits away from the primary tumor site. And the follow-up had to be at least for greater than 3 months after surgery. The patient disease characteristics were well balanced in the no radiation as well as the radiation group. As far as gender, the primary sites and everything was concerned. The perineural invasion, lymphovascular invasion, and the median breast lobe thickness, all the factors were well balanced in both the arms. Now, treatment characteristics. This was basically the decisions were taken in their tumor board, and this is the balance as far as the other adverse factors that we consider, which is the margin status and the sentinel lymph node biopsies. So both these arms are well balanced in both the situations. Some patients also received systemic immunotherapy and targeted therapy. Now, coming to the results, when we talk about the local control, this above arm shows the arm which received radiation therapy. The patients had microsatellitosis on the histopathological specimen, and at the end of 12 months, these curves start to separate, and we see approximately 89% local control for the arm which received radiation therapy versus 72% in the arm which did not receive radiation therapy. Now, this is a median follow-up of 38.6 months, and it was statistically significant, pointing towards the requirement or maybe consideration towards adding radiation therapy in these patients. When no radiation was given, local recurrences were to the tune of 25%, and when radiation was used, it was to the tune of only 5%. Now, this is what the study was aiming to establish, and this also kind of translated into further recurrences. That is, the control was better in the arm which received radiation, 15 versus 40%. In transit recurrences, in radiation arm, only 19% versus 52% in no radiation arm. And distant metastasis, 24% recurrences in radiation arm versus 61% in no radiation arm. So the hazard model shows when we are adding primary site radiation therapy, the hazard ratio is 3.6. It simply translates to the fact that of a patient who did not receive radiation therapy and had a high risk factor of microsatellitosis was at a risk of developing local recurrence to the tune of 3.6 times versus the patient who received radiation. So to conclude, patients with melanoma microsatellites, they have a higher chance of recurrence even in the contemporary era. And 3-year local control in this present study, it did rise from 72% to 89% when adjuvant radiation therapy was added. So patients should be referred for consideration for post-op radiation therapy in this situation. Thank you.
Thank you, Dr. Ravita Mansan, giving complete information about the adjuvant treatment of radiation therapy for the patient with kidney cancer. Okay, thank you.
May I invite the next speaker, Dr. Rajesh to speak?
beside thanking Kanika for this opportunity, being the last speaker of this session or of this wonderful conference, it's my duty to congratulate on the behalf of all the participants to Kanika for having such a wonderful conference for 2 days of academic excellence. Can we have a round of applause for her? Can large round of applause. So no, you deserve it. So let us start. The topic for the last abstract is it is a single arm prospective trial of postoperative 36 gray radiation in 10 fractions for Merkel cell carcinoma. The authors have no disclosures. The objective of the study was to evaluate the tolerability of hypofractionated adjuvant RT for Merkel cell carcinoma, determine the in-field disease control with hypofractionated RT and estimated oncological outcome with this approach. We all know Merkel cell carcinoma is a very rare, aggressive neuroendocrine cutaneous malignancy, and around 2,000 cases per year are diagnosed in the US. And with the incidence is rising because of immunosuppression, the people having immunosuppression increasing because of disease like HIV and also transplant. 90% patient present with local regional disease, and they have a high risk of recurrence or the distant metastasis. Multiple meta-analyses have shown that RT decreases the local recurrence with a hazard ratio of 0.2 to 0.3 for conventional RT dosing was initially defined by the Queensland experience. The dose of more than 50 gray for subclinical disease and more than 55 gray for the cross disease was established. And generally it was supported by NCDB survival analysis, and some suggest that 40 gray may be enough for the low risk patients. Considering the hyperfractionation, it has several advantages which can be considered. Since immunosuppression patients have worse outcome, shorter course of RT will lead to lesser immunosuppression and less morbidity. Similarly, neoadjuvant or adjuvant immunotherapy are nowadays increasingly used for the treatment of Merkel cell carcinoma. Nodal RT in particular may work against the immune checkpoint inhibitor. It has been noted in the studies, as you can see in the survival curve on the left. It's a radiosensitive histology, and it's also the hyperfractionation has also lower cost and the patient convenience because the radiation ends early. The only possible disadvantage is that it sacrifices generally the well-tolerated therapy or the excellent efficacy in the absence of any robust data. Prior experience with hypofractionation was by the Seattle group at the University of Washington. They have treated 8 gray single fraction or 8 gray 3 fractions, and another group at by Liu et al. They have given retrospective experience of using 20% hypofractionated versus 80% conventional RT. They showed the 2-year in-field recurrence of 4% versus 1% with the hypo and the conventional RT. So hypofractionation was usually used in the old patients, which generally have a worse prognosis and overall survival. So this is the biological basis for considering the dose in this study, 36 gray in 10 fraction, equivalent having EQD2 equal to 40.8 gray, and then normal EQD2 to 47.5 gray. So it was a single phase 2 single arm clinical trial of moderately hyperfractionated adjuvant RT. Objective was 2-year local control estimation of adjuvant RT at primary site and estimated 2-year nodal control of adjuvant RT at nodal basins. And the secondary objective was other oncological outcomes along with the toxicity. This is the schema of the study. The patient which had positive or close margin after surgery or size of more than 1 centimeter LBI and PNI and prior had a local recurrence were taken, and nodal RT was given to also 20 patients, more than 20 patients had nodal RT. A few patient had the sentinel node biopsy. If it was positive, then no RT was given because if the nodal dissection was done, the adjuvant the RT was given if the more than one nodes were positive, tumor size was more than 1 centimeter, or external extension was present. So, and the end of the treatment, the toxicity was acute toxicity and late toxicity assessment was done along with the survival and recurrence at the end of 2 years. So between 21 and 2025, 37 patients were enrolled, or adjuvant primary RT was given to 16, nodal basin RT was given to 6, and both primary plus nodal stations were treated in 15 patients. So for the local RT were 31 patients were there. For nodal RT, 21 patients were there, and last patient was enrolled in June 25, and last update of the trial was published in August 25. So median overall survival for at the end of 16-month follow-up was only primary target where RT was given was 25 months, including primary target, and nodal it was 17 months, including the primary only was 25 months. When including the nodal target it was 10 months, and including primary target it was 17 months. So these are the disease and patient characteristic. I think these are the RT details. In the interest of time, I'll skip it. This was the preliminary toxicity. 84% had grade 1 to 2 radiation dermatitis. Other minor toxicities of grade 1 were fatigue, pain, dry mouth, or radiation mucositis. Late toxicity data is still pending. And these are the primary outcomes. There was no local failure, 0% local failure. Any overall failure were only 7, total of 19%. No local failure, no in-field recurrences. Any nodal failure was 5 patients, that is 14%. In-field nodal local failure was 3%. In-transit metastasis in 5% and distant in 11%. Usually the nodal in-field recurrences were seen in the immunocompromised where more than 2 nodes were positive, unable to tolerate immunotherapy, adjuvant immunotherapy, and develop lymph node metastasis after the dissection. These are so to conclude, adjuvant RT of 36 grain 10 fraction is very well tolerated, both primary and the nodal sites. At 16 months of median follow-up, 1 patient has developed in-field recurrences. Nodal or the primary control site is 100%, nodal control is 95%, and further follow-up for the long-term toxicity is required. And then thanks to all for patiently hearing.
Thank you, Dr. Rajesh Panicha, giving the brief adjuvant treatment for the mantle cell carcinoma and the charm to the audience. Thank you. To may invite Dr. Kuldeep Sharma to moderate the session. Please welcome. Welcome, sir.
So good afternoon, everyone, and thank you, Dr. Kanika and organizers for having me here. And once again, thank you for staying back till afternoon, Sunday afternoon. So now I will be having a panel discussion in which we will be discussing around the last 3 abstracts that has been presented here. So I will just call my panelist, Dr. Abhay Chakravarti. He's a radiation oncologist. Dr. Babita Bansal, she's again a radiation oncologist. Dr. Rajesh Pasricha, and Dr. Prachi, she's a pathologist. I wish we had some surgeon. Is there any surgeon who can just join? Okay. So I will not be discussing the abstract as such, not the methodology, but I will be discussing the basic philosophy behind the treatments that have been done. So coming to the first abstract regarding the sacral chordoma. So we all know that chordomas are the locally aggressive and infrequently metastasizing neoplasms. They generally have a predilection for local failures, and they are more common in males. So Dr. Pasricha, since you have a long experience in radiation oncology, so in practice, how do you see the distribution in cord?
Skull-based chordomas are more prevalent than sacral chordomas. Overall, they are very rare. Means in a year we do see 2 or 3 cases, but mostly they are skull based.
Okay. And
It can be referral wise because we have a good neurosurgery department, so maybe.
okay, so as such, we do not see much. Maybe the surgeons see a lot of chordomas initially, and so as a radiation as an oncologist, if someone comes initially to you with a sacrococcygeal mass, then what differential diagnosis clinically comes to your mind, Dr. Babita?
Like we do a detailed workup for all cases. Lesion could be sarcoma, it could be a chondroma, it could be Ewing sarcoma, or a deposit from multiple myeloma, or a metastatic disease, deposit from any other site. And benign conditions also you have to keep in mind. It could be tuberculosis or osteomyelitis also. So we have to take in mind the imaging as well as the histopathology.
Yeah. So it is always good to have a complete workup and a multidisciplinary approach for these tumors. So are you aware of any oncological marker these days, like any tumor marker or any marker? Maybe the pathologist
The
can answer.
hallmark of chordomas is always brachyury,
Yeah.
which is actually encoded by TBXT gene. And in chordomas, there is a duplication of this T gene. Earlier, we used to call it as a T gene, but nowadays we call it as a TBXT gene. And other signaling mutation pathways which are involved in chordomas are PI3K signaling mutation. Then even we can see come across LYST gene. And the rarest is we have even found the phosphorylated and EGFR mutation. That's why if we give anti-EGFR or anti-HER1 therapy to the patient, it will reduce the tumor load.
Yes. So this was one interesting thing that I came across, that yes, this biomarker which is called brachyury, actually this is a substance that is required for during the embryonal development, but once we become adults, its level goes down. But when chordoma happens in our body, it generally overexpresses. So it is a very good tool for identifying diagnosis, and in future it may become a very good tool to therapeutically target in chordoma patients. So, Dr. Pasricha, what do you think what is the best approach to treatment for chordomas till now as a standard?
We used to refer the patient mainly for the surgery if it is possible, or maybe even debulking if it is possible, followed by adjuvant RT. And if nothing is possible, then the high fraction RT is used. If patient can afford, then probably we refer him preferably for a proton beam irradiation.
Yeah. So, do you till now, was there any incidents where you will consider a patient for definitive RT even if patient is a candidate for surgery? Is it common?
Only when patient refuses surgery, maybe, or some comorbidity, then probably we can consider.
Yeah. So, so this was the basic new idea that came from that abstract which was presented, that they have used particle therapy in those cases also in which there was no contraindication to surgery and patient was willing also. So if we consider the conventional radiation, what is the challenge with routine photon radiation? Maybe, yeah, anyone can take this question.
So with respect to conventional radiation, there is increased risk of toxicity to the surrounding tissues. So according to the ESMO Eurocan guidelines published in 2018, they have said that the limit for the minimum dose should be greater or equal to 74 gray. So such a high dose, if we give it by conventional, that is the photon therapy, then there is a high risk of toxicity to the surrounding OARs, that is the sacral nerve roots, the bowel, the rectum and the bladder. Whereas on the contrary, if we consider particle therapy, such as in this case the carbon ion therapy or the proton therapy, since there is no exit dose and there is greater conformity, the toxicity to the surrounding tissues, especially the sacral nerve roots, is much lesser.
beside that, there's a very solid radiobiological basis. It's a very slow growing tumor, probably very low alpha by beta. Photon may not be that potent for inducing a single double strand break. So in that case, definitely proton or the high LET radiation will be of use, because the particle deposit much more energy as compared to photon.
Yeah, so maybe this was the reason that till now it has remained a domain of surgeons, because we didn't have a tool which can very effectively address this issue. So now, now we have options. So the option comes in the form of hadron therapy in this scenario. So when we say hadron therapy, most of us know that here we use highly accelerated particles like carbon ions and protons. So the best part of these particles is that they have high precision by virtue of the Bragg's peak, so that the main energy is concentrated at a particular point. They also have high biological potency. So for example, carbon ions, they are 12 times heavier than protons. So they accumulate a lot of energy in the tumor site, and because of which the biological efficiency is more. And the third is the lower oxygen requirement. So generally when we use photon, so oxygen is required to create the free ions, but when we use hadrons, so oxygen requirement is low, so even the hypoxic tumors can be treated in a better way. So once this modality is available with us, then apart from surgery, radiation can become a very good modality to treat chordomas. So what is the general dose and fractionation schedule you use, Dr. Babita? In conventional, if in
We are
conventional.
able to, depending on the margin status and everything, anywhere between 66 to 70 gray we are able to go up to. But we also have to respect the tolerance of the surrounding normal organ structures. And when the margins are positive, dose escalation definitely has to be considered. But going beyond 70 gray does become a challenge.
Yeah, so this case is our case which is depicted. So this patient had a gross disease after surgery, but patient was very weak, wheelchair bound, and although we should have given more than 70 gray, but we couldn't give that, and we gave just 60 gray. But thankfully, patient is still doing fine for last 2 years and still following with us. So if talking about the hadron therapy, as already been discussed, so these are a few schedules. So these carbon ion radiotherapy generally use schedules in the form of hypofractionation, while in proton it is more of a conventional fractionation. And so do you think that this result, which has been shown that surgery and hadron therapy results were equal, so do you think that we can extrapolate or this same thing in the conventional photon therapy also?
I don't think it is possible because of the inherited biological difference between photon and heavy ions. I don't think it is possible.
Yes, so because there is inherent biological problems, so it is very difficult, but thankfully now we have more and more facilities coming up with hadron therapy, so the future looks brighter. So coming to the next abstract regarding the cutaneous melanoma. So as already been discussed, so when we are talking about melanomas, so apart from the size, another big factor that is responsible for local recurrences is the presence of microsatellitosis, macrosatellitosis, and in-transit metastasis. So microsatellitosis means that tumor cells are present microscopically around the main tumor within 2 centimeter. In macrosatellitosis, it is the presence of gross melanoma within 2 centimeter, and in transit means there is presence of either microscopic or macroscopic disease, but more than 2 centimeter away from the main tumor, but less than the nodal basin. So if any of these features is present, then it has an implication that it makes the disease high risk, and that is why once any of these characteristic is present, the staging goes to N1C, and patient directly becomes stage 3 or stage 4. And it has been seen that once these factors are present, then the risk of loco-regional recurrence increases. So what are the other factors that leads to higher local recurrence, Dr. Babita?
That will depend on what are the factors leading to the higher stage of the primary tumor, whether there is microsatellosis which is present or not, whether surgical margins were positive or not, peripheral nerval invasion, then positive nodal disease, any extracapsular extension.
Okay, so in this study, the main focus was on controlling the local recurrence. Yes, Breslow's depth. If it is more than 3 mm or 4 mm, yes. So in this, the main focus was on giving radiation to reduce the local recurrence. Why do you think that it is necessary to control local recurrence rather than distant recurrences?
Firstly, the local recurrence has its own issues and problems. There is a constant weeping wound with ulceration, repeated infections, and the chance for it to, transform into a high-risk disease later on. And then secondly, once the disease is locally controlled, you can reduce the extent of nodal disease in transit recurrence as well as systemic recurrence also, rather than depending only upon the immunotherapy or targeted agents for that. So if you control the local disease as well, I mean, it's a win-win for the patient.
So it was seen in this abstract also that once the local disease is controlled, then the regional and distant recurrences were also low. So it is very important to control the disease where it has arisen. So what are the common dose fractionations that you use routinely for melanomas, for adjuvant radiation?
Nowadays, the focus is more upon using the hypofractionated regimens, given that melanoma is a relatively radio-resistant disease. So 2.5 to 3 gray per sitting. And the common fractionation we generally use is 48 to 50 gray in 20 fractions. Treatment is given daily, 5 days a week, and completed in 4 weeks. There is also another fractionation which I came across, that 30 gray in 5 fractions, though I have not used it, to the high-risk nodal basin, if I'm not wrong. That's where it's used.
And do you think that once these immune checkpoint inhibitors and all these novel therapies are coming, so does it negates the role of radiation, or radiation still holds its place?
Most of these trials were focused on preventing a systemic recurrence or done in patients who already had a systemic disease. And not
Yeah,
really
so in your trial, in your abstract, it was also seen that although 59% of the patients, they received immune checkpoint inhibitors and other novel systemic therapy, but still the value of radiation was there. So when radiation was not given, the local recurrence were very high, and it was local as well as regional recurrences were high. So you have to be very careful that even if these novel therapies are being given, the role of radiation still holds in a big way. Okay, and just to add that most of the time we are worried about the radiotherapy toxicities, but in skin, generally we do not see any grade 3 or 4 toxicities, and in this abstract also no grade 3 or 4 toxicities were seen. While on the other hand, checkmate and keynote trials, they have showed that there were 15% grade 3 plus acute toxicities were there. So it is a sort of misnomer or misconception that we believe that radiation is always toxic and these novel therapies, they are always free of toxicity. So you have to individually look at the trials and the literature rather than assuming this as a basic truth. So coming to the last abstract, which was on the post-operative radiation to the Merkel cell carcinoma. So how many of you have seen Merkel cell carcinoma in your practice?
Sir, I have seen one case till now.
Okay.
In my entire practice, I have seen 2 or 3, maybe 5, 6 years or 10 years, one case may come.
Yeah, it is indeed, it is a very, very rare disease, and
By chance, 2 patients in the same year, last year, 2 patients.
okay. So 2 patient is a big number that way, because if you see, the incidence is only 0.1 per lakh population, that too in the Western thing. So it is more prevalent in Australian and Caucasian males, and the problem is that it happens mostly in very elderly patients. So the treatment is not always the best offerable treatment. The etiology is due to the exposure to the Merkel cell polyoma virus and to the exposure of ultraviolet lights. So in Australia side of the globe, 80% of the tumors are caused by ultraviolet exposure, while in rest of the world, 80% of the disease is caused by the this virus. So this is the differing contrasting etiology across the globe. And my question is to the pathologist, that what are the differential diagnoses that comes that you have to rule out when you see these tumors?
Merkel cell carcinoma is just like a cutaneous neuroendocrine tumor. So we have to exclude all the tumors in which we come across a small blue cell tumor. So the most important differential here is lymphoma. And next is the metastatic small cell neuroendocrine carcinomas. So in lymphomas also, many a times we see a combination of CLL and this Merkel cell. So in those cases, we cannot distinguish based upon the hematoxylin and eosin slides. We have to subject the tumor under further ancillary testing, that is IHC. And the most characteristic feature of this Merkel cell carcinoma is that they will show CK20 paranuclear dot-like positivity. That is the most characteristic and pathognomic feature of Merkel cell carcinoma. Another important point here is that they'll show positivity for neurofilament also, along with the neuroendocrine cell markers positivity. So these are the two main differential, and other rarest differential which we can come across is definitely adnexal carcinomas we can see. Then the basiloid form of squamous cell carcinoma or basal cell carcinomas, those also they can mimic this, but definitely we have to subject the tissue to IHC staining.
Yeah, so this is one very normal question in our vivas, that what are the blue round cell tumors. So Merkel cell is one of them. So another point is that the systemic spread is not uncommon in these cases. So it is very important to consider PET scan in these cases, because approximately 16% of the patients has been seen to be upstaged as compared to a routine CT. And when it comes to the management, surgery is the treatment of choice, and a Mohs technique is generally preferred in spite of routine wide local excision. And radiation, because this tumor is very sensitive to radiation, so radiation holds a very important role in adjuvant therapy. There is a role of sentinel lymph node biopsy also, because it has been seen that in many cases where the clinically disease is not there, on sentinel node biopsy, up to 1/3 of the patients can have a positive node. And if this happens, then further nodal dissection or adjuvant radiation becomes important. Then coming to margins, generally it is recommended to have more than 2 centimeter margin, but if not possible, then at least 1 centimeter margin is required. If 1 centimeter is not achieved, we have to add adjuvant radiation. And then indications are that except T1, N0, M0, all other cases, they require radiation. So Merkel cell carcinoma is one indication where a lot of radiation scope is there. So radiation residents should know this entity as such. These are the generally dose and schedules. So if there is after surgery margins are negative, then 50 to 56 gray is recommended. If there is a microscopic disease present at the margins, 56 to 60 gray, and if there is a gross positive node, then more than 60 gray. 1 minute, just I'll take more just to finish. And This abstract was regarding the use of hypofractionation, and this study proved that either we can use a conventional fractionation or a hypofractionation like 30 to 35 gray in 10 fractions. So the final question was that which of these studies is most likely to change your clinical practice? Any one of you can give a just quick answer.
I think the SACRO trial has a promising approach. It was considered to be a randomized study, but now it is a prospective parallel cohort study. Before this, no other prospective study has been done before this.
I don't think for our practice changing this the last abstract. If in case you get a Merkel cell carcinoma, rather than treating with conventional, it's better to treat with hypo. That's practical thing. But this may change our practice if we get a Merkel cell carcinoma.
But I think all these three abstracts, they were very, very good and very practice changing, although they all were related to very rare pathologies, but they are very good. And just a thought that generally we think that once these novel therapies are coming, so radiation role is going to be less. I think it is not going to happen, because once you are giving systemic therapy, you are increasing the patient's outcomes. So maybe in future they will require more and more radiation. So that way we should be very happy that radiation oncology and medical oncology and surgical oncology should go hand in hand. So with that, I thank you all for and over to the organizers.
Thank you, Dr. Sarmasar. You moderated this session so nicely. And thank you all the panelists to participate in the program. And finally, thanks to Kanika Madam to organize the best of ASTRO in India. Thank you.
We now come to the last topic of the, and may I invite Dr. Mukesh Patikar for the last presentation.
Thank you, Chairperson sir. Thank you, Kanika ma'am. So I think this is the last session for this wonderful meeting. So task here to discuss what after radiation therapy in stage 3 non-small cell lung cancer. So I'll be discussing two landmark trials. One is Pacific and LAURA. So if you look at the stage 3 non-small cell lung cancer, it's not a single disease. It's a heterogeneous disease where we have stage 3A, stage 3B, and stage 3, where we varies from potentially resectable to the unresectable disease. So based on the nowadays we have a lot of options. So those with borderline resectable, we have neoadjuvant immuno chemo based combination. We have neoadjuvant biological driven options. So the outcome definitely has improved as compared to previously when this Pacific was designed. That time we don't have these trials. Now specifically today, I will speak upon those patients are getting radiation therapy. And if you look at the overall survival by the pathologic stage, so if you look at from stage 3A, the median OS is 41.9 months. If you talk of the stage 3C, the median OS drops down to the 11 months only. So that is a drastic reduction in the survival. Only barely certain changes in the nodal disease status in lung cancer. The key consideration in management of stage 3 lung cancer always involve the patient factor and tumor factor. And we also need a multidisciplinary team to plan the treatment option, like we always discuss in our MDT tumor board. Nowadays, there is no debate that concurrent chemoradiation is a preferred approach as compared to sequential approach, except in certain patient with poor performance or the frail patient where we choose sequential approach. But predominantly CT has proven the treatment of choice for stage 3 lung cancer. And these are the stakeholders in the management, like we need radiation oncologist, medical, pulmo, thoracic surgeon, at the time of initial treatment planning, because intent has to be clear at the start of therapy whether this patient is going for the surgery or radiation therapy. And thankfully nowadays we are also having perioperative options like perioperative chemoimmunotherapy. Suppose some patients were planned for the surgical, but unfortunately they couldn't optimize for surgery, then we can do the radiation therapy and we continue as a durvalumab maintenance. So that is the advantage of EGN, that is a perioperative study of durvalumab. So goal of the chemo radiation stage 3 is also like cure. But problem with the stage 3, if you look at the multiple studies, the overall response rate and median OS and median PFS as well as OS, it is varies between 9.8 months for the median PFS to the median OS ranges to the 25 months. So this is we don't expect. We want this patient of stage 3 lung cancer to survive more. So that's why we have different approaches that I'm going to discuss in my subsequent slides. This is the data for consolidation trial. Like people before evolution of the immuno-oncology drug, that time patient used to get docetaxel as a consolidation therapy, the platinum-based consolidation therapy, but none of these the approaches have shown any meaningful impact in PFS as well as OS. Coming to the Pacific trial design, so this was specifically for stage 3 lung cancer, those who are ECOG performance status 0-1, estimated life expectancy of more than 12 weeks, and those patients who have not progressed following the CTRT. And if they have received in induction therapy, if they have received 2 cycles of chemotherapy, they were also allowed in this trial. After gap of 1 to 41 days, the patient were randomized into the durvalumab versus placebo. Durvalumab was 10 mg per kg Q2 weekly for 12 months, and the primary endpoint was PFS and OS. We can see that the duration is like up to 42 days were given for this the planning till the randomization from the starting screening to the randomization, because we know that sometimes patients do get a lot of time to recover from the radiation toxicity, and that is how this trial was designed to incorporate these patients, and so that we can have optimized patient in this trial. So this is the primary endpoint, progression-free survival. The median OS was 16 point, this is a type error, median PFS is 16.9 months as compared to 5.6. I have shown in previous 2 slides that median PFS was ranges between 9 months. Here with the addition of durvalumab, we got the PFS of 16.9 months with this approach. And another thing is, if you look at the 5-year PFS rate is also 33% versus 19%, which is quite significant. Coming to the median OS, the 47.5 month versus 29.1. So there is a almost doubling of the median OS with bare addition of this durvalumab for 1 year in these patients. If you look at the 6-year data, so 42.9% versus 36. There is a delta of almost 9% benefit of adding immuno-oncology drug in this trial. So this is the slide where some patient having EGFR mutation was also there in this trial. So there were 24 patients in durvalumab and 11 patients in placebo. Total 33 patients were there. In this addition of the durvalumab did not get any benefit. So there is no benefit of adding immuno-oncology drug in EGFR mutant cases. The main concern with this molecule when you plan the chemo radiation followed by the durvalumab is the radiation pneumonitis. So if you look at the all grade toxicities, and predominantly grade 3 and 4, it was 30.5 versus 26.1, which is comparable. 15.4 patient required treatment discontinuation in durvalumab as compared to 9.8 in placebo. Coming to the radiation pneumonitis, so grade 3 and 4 toxicity was 3.6% versus 3.0. So numerically there was no difference between radiation pneumonitis or any grade pneumonitis between 2 arms. Grade 5 toxicity was there 1.1%, 2.1% in placebo arm. Adverse event of special interest are also numerically more in the durvalumab arm, but they were mostly manageable. Coming to the safety summary based on the time from radiation, because in this trial, as I said, the time was 1 to 41 days. So this trial, this is the post hoc analysis. Those patients are randomized before 14 days and after 14 days. They try to understand the toxicity, but there was not much difference between toxicity, like grade 3 toxicity are all comparable, whether you start early versus late. And they also look into the outcome also, whether you add early durvalumab or late, so outcome was not different. To conclude Pacific trial, this is the only immuno-oncology drug trial where after concurrent chemo radiation, it has set the standard of care that durvalumab has demonstrated meaningful PFS as well as OS benefit. There was no statistically difference between the radiation pneumonitis in two arms, and EGFR mutant patient did not get any benefit. So this patient shouldn't be considered for immuno-oncology based therapy. So this is the retrospective comparison between sequential and concurrent. We know that sequential has a upper hand, sorry, concurrent has a upper hand over sequential approach. Coming to the LAURA trial, so we know that non-small cell lung cancer specific adenocarcinomas do have EGFR mutation positivity in a tune of 30% in Indian population, around 40% in Southeast population. So this trial was specifically designed to address the question: if someone has a EGFR mutant disease and after concurrent chemoradiation, addition of osimertinib, that was 80 mg daily, and the patient was randomized into 2:1 fashion, and the primary endpoint here was also the PFS, toxicity and discontinuation criteria. And in this trial, the osimertinib was given till progression or till unexpected toxicity. The PFS was the primary endpoint here, and secondary endpoints were OS. So baseline parameters are well balanced. If you look at the EGFR positive, the exon deletion 19 and L50R, they were taken only. So there were no other mutations like composite mutation or some rare mutation were not included. That is the drawback of this randomization, but we do get this standard mutation most of the time. So coming to the PFS, so we can see that this the Kaplan-Meier curve which shows the osimertinib addition after concurrent chemoradiation has shown drastic improvement in the PFS. That is, median PFS was 39.1 month with hazard ratio of 0.16. Coming to the patient, like there is a early separation of the curve with hazard ratio 0.19. On all the subgroup, whether you can see on the left side, all the subgroup, whether age, sex, race, EGFR mutation status, whether they are from Chinese cohort or non-Chinese cohort, whether they are sequential or concurrent, every patient or every subgroup has shown benefit of adding osimertinib. So this is the waterfall plot which shows there is a significant overall response rate 57% versus 33%, and median duration of the response is 36 versus 6.5 months. So there is a huge difference between the outcomes as well as duration of the response. Another benefit of adding osimertinib, it is a brain protection. There were very few failure in the brain as compared to placebo. So there were 39% patient had failed in the brain. They are not given the osimertinib in the as a maintenance setting. So this is interim analysis overall survival in 81% blinded independent central review confirmed progression. They were crossed the osimertinib. So we can see that the OS is not mature as of now. The 36-month OS rate was 86% versus 74%, and there is a significant crossover also. That's why the whatever OS we are going to get, that may not be meaningful in the future also. Coming to the toxicity, as we know that osimertinib has a propensity to cause ILD. So in this trial, so the area of concern will be the toxicity pertinent to the radiation pneumonitis. Here also grade 3 toxicity is also comparable, and that it was not that much high. So osimertinib had leads to the significant longer duration treatment exposure, and adverse event is generally manageable as we use this molecule more often in the metastatic setting also. So in this trial, this is the only trial they have taken radiation pneumonitis as a separate toxicity. We can see that 48% patient in osimertinib had the radiation pneumonitis as compared to 38 in placebo. So, but these all were grade 1 and 2. Grade 4 were not that much common, and they were manageable with the steroids. Another, they have taken the most important thing is ILD. So they have taken ILD as a separate entity in this trial. The time of onset of radiation pneumonitis was similar between both arms, so there is no additional risk of having radiation pneumonitis or toxicity after addition of osimertinib. So as of that it has approved in first line setting, new Adura trial, we have this LAURA trial. So osimertinib has a different approval in the lung cancer profile. Durvalumab is approved in non-small cell in perioperative setting, as well as it is also approved in the non-small cell lung cancer. To conclude my session, the EGFR mutation testing is critical in phase 3 non-small cell lung cancer. Until recently, there was no approved therapy, but with the onset of LAURA, we have osimertinib is the standard of care for these patients. The median PFS is 39.1 month as compared to 5.6 in placebo. OS data is still going to the mature, but trend shows it might come positive. Safety profile of the osimertinib post-radiation therapy was expected, and it is well manageable. So with this, like to conclude. Thank you for patient hearing.
Thank you, Dr. Lopez, for giving the transparent timelines for the unresectable stage 3 lung cancer. And it is highlight to present this the latest treatment modalities for lung cancer, including best of best. And along with this, finally congratulate our program director, Kanika Sharma Madam, director and clinical lead radiation oncology, Narayana Hospital.
Thank you so much, sir. So I hope all of you enjoyed the lunch and chocolate mousse. So, ladies and gentlemen, as we arrive at the conclusion of this remarkable scientific conference, and it is now time to express our sincere gratitude to everyone who has contributed to the success of Best of ASTRO India 2025. And to deliver the vote of thanks, I would like to invite, and it is my privilege to invite Dr. Kanika Sharma ma'am on stage. Please welcome.
I think there is one formality for which there are few youngsters waiting eagerly. They were the first entrants in this hall in the morning, and I don't want them to be the last ones to leave. So first, we would want to announce the results of the quiz. So what was intended to be an individual excellence turned out to be a collective effort, and we had teams. And I think the quality of questions posed to you were really exam level, and you all really did well, and I'm really happy to announce the winners. The third position was jointly sought by Dr. Vaibhav Saini, Dr. Harsha Vyas, and Dr. Shubham Dhukuria. Vaibhav is from Medanta, Harsh is from RGCI, and Dr. Shubham is from AIMS. Please come and collect your prize. I invite Dr. Vikas and Dr. Kuldeep to please join us on stage to, give prizes to our budding young oncologists. So cash you will divide amongst yourselves later. The kind is being given to you right away. Third prize. Huh. So this is a good example of collaboration. All three of them coming from different institutes, competing together in unison. मैं भी आ जाती हूँ. So Dr. Pooja and Dr. Divya, please join us along with Dr. Kuldeep and Dr. Vikas on stage. Yes. So for the second prize, I did expect that because it was a collaboration between a medical and radiation oncology group. So the second prize goes to Dr. Taruni, Dr. Ritvik, Dr. Shubhansha, and Dr. Deepti. They are all from Dharamshila Narayana Super Specialty Hospital. Any guesses for first? इनको अपनी ये वाली बॉटल. So I'll just remind you, first prize was 30,000, second prize was 20,000, and third prize was 10,000. So I've forgotten one of my quiz masters. Dr. Gopika, please join us on stage when we announce the first prize. Any guesses? Kuch to bolo. So the first prize is jointly received by Dr. Nehal from RNR, Dr. Sushant from AIMS, and Dr. Adarsh again from RNR. Please, a big round of applause for these three. तुम्हारी कोलैबोरेशन तो अभी टूट गई तीसरा कहाँ गया प्लीज please just applaud the young budding oncologist. I think they do deserve a big round of applause. So gratitude, I think, is the biggest asset a human has in form of humility, and with a great humble heart, I express my gratitude towards each one of you. Last 2 days of engagements, to my surprise, were very, very vibrant. I started with a trepidation that how are we going to take this Herculean task at hand? When you conduct a conference, there are challenges. There are challenges of logistics. There are challenges of finances. There are challenges of getting the best in line to present these papers. Because the papers of ASTRO are not simple. As you all might have seen in your own papers, these papers were complex, did not have full text to support your understanding. Not much was available about them on the internet as well. So I think a huge round of applause for each one of you who presented the paper so beautifully. I think जो मंथन आप लोगों ने 2 दिन में किया है, that was amazing. अगर एस्ट्रो वाले इन पेपर्स को खुद भी आपके नजरिए से पढ़ जाएंगे ना, I think it will be amazing. It will be really amazing to see the Indian perspective or the Indian manthan of Best of Astro. So I really am really indebted to our entire faculty who have put in their efforts to make this program what it looked like. I was grateful to all our patrons, our senior mentors and institutional leaders, not to, forget mentioning our key leadership, Dr. Devi Shetty and Dr. Rupert and Dr. Kohli, who have always backed my overzealous, adventures. They always back me for what I, take in hand, and that is how Narayana is. It always supports academic, events wholeheartedly, and I'm really indebted to them for this. I have a great sense of gratitude to Aarti Sareen ma'am, who on a single request agreed to be part of the event, and not just be part of the event, to say such beautiful encouraging words yesterday, which was a sort of a manthan of her own career journey. As ma'am is going to complete her tenure with the armed forces next month, her learnings expressed in those 10 minutes were something I would take back home with a lot of understanding. I would also want to thank the platform of ASTRO that they enabled this event here. There were glitches, but ultimately, we were able to deliver it in timelines. We could not have pushed this meeting beyond August. We just finished it at the appropriate timeline. I would want to thank the entire organizing team from Dharamshila, all my colleagues who were working tirelessly, Dr. Divya, Dr. Gopika, Dr. Jhanja, Dr. Pooja, not to forget Ritvik and Deepthi, who were standing here throughout the last 2 days to present it. Shubhansha, who may not have been seen here, but the amount of work she has put in. 2 मिनट में मुझे ये ढूंढ के लाके दे, 2 मुझे सबके फोटो लाके दे. She was the one who was collecting everything left, right and center, despite being the exam going PG. I would want to express my gratitude to the entire MedEvent team. I think venturing with you gave me the confidence that yes, I will be able to make this conference be the way I dreamt of it. I think मेरी wish list को हरीश ने पूरा किया जो मुझे चाहिए था मेरे को ऐसी बुक का रेप्लिका चाहिए मुझे ऐसी फोटो चाहिए आई थिंक ही वाज द मास्टर मैजिशियन जिसने मेरे सपनों को आकार दिया इस कॉन्फ्रेंस में आई रियली एक्सप्रेस माय ग्रैटिट्यूड फ्रॉम द डेप्थ ऑफ माय हार्ट not to forget our academic partners I think without your support my dreams his conception of realizing those dreams could not have materialized so with my great express gratitude I would want to name each one of them I would thank not in order of any uh, contribution, all of them, Roche, Sun, AZ, RES, Servier, Abbott, Electa, Across, UV Can Cure, Healthcare Limited, Medcure Pharma, Medeleaf, Visionati, Shinva, Zuvius, Verin and Siemens, POCL, CQ Medical, PTW, Cipla, Eli Lilly, Celigen, J&J, Fibrega, Zavitor, and Dukes. I think you all pitched out the best support we could have asked for, and I think the hospitality which we were able to deliver was courtesy your academic support. So again, I will not take much time. I thank each one of you, and I hope the learnings which we had in the last 2 days can transform some amount of our practice coming Monday. Thank you all, and have a great day.
I guess Dr. Kanika deserves an standing ovation for this magnificent job.
Congratulations, Kanika madam. Aiming to make the best of Astro grade 7.
Best of Astro, best नहीं एक ग्रुप फोटो हो जाए अच्छा आगे हो जाए फटाफट all of you everyone in the hall आगे पीछे खड़े हो गए स्टेज बहुत बड़ा है बहुत बड़ा this photograph is going to go to Astro as a proof that we had even right in the end please come my work doesn't finish I have to write full report with photographic evidence आगे pictures Thank you so much.